could do is, as agreed, we will request Dr. Chabra to welcome and start the sessions. And
Yeah,
then,
Raghav, we are live, I
We are
think.
live, sir.
Sir, we are live, sir.
we're live,
Good
yeah.
evening all.
May I request Dr. Chabra to start the session?
So, good afternoon, everyone here in India, and good morning to friends in Germany. I think today is a historic day. We initiate the collaboration with DWG officially today with this joint session, even though individually a lot of us have been collaborating together with each other. I just have a brief presentation to make. So, meanwhile, welcoming all our friends from Germany and, of course, our colleagues here who are in India as well. So, I'll be talking on opportunities and challenges for ASSI and DWG collaboration. For our friends from Germany, a brief history about Association of Spine Surgeons of India. It was 18 December 1985 when Dr. V.T. Ingelhalliker spearheaded the need for Association of Spine Surgeons of India. The first scientific meeting of ASSI was held from 1st to 3rd May 1986, Mumbai, as ASSICON 1. The main objectives of ASSI are listed below. And in fact, we will use this to discuss on how we could collaborate further. Of course, the German Spine Society needs no introduction. Along with its presidents, we have its officials here. So welcome to all of them. And we look forward to a long-term collaboration. Its activities, as we could see, are focused on exchange of knowledge, connect and collaborate with other countries to come together and work against the spine-related ailments and adopt the cutting-edge technology. So the second activity is the one they are pursuing here. Let's discuss what is the need for ASSI and DWG collaboration. In fact, I would ask, do Indo-German relations need any introduction? There are 98 German colleges in India. There are a lot of collaborative efforts going on. There's an Indo-German Chamber of Commerce. We have an Indo-German Young Leaders Forum. We have an Indo-German Training Center and an Indo-German school. And our leaders frequently meet each other and collaborate with each other. And that happens not only within the leaders, but also amongst the citizens as well. We have an Indo-German Orthopaedic Foundation and the Indo-German Cooperation in Health Research is going well with the Department of Biotechnology, Government of India, and the Federal Ministry of Education and Research, Federal Republic of Germany, agreeing for cooperative programs in biotechnology. Similarly, we have an Indo-German Endo and Laparoscopic Society, which is there. We have been working with our friends in Germany individually, whether it's Patrick, who first introduced me to all of my friends in Germany, to the stalwarts, other stalwarts in Germany. We have been working, but this is the first time that our societies could come together. So India is one of Germany's closest partners when it comes to jointly funding major research facilities. Both countries are committed to holistic research for greater impacts and applied solutions. And when scientific minds come together, there's always a scope for research. Collaboration always helps in the sharing of knowledge. Together we think more than individual. So since we think alike, let's work together, and that's a normal going. So we could discuss our various collaborative efforts under the various aims and objectives of ASSI. I'm sure they are the same for DWG. When it comes to scientific activities, we could have combined sessions in conferences like these ones. We could, in fact, also have joint conferences if we evolve to that stage. We have an Indian Spine Journal, and we could seek contributions from top scholars within your society. We could expand the reviewer database to DWG. We could have seek your help in ASSI Connect app, which we are using for case-based discussions, and webinars for fellows, cross-country fellow webinars and case presentations could take place. So when it comes to education, training, and capacity building, ASSI plays a multitude role in enhancing knowledge and education of budding spine surgeons. So we have a 2-year comprehensive spine fellowship program. We have ASSI short-term fellowship program. And in fact, many of my fellows here periodically go to colleagues in Germany, whether it's Patrick or Franke or anybody, and we could develop that officially between the two societies, an exchange program within the fellowship course that we all run. We also have an online master series webinars which take place, and pro series webinars which take place for the general orthopedic surgeon. And we could collaborate to have joint webinars in this regard. When it comes to networking and collaboration, networking amongst executive committees and members could take place, such that the official handshake which takes place at the top reaches people, also the normal members as well. And we could come out with joint newsletters. When it comes to research, ASSI has a multicentric research project. We have around 6 multicentric research projects going each year. And we could also collaborate such that we could expand the multicentric research projects across the continents between our two countries. We could look at various other advanced technologies like epidural stimulation, brain-machine interface, biomechanics laboratory, and skill development centers. And we could also collaborate in the field of basic sciences and epidemiological research. In fact, we have various research awards, and we could even think of joint research awards which would make it more prestigious. When it comes to partnering and collaboration, we are doing just that right now. There's a need to strengthen and consolidate it further. And of course, in the field of advocacy, we observe SCI Day along with also our colleague, our sister organizations in Germany, but we could strengthen that between our societies. We yesterday launched the Injury Prevention Community Awareness Program. I'm sure we can work together in this regard, and we can try to lobby to reduce unethical practices like experimental stem cell therapies being offered at a price to people and trying to adopt it into clinical practice. So what we will achieve with this collaboration: growth and enhancement of knowledge amongst the surgeons, increased opportunities of research, develop innovative ideas, teamwork amongst young surgeons, technology exchange, and things like virtual reality could be used. How we could do it? As some of the salient features that we discussed would be combined annual meetings, virtual meetings, CMEs, fellowship exchange programs, multicentric trials, and exchange of knowledge programs at professor level. A small step in the right direction is often what is needed to embark on a fulfilling journey. We need to stay in closer touch and brainstorm. Use it as an opportunity to learn to build a more positive and inclusive future. Many single drops make a sea. Let's come together and begin the journey to fight the spinal ailments, because we have got each other's back. Dankeschön.
Thank you, Dr. Chabra, and that was very nice. You have actually included every spectra that we can cooperate with the German societies. Now, may I request Frank? Frank, Canziora, I think I got the surname correct, on what they think about the projects of the German Spine Society and their collaboration with the Association of Spine Surgeons of India and how they can take it forward. Over to Frank.
So first of all, let me say thank you very much. It's a great honor and a pleasure for the German Spine Society to be here. On behalf of the German Spine Society, I would like to say thank you very much for inviting us to your prestigious meeting. It is very important for us, which you can see due to the fact that the whole presidential line of the German Spine Society is part of this day today. Ulf Liljenquist as the current president, Peter Weikoczi as the vice president, and finally Markus Arendt as the president-elect. They are all here together with you, and we would like to elaborate what type of cooperation we can have in the future. So thank you very much for having us today.
Thank you.
Of that prestigious conference. I'm the past president of the German Spine Society, der Deutsche Wirbelsäulengesellschaft. It's a great pleasure to be here today and to talk about a future cooperation. I think it's absolutely mandatory before we talk about cooperation, we need to talk about who we are. And so I would like to present you some news about the German Spine Society. In fact, the German Spine Society is a very young society. It was founded in 2005, but it has two very prestigious predecessor organizations. One is the German Society for Spinal Research, which was founded in 1958, and the other one is the German Society for Spinal Surgery, which was founded in 1987. And both of these societies merged in 2005 and founded the German Spine Society. The German Spine Society has currently 2,300 members coming from 26 different countries. Most of them are, of course, from the German-speaking ones. We are balanced societies between orthopedic surgeons on the one side and neurosurgeons on the other side, and we are predominantly a male society. The structure of the German Spine Society is, first of all, it is a scientific organization with the goal to improve the quality of spine care. But we have other organizations which are associated with the German Spine Society. That is the German Spine Foundation, which is a charity organization which supports science, spinal science. We have a business unit, which is the Academy of the German Spine Society. And we have a political arm, which is the Professional Spine Association, which we run together with our orthopedic and neuro colleagues. The main activities of the German Spine Society include the German Spine Congress, which is an annual congress where typically more than 4,000 participants are on the spot. We also run a program for spinal education events. We had 33 of these spinal education events in 2019. We are offering a publication, which is the Wirbelsäule, with 4 issues a year. And we're doing something for our patients. We provide a second opinion portal and patient information material. Our major project at the moment is to develop a state-certified spine surgeon curriculum together with our orthopedic and neurosurgical friends. In fact, as already mentioned, the main goal of the society is quality assurance to improve spine care. And we are running a program with 3 different topics. First, an individual certification program, an institutional certification program, and finally, a benchmarking via the German Spine Registry. And I would like to talk a little bit more in detail about these 3 different projects. First of all, the individual quality assurance, which is a certification project which was started in 2011 with a surgical arm and which was added to a non-surgical arm in 2018. So far, more than 1,800 surgeons have been certified with that individual quality assurance certificate, where you can have either a basic, master, or excellent certificate. For the basic certificate, you have to be part of some basic surgical courses for including the degenerative diseases, deformity, fractures, but also intradural pathologies. For a master certificate, you need to have advanced courses which deal with advanced surgical techniques and also with revision and complication management. And for the conservative, non-surgical courses, you need to know a lot of things about manual medicine, physiotherapy, pain treatment, or injection therapy. So all the different courses which we are running have a standardized structure. So they are typical 2-day courses, as depicted here on the right side. They have a standardized content with a defined curriculum and with master slides for where are theoretical and practical parts included. We offer cadaver labs during the courses, and we perform a continuous evaluation of the courses to improve them over time. And we also started with having e-learning modules. So if you want to get a certificate by the German Spine Society, a basic certificate, you have to be a board certified trauma or orthopedic or neurosurgeon, and you need successfully pass the 6 basic courses which we are offering. If you want to have a master certificate, you need to have the basic certificate, of course, and you also have to pass the 2 advanced courses. Further, you have to be a minimum of 3 years in practice, and you have to do a certified number of spinal surgeries. Finally, if you want to get an excellent certificate, you need to be 5 years in a leading position of a spine department. Of course, you have to have the basic and the master certificate, and you have to have an adequate scientific output, and you have to be voted for that excellent certificate anonymously by the 12 members of the commission. The second type of our quality insurance program is the institutional quality assurance programs we put in place 2015. So far, already 82 centers in Germany have been certified by a 3-level certification system, which is a level 3, a spinal institution, a level 2, a special spine center, or a level 1, a spine center of maximum care. To become such a certified spine center, you have to apply for it, and you have to take care about your different pathologies, degenerative disease, tumor, inflammatory injuries, or deformities. Depending on the applied certificate level which you want to get, you have to meet the requirements of either 1, 2, or 4 of these pathology groups. And you have to fulfill a certain amount of characteristics with regards to equipment, diagnostic, therapeutic, or your interdisciplinary facilities. Overall, there are 142 items which you might fulfill, which includes quality management, a certain amount of staff members, on-call duty for spinal pathologies or outpatient clinics, but also a certain frequency of surgery per year. For example, if you want to be certified for a degenerative pathology as a spine institution, you need to perform a minimum of 100 surgeries. If you want to become a special spine center, you need to have 200. And if you want to have a spine center of maximum care certificate, you need to perform even 400 spinal surgeries. So how does it work? In fact, you have to apply for such a certificate, and you apply not to the German Spine Society. You apply to a controlled certification company, which is accredited by the State and Health Ministry in Germany. And then you have to fill up your form, when you will have an audit, and if the audit is good, when you will get your certification. And the only thing the DWG does is it will double check the recommendation of the certification company, and then you get your certificate, which is typically valid for 4 years. So why should you be certified? Of course, the certification sets your institution apart as a recognized spine center, not only in the eyes of the patient, but also in the eyes of your colleague, the employers, and the insurances. It ensures a certain standard due to the external independent quality control, but it also gives you the opportunity to establish your own internal quality control to optimize your structure of your spine center. Finally, the third level on the third part of the program is the benchmarking due to the DWG registry. It was established in 2013 based on the spine tango of Eurospine. It currently includes more than 180,000 data sets, and 106 centers in the German-speaking countries are contributing. It is not only a benchmarking tool, it is also a scientific tool because it gives you the option to document all the pathologies, surgeries, regardless if it's conservatively, and also the implants on the one side. But it allows you the evaluation of your patient with follow-up examinations like the COMI, the ODI, the ECO5D, or the SRS-22. As you can see, the number in the DWG registry is continuously growing over time, and what it gives you is depicted here on the right side. It shows your own cases in relation to the overall benchmarking in the registry. So, in summary, the German Spine Society has, as you have seen, developed a lot of activities. Quality insurance is one of the major focus of the German Spine Society, and we are really willing and able to cooperate with the Association for Spinal Surgeons in India in many, many ways, and it would be our pleasure to work together in the future. So, thank you very much for having us today.
Thank you very much. That's a very interesting system that you have developed in Germany, and we hope we will also emulate and get on to similar standards so that our quality of care to our patients will be on par with the best in the world in the vast country like India. And we're also working on, as President Chabra has said, we were working on getting centers developed into a proper spine education centers and incubating centers where the surgeons from across India go there and train and teach the local surgeons. That is what we are doing, and hopefully we'll plan to do a bit more. Can you tell us just one or two areas where we can think of cooperating between India and Germany at the moment?
I think there are a lot of things which you can profit from each other. I think it is absolutely mandatory to work together to improve our educational events, for example. You know, for example, something like tuberculosis. Tuberculosis is extremely rare, and nobody in Germany has an idea about that. You're familiar with that. So you can teach us, we can teach you. I think that would be a great opportunity to work together. It's also, if you look at the scientific component, which was already mentioned, I think if we combine our knowledge and our research options, I think that would be very beneficial for both societies.
Lovely. We'll certainly take it forward from there. May I request now Dr. Rajashekaran to speak on subclinical infection, a cause for lumbar disc degeneration.
Good evening. I would like to start off by thanking ASSI for this opportunity and also wishing our friends from Germany and also all the participating societies a very happy, healthy, and safe 2021. Now, the topic of my talk is on the role of subclinical infection in disc degenerative disease. Now, we all know that disc degeneration is inevitable, but the etiopathogenesis is still a controversy. And the big question mark is on the role of subclinical infection. Now, it all started with this paper in 2001, where Alistair actually demonstrated the presence of bacteria in disc samples from herniation. And this factor got augmented by the paper from Albert, where he showed good results following antibiotic therapy in a certain group of low back pain patients. But this idea is still a raging controversy. And most of the non-believers actually strongly believe that the bacteria that is demonstrated in these studies is actually a contamination. But however, there is a strong proof that bacteria can be an initiator and propagator of many diseases. Like, for example, we know H. pylori is a cause for peptic disease. We know that there is a strong association between P. acnes and adhesive capsulitis. And in rheumatoid arthritis, there is a whole amount of organisms which have been proven to initiate and propagate the inflammation. And in many cases of aseptic loosening, which were previously thought to be cement-related, are now known to be infection. In 2017, we also presented this paper on the Easels Prize-winning paper on the role of possibility of subclinical infection being a cause for disc disease. We not only demonstrated bacterial proteins in normal discs, but to a high level in discs with disc herniations and disc degeneration. But there is still a lot of controversy, and this controversy is between infection and contamination. Now, if we have to settle this, there are many missing links that have to be addressed. And I would like to present our work on this subject. First of all, we need to document the presence of bacteria in the discs. We need to decide whether it is contamination or actually infection by showing viability of these bacteria and that there is an infective process going on, and this is the cause for disc disease. So it all starts with the primary question: does normal disc have bacteria? Now, most of us strongly believe that the discs are highly sterile in health because they are the largest avascular structures in our body. But our understanding of infection etiology has always depended on our ability to identify organisms. So far as we restrict to culture-sensitive methodology, we will miss identifying a whole lot of microorganisms which cannot be cultured easily. And so metagenomics and next genome sequencing is the future. And this allows us to identify all the bacteria by DNA sequencing. And this is what we employed. And we looked at 8 MRI normal controlled discs, 8 degenerated discs, and 8 herniated discs, which were all harvested under sterile precautions and immediately snap frozen. What we found was that there was a rich bacterial presence in all 3 groups, and even in the normal discs, which showed that even in the health, normal lumbar disc has a good presence of bacteria. But the microbiome of normal discs differed from that of the degenerated and herniated discs, both in biodiversity and abundance. While normal discs had a wide spectrum of bacteria and relatively very low abundance of established pathogens, degenerate discs had a reduction in the spectrum, but they had a relative increase in the number of pathogens. Beneficial bacteria like Bacillus coagulans and Bacillus clausii, they were all present only in organ donor discs. And Lactobacillus mucosae and Sphingomonas were present in abundance only in the organ donor discs. Whereas bacteria with pathogenic potential like Pseudomonas fragile, Privatola, and Streptococcus and Privatola pallens were all present only in the degenerated and herniated discs. And this is what we reported last year in the European Spine Journal, that human intervertebral discs harbor a unique microbiome, and dysbiosis determines health and disease. Now, what is meant by dysbiosis? Dysbiosis is the balance in the normal between the type and quantity of bacteria which is present in a tissue, and an alteration of the normal ratio can actually determine and cause a disease. So we have symbiotic bacteria, commensals, and pathogens. And when they are in balance, it is the state of health. And an imbalance between the type of organism present can actually cause a dysbiosis, which can result in a problem. Now, in the last 2019 NAS Outstanding Paper Award, we established that there is an inflammaging, a constant low level of inflammation occurring in diseased discs. And we also showed that this could be because of a bacterial-induced inflammation. Now, if you looked at normal discs in healthy young discs, most of the proteins that were present were structural proteins and metabolic proteins, and there was no complement cascade proteins or degradative proteins. Absence of inflammatory markers and degeneration was in the young and normal discs. Contrast to this, in degenerated discs, we found an upregulation of complements and degradation proteins and inadequate complement inhibitors. which actually showed that this inflammation which is present in the degeneration and herniation could be as a result of bacteria. In the third part of our study, there was further proof because we established the presence of host defense response proteins. Now we know that whenever there is a pathogen exposed to the tissue, the human body mounts up a defense. And the proof of this can be found from the presence of human defense response proteins. Now, you could see here, we were able to establish a whole number of host defense response proteins. For example, we found that prolactin-induced protein, it was 9 times higher than what was present in the normal disc. And we also know that these act as the first line of defense against invading pathogens. Similarly, complement component and heat tolerant, there was a 3.6-fold variation. And we know that these are all a part of membrane attack complex on bacterial cell membranes, in which beta subunit helps in complement-mediated bacterial clean. Proof of all presence of these bacteria actually stand as a proof for infective pathway and activity going on. For example, defensin was also uniquely present only in disc degeneration and in herniation. And defensin is a family of antimicrobial and cytotoxic peptides found in the microbicidal granules of neutrophils that helps in phagocyte-mediated host defense. And the presence of this and another 42 host defense response proteins in diseased discs actually showed proof of inflammation, and an inflammation that is initiated and progressive because probably of bacteria and infection. So we came up with a unified pathway. Most of us used to think that the traditional hypothesis that degeneration is mechanically induced, but we do think that this is an important factor, and this can actually be the initiator of a cascade of events. Mechanical disruption can either lead to end plate breaks or annular tears, both of which lead to neovascularization of the disc. There is ample proof for this in literature. Neovascularization then carries the bacterial, and this can lead to bacterial inoculation, and that can lead to a low-grade infection. And this low-grade infection can lead to a constant source of inflammation, and this inflammatory cascade and perpetuation of inflammation can lead to disc degeneration and herniation. Now, there can be a genetic susceptibility for this, and that is the way that genetics also will play an important part in disc degeneration. So our study over a period of time has shown proof that bacteria is present in even health, and they are present in a difference of ratio with dysbiosis in the degenerated disc. It is not a contamination because we have proved that the virulence, that they are multiplying, they are viable, and actually they are a cause for infection because we have also proved that there is dysbiosis and there is inflammation and the presence of host defense response proteins, which actually shows an infective process. We know that human cells versus bacteria in the body, we are outnumbered by the bacteria by a ratio of 10:1. Many of the bacteria which we thought were commensals, now we know that they can be a source of many kinds of disease. Now, it was Chanakya who actually said to underestimate the enemy and to mistake an enemy as a friend are the two mistakes that any king must avoid. So I think in the recent few years, we have now come to the state, mainly also because of the fact and the ability of us to identify all the bacteria that are present in the tissues by next genome sequencing, that many of these bacteria are the source of a constant inflammation in the tissues. And this is also probably the cause, or at least one of the causes for disc degeneration. Now, this will be very important, because if the role of bacteria as it is being established in health and disease, and if we can prove that there is a role for infection in disc degeneration, it will dramatically change the way we look at this pathology, and it will also offer and open up new possibilities for treatment of these. As Louis Pasteur said, we are all on the verge of mysteries, and the veil is getting thinner and thinner, and hope that the truth of what is the real pathology behind disc degeneration will be in our hand very soon. So thank you very much again for this opportunity, and my greetings to all of you.
Thank you, Raja. I think we'll have some questions, if any, from our panelists as well as from the delegates who are attending the meeting. Before that, may I ask Raja, as you rightly said, there are believers and non-believers, and only time will tell what you're saying. I'm not very inclined to... Sorry?
You're a non-believer.
At the moment, I'm a non-believer. Because I understand that, yes, in the cervical spine and in the lumbar spine, there is more degeneration. So, yes, there is a chance that because of the mechanical problems that you have mentioned, the bacteria can go there and multiply. How about an isolated thoracic disc? Right? We see a young disc coming out, a virgin disc coming out and then causing pressure. So, there is not much mechanical instability there. There's not much tear there, but then still it comes out. And the same thing happens in sometimes we see in children. Children in the age group between 13 to 15 or 16, sometimes coming to us with big discs, though rare, they come. And we don't see much degeneration of the end plates there, but we see a nice, soft disc coming out. So does your theory apply in those situations as well?
Yeah, Rahul, first of all, thank you very much for this question. Now, if we say that subclinical infection is the only cause for disc degeneration, that would be very, very wrong. Now, certainly there is a huge mechanical element to disc degeneration, but also mechanical effect also cannot explain everything. For example, you see a degeneration at L4-5 and L2-3, and you get a L3-4 disc, which is absolutely normal. You get various patterns of degeneration with completely normal discs and discs which are completely degenerated. Which gene would affect only one disc in the body, or what is the mechanical effect that would affect L2-3 but not L3-4? So it's a very big interrelated issue. And as I told you in one of the slides, so now we think that it is all very, very interrelated. Now, we are now able to identify many of these bacteria also as coming from the gut. So what we feel is that there are small end plate breaks and also annular ruptures, and that is mechanically originated. Now, once this happens, neovascularization takes place, which takes the bacteria inside. And these bacteria are not Staphylococcus or Pseudomonas or Klebsiella. They are fastidious organisms which cannot be cultured. They can be only identified by next genome sequencing. And they actually are very, very slow growing organisms, and they produce enzymes which can disrupt the collagen, make the disc slightly weaker, which again makes it more susceptible for mechanical effects. So it is not just subclinical infection. It's a combination of what's happening between the mechanics, and also we are saying that subclinical infection can be one of the causes. What we would like to emphasize from our research is move away from the much believed thought process that in health, the human discs are completely sterile. It is not. It is just full of bacteria. But those bacteria are completely different from the ones in which we see in the disc degeneration. This is called dysbiosis. And dysbiosis has been proved to be a problem in atherosclerosis, in irritable bowel syndrome, And subclinical infection has been proved in many, many diseases like rheumatoid arthritis or even Parkinsonism now, and many of the neurodegenerative disorders. So slowly, one by one, many of these diseases are going to be proved at least to have an effect of bacterial infection. So we are not saying bacterial infection is the end of it all or the beginning of it all, but there is an element in which the subclinical infection produces inflammaging, and this inflammaging weakens the matrix of the disc.
Now, if I can take it further, this question. Now, how much the number of discs that you operate or you see in the clinical practice, how many of these disc degenerations are bulges or sequestrations are due to infection? Just to put a percentage, and how many are due to degeneration and other genetic issues? In your
all of them are degenerated, right, and all of them have bacteria. None of them will grow a bacteria if you culture, because the organisms you are talking about are not culturable. So if you tell me, okay, Raja, I sent 10 of my herniated samples and none of them grew any bacteria, I'm sure you're right, because they are not culturable. That is the most important problem. These bacteria are completely different from the bacteria which we know as pathogens. And they can be only identified by next genome sequencing. For example, Raghav, we have 1 trillion human cells, but we have 13 trillion bacteria in the body. 65% of these bacteria have still not been coded. So our genome is overridden by the bacterial genome, and many, many diseases are now being associated with this. So let me make it very clear. I'm not saying that bacterial infection is the only cause. I'm just saying that we need to keep sure, have the knowledge that human discs are loaded with bacteria in health and also in disease, and there is a dysbiosis between them. And we have been able to prove by human defense reaction proteins that there is a mild element of infective process and host response going on. So we are not just saying that is it. We are saying let's think of this possibility also.
Raja, there is a question from a delegate. Similar to the pathogenesis of gastric ulcers and H. pylori, did you find a single organism that was implicated and can be targeted with antibiotic therapy? That's a question.
Yeah. So P. agnes is the one that is being highly implicated. P. agnes, I mean, there are loads of papers which have identified P. agnes in the disc, and people are very strong about it. But in our study, we also found P. agnes. But in addition to P. agnes, we have found other bacteria also. Now, that is the next question to find out. Is it just one of these bacteria, or any of these bacteria can just start a small inflammatory trigger? Now, it is not infecting the whole disc. It is just that these bacteria can trigger off an inflammation. And then the inflammation cascade starts. And once this cascade starts, then there are numerous biological pathways which can lead to degeneration. I mean, it's a long story, so I'm just putting it in short. But this is one of the interesting things that is coming up. There is a mounting evidence for this. But as you said, I mean, when you first think about it, it looks impossible and it's very difficult to believe.
Yeah, Dr. Raghav, we need to move forward, but allow me to ask one quick question to Dr. Frank. The certification that you gave, so I believe it is approved by the regulatory authorities in Germany?
In fact, not really. That's currently exactly the thing which we are working on. So the problem is that we do not have a spine surgeon in Germany at the moment. We have either neurosurgeons or ortho and trauma surgeons which do spine surgery, but we do not have an official spine surgeon. And we are currently working on that topic. So do you have an official spine surgeon in India?
Yeah, we have a National Board of Examinations, which runs a fellowship program, 2-year fellowship program. It's not by the National Medical, it's now combined under the National Medical Commission now. But we have around 8 centers which are running fellowship programs. But ASSI also has its own fellowship. So I was only exploring joint fellowship programs or joint certification or something like that, if we can explore on that, maybe we could carry that further.
Would be very interesting. Thank you very much.
Thank you.
Thank you. We will move on to the next speaker. I'm sorry, my pronunciation of the German names is not very good, but Professor Lindquist, if I'm right, on indication, techniques, and limitations of en-bloc resection of primary bone tumors of the thoracic spine.
Ladies and gentlemen, it's a great honor for me to present my experience and the indications, limitation of en-bloc resection on the thoracic spine in primary malignant tumors. The indications for en-bloc resection are locally aggressive tumors like the giant cell tumor, the aggressive osteoblastoma, and mono and oligometastasized patients with breast, kidney, or thyroid cancer, and of course the primary malignant tumors like sarcoma and chordoma. However, these are very rare pathologies. The rationale behind that is that we know that we have increased survival rates if we do an external lesion resection of sarcoma, and we have a reduced local recurrence rate in aggressive osteoblastoma, giant cell tumors, or solitary late metastases. The principle of en-bloc spondylectomy is an en-bloc resection with anything appropriate margins, which means an extra lesion resection, and the tumor should be covered by a layer of healthy tissue, which means you have to achieve free margins. And the way to do that is that you have to create a tumor-free corridor to release the dural sac with its content. And in most cases, you will find a tumor-free corridor like here, which you can resect and then deliberate the dural sac and do an en-bloc resection of the whole vertebral body. Just a few examples. So here, even if both pedicles are affected, you can stay outside the tumor and do an external resection and create this corridor to release the dural sac. Here, a bit more challenging case, a giant cell tumor, where I do a lateral corridor here to release the dural sac, and here are the pathological specimen, and also here we were able to achieve clear margins. Even in tough cases like this, with a malignant fibrous histiocytoma and a large epidural involvement, as you can see here, and a large extraosseutic component, you will have a tumor-free corridor here. So even in this challenging case, we were able to perform external lesion resection. Here you see a 3-level en-bloc resection with a reconstruction.
Als Rekonstruktion bezeichnet man in den Vereinigten.
If you have or in rare cases where both pedicles are affected, like here in this low-grade osteosarcoma, it's probably the best thing you can do is to do a contaminated marginal resection, as we did here, with a minimum spill of tumor cells, with a front and back reconstruction, as you can see on the X-ray. The technique I would like to explain to you is the front and back reconstruction. We presented that back 2008 in the European Spine Journal, and ever since the technique hasn't changed very much. And I would like to take you through a history of a case. It's a 7-year-old girl named Dania with a history of leukemia and radiation therapy and bone marrow transplantation, and she received a total en-bloc spondylectomy T4 to T7. Further challenging comorbidities was a steroid-induced osteoporosis, and she was biopsied, and the histology showed a secondary osteosarcoma T4 to T7. And these are the X-rays and MRI. You can see the osteolysis. She had a quite wide scarring of the biopsy. You see a lesion of T3, and you see the affection T4 and T5, the solid tumor, and T6, and the affection of the neuroframe in T6, T7. So this is the planning, and I just recommend do a very thorough surgical planning preoperatively. And I like to do this drawing and take it into the OR, put it on the wall, just to make sure we're doing the right thing. And this is a total en-bloc spelling T4 to T7, and this is the planned resected specimen. What we do is we leave the biopsy scar and then contaminate biopsy cord on the specimen. We put on pedicle screws T2, T3, T8, and 9. We do wide lateral rib osteotomies on the left and proximal rib osteotomies on the right. We create a tumor-free corridor and release the nerve roots and do a subpleural release on the right, because that's going to be the side we will face downwards when we put the patient on the right. We do left-sided nerve root ligation because here the tumor is too large of extent. We do subtotal disc incision T3, 4, and T7 and 8 and transect completely the posterior annulus, which is very important because from the front it's hard to get that approach. We do flavotomy and bilateral laminotomy T3 to resect the spinous process T3 as well, and then a temporary rod. Then we have a short break and do a right lateral position. We drape the posterior wound as well, do high thoracotomy on the left side, complete the discectomies, and then we open the posterior wound and do a simultaneous a rotation of that specimen, spondectomy of the 4 vertebral bodies. And you can see here still the skin scar and the corridor of the biopsy corridor still on the resected specimen. And by that, we stay outside the tumor and have a strictly axial resection. And here you see the vertebral body, T4, 5, 6, and 7, with a large tumor mass here. And a Gore-Tex patch reconstruction of the chest wall is important as well. Here the post-op X-rays, that was an 8-hour surgery with 3.5 milliliter of blood loss. And I have, yes, 6 years follow-up, so far no evidence of disease. So commonly, thoracic en-bloc spondylectomies are rarely single-level resection, but in most cases multi-level resection. So a nerve root sacrifice is frequently necessary. We know from studies from Japan that up to 3 pairs are neurologically safe. If you have to do more than that, you might end up in ischemic paraplegia. Here are just a couple of examples of osteosarcoma or Ewing sarcoma with multi-level resection. What about the fusion length? Normally, if you have a 2 or 3 level resection, 2 above and 2 below is sufficient. If you have more than 3 levels to resect, as you see on the right side, it's probably safe to instrument 3 levels above and 3 levels below. And don't forget the additional anterior fixation to get maximum stability. As pointed out, excise the scar and the biopsy tract if possible, like here in the 12-year-old girl with the osteosarcoma with a huge laminectomy defect, where we left the skin scar and the corridor on the specimen to get free margins. And we have an 8-year post-op complete remission follow-up of this lady. If you want to start with this technique, well, the easy ones are the 1 level with hardly any soft tissue involvement, with a wide tumor-free corridor, no pre-op surgery at the virgin spine, with a small biopsy tract, and thoracolumbar regions probably the easiest one. Lower lumbar and higher thoracic are the most challenging one. And of course, the psychological burden on the surgical skills are somewhat less than the metastasis compared to primary tumors like sarcoma. The tough ones are the multi-level resection, a large soft tissue involvement, rib involvement, like here in the 4 level, or in another case, a 6 level resection, osteosarcoma, with wide bilateral rib osteotomies and nerve root sacrifice. And this patient ended up in an ischemic paraplegia. However, she's still alive. She had 12-year post-op follow-up on her, and she's still alive with no evidence of disease. Extensive rib involvement, like in this Ewing sarcoma, might be challenging. And here it's very important to cover the chest wall with a Gore-Tex patch. And here's the girl in the post-op X-rays after en-bloc resection of 2 level plus 3 ribs. If you have the rare instance of a single level affection with hardly any soft tissue map, you might go for a posterior only en-bloc resection. However, you do not have any anterior control and certainly high mortality. So my choice of preference is certainly the combined posterior and anterior technique. Complication you might end up is, of course, bleeding, dural tears if you have one, closed it very meticulously, neural deficits, infection, or even local recurrence, as pointed out in these cases. This was an interesting complication. The more you the more cases you do, the more long-term complications you will experience. And this was 7 years post-resection of an angiosarcoma, and she had a broken rod, as you can see here, with a kyphus and a pseudarthrosis. So we repaired that, and the surgeon who did it thought, well, I do some correction of the kyphus, but she woke up paraplegic, and you can see here why, because the posterior rib that we had put on as a biological graft fractured and impinged into the spinal canal. So we took her immediately back to theater and decompressed the spinal canal, did this 4-rod reconstruction. Fortunately, she recovered completely. Tips and tricks. This is high-level surgery. You need, first of all, a clear strategy. You need a good radiologist to go through all your X-rays, MRIs, and CT scans to know where is tumor, where do I have a tumor-free corridor. You have to have a profound experience in entry approaches, microsurgery, vascular surgery, and you should be creative when you reconstruct your spine. Like here, we do posterior biological reconstruction with iliac crest grafts, or here with fibular grafts, just to enable a long-term stabilities in young patients. You need an experienced anesthesia team and stand by. I always include inform my vascular surgeon. In many cases, I don't need them, but it's a good feeling to have them informed that in case you need them, they are prepared. And again, especially if you have primary tumors like sarcomas, free margins are the primary goal and the prerequisite for survival. Thank you very much for your attention, and best greetings from Germany.
Thank you very much. Any questions from the panelists? Okay, I have a question, which is one of the problems that we face is in these osteoclastomas, and when they recur, it's a big problem. So how do you deal with recurrent osteoclastomas?
Well, the best thing is, of course, to prevent them by doing it right in the first time. So we resect osteoclastomas, giant cell tumors, extralesionally if possible. And if you have recurrences, you might talk to the radiologist or to the oncologist with some adjuvant therapy to decrease the soft tissue involvement, and then go for surgery after this adjuvant therapy to make life a bit easier. But I think the most decisive thing is to do it right from the beginning, and we know that we have a 50% recurrence rate if we do it intralesionally. So try to resect them extralesionally with free margins from the beginning.
Do you use radiation if there is a recurrence, recurrence after recurrence, after you do this excision and as well as radiotherapy?
Not routinely, no, not routinely. Radiation doesn't play a major role, no.
Right. Would you use gamma knife or proton beam therapy?
In a giant cell tumor, no.
Recurrent ones?
Even the recurrent ones, no. It's a surgical therapy.
Okay. Thank you very much. I think if there are no further questions,
Raghav, can I ask a question, please?
Sure. Arvind.
Yeah. Dr. Lundquist, great presentation, great work. I have a basic surgical question to you. You from your X-rays and your presentation, I could see that you use a fibula or a rib to cover the large laminar defect at the back before closure, right? Number one, if you're using these bone grafts, how do you keep that into position? Number one, what is your take on using titanium mesh, opened out like a titanium mesh, and putting bone graft over that?
Very good question. Thank you very much. What we do is in the lumbar spine, especially you have to differentiate. In metastasis patient, you probably do not influence the long-term survivalship. So here, I probably do not pay that much attention to posterior biological reconstruction. But in all the kids and younger patients with the primary sarcomas, I do try to reconstruct the posterior column as well. And what we do is in one level en-bloc spondylectomies in the lumbar spine that I take a butterfly graft from the iliac crest, and I just squeeze it in between the remaining spinous processes of the neighboring vertebra and fix it with a transverse connector, number one, and then cover it with bone. If you have larger defects, the titanium mesh is a wonderful idea. You just cover the spinal canal, and then you put on bone graft, allogenic or bone graft on that. Or what we do in longer, in 2 or 3 level en-bloc spondylectomies, I like to take autologous fibula grafts. And what we do is, that was your question, I think, we secure them with titanium screws to the upper 2 and lower 2 spinous processes.
Thank you.
Lovely. There are a couple of questions here. One is, I think it's not correct, but how do you deal with circumferential chordoma, number 1? And number 2 is en-bloc resection possible in cervical spine?
Yes. Well, in circumferential chordoma, these are challenging ones. And here we do, of course, all of these cases are discussed in the tumor board. And here proton beam radiation and the radiotherapies do play a major role. So I think also from the literature, what is now recommendable is to do a tumor size reduction and then go for radiotherapy. And in the cervical spine, you always have the problem of the vertebral artery. So what you definitely need to do is to check what is your main and dominant vertebral artery. If you have a non-dominant vertebral artery, you might resect it and occlude it preoperatively with the help of the radiologist. But of course, cervical spine, especially the upper cervical spine, is even a very, very tricky anatomic region. Let's put it this way.
All right. I think we're running late and been getting warnings from the organizers. Thank you very much.
Dr. Raghav, sorry, Dr. Venkatesh here.
Yeah.
Regarding the en-bloc cervical spine resection, I think we should watch Dr. Boriani's interview today at evening. Right. So he is going to talk about it.
Sure, lovely.
The interview, yeah.
Thanks. Let's move on to the next speaker, Peter Vakoczy. Sorry, once again. Treatment strategies for thoracic disc herniations.
Chairman, ladies and gentlemen, first of all, thank you very much for the kind invitation to this joint symposium between the German Spine Society and your distinguished society, and it's a pleasure to detail you our key concepts for the surgical management of thoracic disc herniations, which is still a challenge despite all the advances that we have seen in the surgical treatment of degenerative spine disease. So why is it so difficult sometimes to treat these thoracic disc herniations? Number one, these are quite rare, and this is why we are not really prepared and trained well, because less than 1% of all disc herniations are in the thoracic level. Number two, there's really no room for conservative treatment, since most of the patients will present with severe neurological symptoms asking for a surgical treatment. Most of these lesions are localized in the mid-thoracic area, and they are localized centrally and sometimes intradural, which makes it challenging to remove them without injuring the spinal cord. And most of these are hard and they are calcified, which again makes it difficult to fish them out of the spinal canal. The diagnostic workup, that's how it starts, is straightforward. Number one, we start with the MR. Most of these patients present with incomplete spinal cord symptoms. And then when we have identified the disc herniation, we have to clarify whether it's soft or whether it's calcified. And this is usually done with a CT imaging, as in this case, where we can identify the centrally localized calcified disc herniation. The laminectomy, the pure laminectomy, has been the standard approach for most of these lesions for a long time. Today we have learned that this is a high-risk surgical procedure, which is meanwhile obsolete for thoracic disc herniations, because the complication rate is high, and even there is a certain risk for mortality of these patients due to a severe spinal cord injury. It's obvious that just removing the dorsal lamina will not adequately decompress the spinal canal in the kyphotic thoracic spine, where the disc herniations will push the spinal cord back. And this is why in the past several procedures have been suggested for the surgical treatment and for the surgical removal of thoracic discs, where either the pedicle, the facet joint, the rib head, or parts of the rib are removed, or we are coming in through a thoracotomy to come more laterally and advancing more laterally to the spinal cord and to the spinal column. But it's very simple. If the thoracic disc is localized medially and it's hard, then one should come from a posterolateral or from a lateral approach. If it's soft or localized more laterally, then a posterior approach might be sufficient if parts of the facet joints or the pedicle are removed. Here, our favorite approach, and this is what I would like to detail first, is the mini-open transthoracic approach, where we will advance to the spine through a retropleural preparation. The patient is positioned in a lateral position. We will expose the rib over the index level. The rib will be removed over a length of approximately 5 centimeters. Then we will perform a blunt dissection retropleurally, and we will identify the disc, and we will retract the lung. And this can be all done by microscopic means, and for sure maybe endoscopic means are not necessary. Everything can be done microscopically. And the concept is then to drill a cavity into the bone, into the disc space, which will then allow to push the calcified fragment away from the spinal cord into this cavity, and thereby directly decompress the spinal canal and the spinal cord from this calcified disc. Besides the microscopic approach, this approach has been also benefited from navigation and intraoperative imaging. Here we have a case where we have performed a full navigated approach. We have identified the level, we have planned the extent of resection, and we have performed intraoperative imaging in order to confirm the extent of bony resection and the removal of the calcified discs. So navigation and intraoperative CT are really helpful tools in order to further improve on the quality of the surgical removal of these thoracic discs through a transthoracic approach. And in our last cases, we have further advanced to the minimally invasive approach using these tubes, which are inserted through the mini thoracotomy. They are placed at the index level, and today we are removing discs through these tubes, which again minimizes the trauma or minimizes the access to these discs. This is a video detailing the classical microscopic approach, the transthoracic approach to this calcified thoracic disc. Here is the mini opening, the small skin incision, the exposure of the rib, which is removed for a length of 5 centimeters. Then we have the blunt dissection. Retropleurally, the lung is slowly mobilized, and here we are at the bottom of the preparation, the lateral aspect of the spine. We can identify the disc, and we are slowly removing the soft tissue or mobilizing the soft tissue. Here the segmental vessel is coagulated and controlled and then cut. We identify the rib head, which will be removed partially in order to identify the lateral aspect of the pedicle in order to gain access to the spinal cord. This is again identifying the correct level either by fluoro or by navigation. Here we are using the high-speed drill, and now we are removing parts of the disc. In the center, we are removing the ligament over the disc, and then we will use the high-speed drill in order to create that cavity, approximately 5 millimeters into the upper end plate and 5 millimeters into the lower end plate, and this cavity will then allow to push the fragments into this cavity away from the spinal cord. We are using the drill with a continuous irrigation, and by getting more towards the spinal cord, we can then identify the posterior ligament, which is usually calcified. Sometimes it's very attached to the disc fragment, and here you can identify the dura, and then with the help of the assistant and with the help of microsurgical sharp dissection techniques, the calcified posterior ligament plus the calcified disc are pulled away from the dura instead of mobilizing the disc directly to us. So first pushing the fragments into the into this cavity will allow to slowly decompress the spinal canal, and you can see the stepwise decompression of the dura. And then we are using the intraoperative CT in order to confirm the extent of our drilling and to confirm the removal of the calcified disc. In addition to this transthoracic approach, I would like to introduce you to an additional alternative which has been recently described by the Dutch group around Dr. Koppes. The route they are taking is again a posterior approach, but instead of going around the dura is opened in the posterior level, then the dentate ligament is cut, the dura can then be rotated using sutures which are tacked to the dural ligament, and then this allows us to open the anterior dura again, and then having a transdural approach to the disc, you are then able to slowly remove soft discs and even hard discs. This has been initially reported with 13 patients. Meanwhile, the group has an experience with 30 patients. The results are very good and the complication rates are low. We have tried these with our last cases. This is a case of a soft central localized disc. Here we have already opened the posterior dura. Here is the dentate ligament which has been cut. The spinal cord is rotated. You can see the tack-up suture, and here the anterior dura has been opened, incised sharply, and the soft disc is slowly removed. And you can appreciate the minimally invasive access to this delicate area, and by mobilizing the dentate ligament, the spinal cord can be now manipulated in a way that the disc can be removed. It comes without saying that all these manipulations are done under neurophysiological monitoring with the continuous assessment of MEPs and SEPs, but with a hook and with the microdissectors, these soft discs and sometimes even the hard discs can be removed by this posterior transdural approach. The dura is then simply sutured with 6/0 sutures, or it can be patched or glued. Especially the anterior dura will then be compressed, and the posterior dural is classically sutured. So we have two approaches which are very helpful in treating thoracic disc herniations today. The neurological outcome in the literature has been reported to be excellent. In comparison to the data that we have from the laminectomy, we see excellent results, especially with the transthoracic approach, but also the posterolateral and the lateral approaches seem to be very efficient and more successful than the laminectomy alone. Here you can see the predictors of an unfavorable outcome, and especially the preoperative motor deficits and those patients that had previous surgeries. These patients seem to be high-risk candidates despite everything that we can do with modern surgical techniques. Here another study detailing the postoperative complications and nicely showing that in comparison to laminectomy, the posterolateral and the lateral approaches are characterized by very few complications, neurological complications, and the same is true for the surgical approach complications, where all these approaches are characterized by a low incidence of surgical or approach-associated complications. So in conclusion, this is our current working algorithm for the surgical management of thoracic disc herniations. We start with an MR and with a CT. Those thoracic disc herniations that are soft and that are lateral are good candidates for posterolateral approaches, where we remove the pedicle, remove the rib head, or even parts of the proximal rib. Then these soft and lateral discs can be removed safely. If, however, the disc is localized more centrally, or if it is hard or calcified on the CT, then we will consider a posterior transdural approach if they are more on the lateral side, which I've shown you, and if they are really centered in the midline, localized centrally, and if they are hard and calcified, and if they are of big size, then we would recommend rather come in from a transthoracic approach if they are extradural, and if we can identify them to be intradural, we would come in with a posterior transdural approach. And I hope and I'm convinced that this kind of algorithm might be of use in the future for treating thoracic discs in your practice. Thank you very much for your attention.
Thank you very much. It's an excellent talk. There's just one question here. Now, don't you think that fixation and fusion at the index level is important because the procedure creates a big cavity in the adjacent bodies? This is from our Professor Sudhir Srivastava.
I think that's an important question, and everybody, and this has to be considered on a very individual basis. If you look at the literature about the long follow-up of these, I mean, this is not a big cavity. It's a minimized oblique drilling that you do from coming in from the transthoracic approach. So all the literature says that you might not need a fusion, and until the posterior elements are intact because the patient has not had previous surgery, our experience is that you will get away. But obviously, you have to assess the amount of drilling intraoperatively or postoperatively, and if you feel that you have destabilized the spine because you have removed too much bone, then a second staged surgery with a posterolateral fusion makes sense. And I would rather recommend to do one more than to do one few or not enough. But the data is not really supporting the need in general for fusion.
Okay, a couple of quick questions. How do you deal with CSF leak in thoracic approach that is transpleural? How do you deal with CSF leak in a transthoracic approach that is transpleural?
That's the perfect question for the upcoming case illustration that I'm going to show you. Because in the case that I will describe in a few minutes, we really created a leak due to a very calcified large disc fragment. And we tried to patch this coming in through the transthoracic approach, and it didn't really work. So the lesson that we have learned, just to tell you in advance from this case, is that it's really helpful to come in early through a posterior approach and repair the leak transdurally. So this is really a good question, and I think trying to fix it through a transthoracic approach is often not successful.
Thank you, Peter. I think we should stop there because there's lots of questions coming up, but I'm sure you will address them at a later time. We will move on to Bharat Dave.
Panel faculty to look at the chat box, Dr. Peter, Dr. Marcus, Dr. Frank, and Dr. Ulf, because there are a lot of questions for you on the chat box. If you look at that, they will answer them.
Yeah. Now we will move on to the next topic, surgical approaches to thoracic myelopathy by Bharat Dave from Ahmedabad, India.
Greetings from Bharat Dave. Greetings from Bharat Dave. I am talking on behalf of Dr. Ajay Shetty, who is not able to attend the meeting today. My topic is dorsal myelopathy, surgical approaches. Dorsal myelopathy can be seen in various conditions. As this case, one can see the ligamentum flavum calcification. We call this as OLF, ossification of ligamentum flavum. Could be because of the prolapsed disc, commonly seen at the lower dorsal area. Could be because of the infection, which is quite common seen in our part of the world, that is because of the tuberculosis. Could be because of the metastases, secondaries, or even primary tumors as well. And could be because of the fractured spine, dorsal myelopathy. But the most important thing is the clinico-radiological correlation, and that has to be achieved by proper assessment before planning the surgery. And for that, most important is we have to ask about the bladder valve involvement and have to have the grading of the neurology. X-ray are must because these are the junctional problems and where we really need to count the vertebral level, and that is why DL and LS junction has to be included in the X-ray. And most of the time in order to rule out the tandem stenosis, we usually have the full-length MRI, and CT scan is an added tool in order to see the calcification. Eventually, we confirm the diagnosis and have the clinico-radiological correlation and treat this pathology. Also, we should be assessing the outcome, neurodeficit, how much it's going to improve, and we have to stress about the post-op rehabilitation. And the most important will be the social support. If the poor social support, then the overall outcome is really bad. So management strategies, well, it's a surgical disease. Myelopathy, particularly the dorsal spine, it's a surgical disease. Can we treat with the Solumetrol? Well, most of the time we do see patients being treated with steroids, but it does give temporary relief. But at the end, the compression has to be relieved. Coming to the case discussion, 65-year male who had back pain since 10 years, but there was recent worsening of the activity of daily living and had upper motor neuron lesion with hyperreflexia and plantars upgoing, but bladder bowel were normal. But his cardiac function was only 30% ejection fraction. These were his MRI. One can see the lesion in the lower dorsal, compression as well as the disc prolapse as well. You can see that symptomatic level was operated because the cardiac function was only 30%, although patient had lumbar stenosis, which was predominantly not symptomatic as patient had a recent onset of the symptom and activity of daily living. These 10 years of the back pain which he had in the history was because of the lumbar degeneration. Another case, 49-year-old lady, both thigh pain, 2 years, tingling numbness, both lower limb. She was non-walker, 1.5 years, and spasticity in both the lower limb. Her neurology was power grade 3/5 with hyperreflexia and plantars upgoing. X-ray reveals density of the bone that has increased, and one can see calcification of ligamentum flavum, which is predominantly compressing the posterior cord. She was operated by En-bloc removal of the lamina at the compression level. One can see adequate decompression in the MRI. Usually we have the post-operative MRI done at our center. This patient had adherent dura with the ligamentum flavum, and there was adequate decompression seen. Another case, 45-year female, spastic paraparesis since 6 months. It was nearing grade 4 and bladder bowel affected. One can see the tandem stenosis in the dorsal and lumbar spine, but she was young, 45, and she also had surgery done for the dorsal and the lumbar spine, and one can see the post-operative MRI and X-ray done and adequate decompression seen. The key point here for these surgeries are laminectomy, bone scalpel. Dural injury can happen because of the flavum adherent to the dura. Particularly we see in our cases, in our part of the world, fluorosis is quite common, and we always go for the post-op MRI in order to make sure that we have done the adequate decompression. Another case presentation, 21-year male, had both lower limb weakness, tingling numbness since 4 months, and he was able to walk with the 2% support due to power grade 2-3 in both the lower limb and spastic gait. One can see again the decrease in the disc space at D10, D11, D11, D12 as well. These are the X-rays, reveals bone density increased as well. One can see the dorsal disc prolapse at D10, D11, more on the right side. This patient had lateral extracavitary approach. We often sacrifice the nerve root in order to have the proper access without retracting the dural sac. We are able to remove the disc, and we have fixed that because we usually remove the pars and we put the cage, we push the fragment into the disc space so that there is no manipulation of the cord. And this is confirmed by the MRI post-operative. One can see, and the CT scan as well, one can see very well decompressed dural sac. Similar case in 2011, patient had symptoms, acute onset 2 months, both lower limb tingling numbness, significant imbalance, and bladder bowel, they were normal. His range of movements, they were free, and he had upper motor neural lesion with clonus on the left side. He also had D10, D11 dorsal disc. These appeared to be the soft disc. And this patient had immediate post-operative, when we reviewed, he had neurological worsening. So we had sent this patient for MRI, and one can see that immediate post-op, we had missed the level of this patient, and there was worsening due to the same. So we ended up operating him again on the second day, and this was redo surgery done at the lower level. So the key point, patient can be operated dorsal disc, probably maybe endoscopically transthoracic, but our approach is through the pars removal and do the discectomy and put the screws. Collapsed disc has to be identified. Whenever there is post-op worsening, consider that one may have missed a level. We never distract when we do this type of disc surgery when there is anterior compression. The neurological deficit is likely, and we operate all these cases in the neuromonitoring. So the management strategy for dorsal stenosis is only laminectomy is contraindicated in anterior compression whenever there is kyphosis. Only laminectomy is indicated when there is posterior stenosis due to ligamentum flavum compression or ossification. Anterior decompression through posterior approach can be achieved through the LICA approach. And we have had one publication in Global Spine mentioning the same with successful outcome in 18 patients. Only one patient had neurological worsening, which I shown earlier. Posterior laminectomy is really helpful with the scalpel. Bone scalpel is one of the tools which has changed our practice, because we have chlorotic patients and sometimes we end up decompressing from C1 to L2, maybe up to L4. So the whole spine we are able to decompress with two teams using two bone scalpel and two consoles. Tandem stenosis has to be ruled out whenever we operate these cases in order not to miss the level either cranial or caudal. Thank you for your patience hearing. Thank you.
Thank you, Bharat. I'm sure most of us, any questions from the audience here? None. As we're getting late, I think we will go on to the next topic. And if there are any questions coming up on the chat box, kindly have a look and we can discuss later if you have time. We will move on to the next topic: indications, techniques, tips and tricks for thoracoscopic spine surgery in trauma cases by Marcus Aran.
So, folks, can you hear me already?
Yeah, we can hear you very well.
Okay, perfect. So I just have to get my screen done. 1 second. Okay, can you realize my screen?
Yes, we can. Looks perfect.
Perfect, thank you. Now, the technique goes back on a former president of the German German Spine Society in 1994, Daniel Rosenthal. He described first the techniques of thoracoscopic spine surgery in herniated discs. And this is actually, I searched for my first operating report when I did it first. It's about 23 years ago. And in 1995, the first reports came using that technique in trauma. Now I have a problem in getting, now, okay. The capability of a new technique, using it, is always a question: do I achieve the same tasks with the new technique than with older ones? And the others, how is the problem with complications with the new technique? In this matter, the conversation situation. So whenever I start a thoracoscopic procedure, when I end up with the open procedure, and you can see the situation in my field. I'm overlooking about 300 thoracoscopic procedures, and in the first 10 years, I had 6 conversions of thoracoscopic operations in open operations, and in the last 13 years, I only had 1 conversion. Now, before you can do an anterior thoracoscopic procedure, at first, you have to have a posterior reduction and a posterior pre-stabilized spine. So as an standing alone anterior procedure, the thoracoscopic spine stabilization is not a good instrument. And as well, you need a controlled situation. We often have polytraumatized patients. We have pulmonary injured situations. And these patients, they must be preoperative with an intact pulmonary function. Now, the indication for anterior procedures is at one part the situation. You can see here that this is a post-operative CT scan of a TH12 fracture, and this is the same patients 4 months later with the next CT scan. You can see the intruded vertebral body. You can see the loss of correction of the vertebral body. You can see the vacuum phenomenon. This is a situation you would be not able to heal it adequately. Another indication for the anterior procedure is defects in the vertebral body and corporal kyphosis, and as well as I will present you a case, encroachment of the spinal canal. Now, pro-thoracoscopy is you have a very, very good exposition. Everybody can see the same what you are doing. The visibility is perfect. Brightness, resolution is perfect. There are contraindications. What I told you, pulmonary insufficiency, then sometimes anatomic variation. Today, that wouldn't be a big problem because I verify from different approaches, right to left as well. So if you have a problem with the aorta or the position of the aorta, you have to go from the right. That is no problem. The multi-level instrumentation would also be not a case I wouldn't do today. So it's a learning curve. And what I told you before, this is a prerequisitation that you need a reduction. You are not able to reduce intraoperatively. Now, this is the positioning of the patient, lateral position. I usually prefer to stand in the back of the patient. The fluoroscope, this is, I personally like the fluoroscope from the belly of the patient coming. There's one assistant there, and there is the camera assistant with me on the side, on the back side of the patient. And if I'm doing upper thoracic spine, the camera assistant is positioned with the legs. And if I do a lower thoracic spine, L1 up to L3, L2, sorry, then the camera assistant is towards the head. This is the positioning. You open the situation, the rib cage to the approach. And what is mandatory at first,
you have to get really lateral positions with the imaging intensifier of the instrumentation location, and you need to know exactly where the projection of the vertebral body you have to go on is on the skin. This is very, very mandatory. Otherwise, you will have problems. This is the approach for the camera. This is the approach for the retractor. Now, this is such a case, a 21-year-old male motorcyclist, polytrauma, initial paraplegia. This is the lesion. It's a TH6 rotation burst fracture. And I'm going to show you the thoracoscopic views. This is the pre-stabilization by a posterior approach. And now we go on what you can see here. This is the vertebral situation. This is the pleura, which we try to get away. And it's very important, these two pins, this is one over the instrumentation, one lower in the instrumentation. Left is leg, right is head. And here I'm doing the incision of the lower disc towards the leg. You can always, in the picture, can see these two pins, which are placed under fluoroscopic view, because if you rotate the camera, you really get immediately lost in the picture, and you don't realize what's going on. Here you see the lung and the retractor, and at first, normal procedure, removing of the disc, the spinal canal is around there. Now here, the disc is removed. Now you're taking the chisel and taking out the vertebral body. I'm always trying to work forward, not backwards, because on the back sides, it's the spinal canal. Here, underneath the retractor, it's the aorta. So you have to be a little bit careful about that. And what you can see here is it is always possible. That's already the posterior longitudinal ligament. You are doing the decompression. You have a perfect view. You can move your camera. You have a 30-degree camera. You can move it as you want. You take out the bone fragments with the spoon or with this rongeur, as you can see that, and you try to get a perfect place for your vertebral body replacement. Here you can see the place of the spinal canal. Now the next step is you just put in the vertebral body replacement. I prefer to use expansion system. This is very easy for thoracoscopic use. Here the expansion, here actually you see the diaphragma down there, and you have to be a little bit careful not to overextend the system. You have to take, using the placement, you have to take the fluoroscope. And now this is the scene after the operation. You should take back the pleura to close the whole situation. Here you see the lung, then you see the heart region around here. And before you go back on the, here already the pins are removed. Before you go back, you just put some water in. Here you see the thorax drainage, and you do PEEP lung ventilation, and you really check if there is any lesion of the lung, and then the operative procedure is over. This is the intraoperative view. you can see again here, this is very important that you don't get lost intraoperatively. You always, during the operation, you need an indication what rotation you have during the operation. Here you can see the decompression, which is complete in that case. Postoperative treatment, we usually do an immediate extubation. In earlier times, when you did the transdiaphragmal approach, we had at least 3 to 5 days postoperative breath management, and we have an immediate mobilization of the patient, and we always do the postoperative CT. Now, in my view, it's a very, very advantageous procedure. It is a significant patient benefit. We have a reduced excess morbidity. If you are really, you have a learning curve with this technique, but if you have really a good technical behavior, it's a very safe operative procedure. Thank you very much for your attention. Thank you.
So are there any questions to Dr. Marcus or to Dr. Bharat Dave?
Dr. Chawla, can I ask a question to Dr.
Yeah, sure,
Marcus?
sir.
Yeah, 2 questions, Dr. Marcus. A great presentation and great handicraft there. Lovely visualization. I noticed that your lungs were inflated. Normally in thoracoscopy, you have a single lung anesthesia. Do you follow that? Or your lungs looked inflated here?
Yes, you definitely need one lung ventilation. This is very, very important. So you need a double tube, and this must be placed perfect. And in the beginning of the procedure, I had to convert one time because I didn't get not a good one lung ventilation. This makes the situation very important. If you have one bad lung of a traumatized patient, the other side must be your approach side and must be good. Otherwise, the procedure doesn't work.
The second question, if you have to decompress two levels, D12, L1, would your approach would be transthoracic, then you go retroperitoneal, or you just cut the diaphragm and go down?
Still, my approach would be still transthoracic. It is no problem to get access to the segment L1, L2, but this is the lowest you can do. You can do an instrumentation on L2, thoracoscopic, but you will not be able to do instrumentation on L3. So the last decompression you can do is L2, L1, L2. This is the last decompression. You cannot get lower, but I would say the thoracoscopic approach or the transthoracic approach, L1 is easier than the retroperitoneal approach, in my view.
So when you go down to say L1 or even L2, if you said you can go down to L2, in which case do you remove a portion of the diaphragm there? You can make a small opening.
Yeah, you just make a small split,
exactly.
Parallel to the vertebral column. Very easy. The problem, as lower as you go, as longer is the distance to the vertebral body. It's very easy in TH12, TH11, and it gets more difficult as lower you go.
So in that case, again a technical question. In that case, and your thoracoscopy, endoscopy, thoracoscopy, how do you repair the split in the diaphragm that you do? You take staples, or you use sutures?
I suture it.
Okay.
Okay, I think we must come to an end of this session. We're coming to an end. Just one last question here. Would using an expandable cage increase the incidence of pseudarthrosis in trauma? you're using expandable cages. Are you worried about pseudarthrosis, unlike in a tumor situation?
You asked me, I think.
Yes.
So I personally, I put bone a lot, the resected bone of the fractured vertebral body. I put that in the cage and on the cage. And usually, if you don't do an over distraction of the situation, I didn't really observe the problem of pseudarthrosis. It's also possible to use an additional plate fixation or rod fixation with the transthoracoscopic techniques to reduce the risk of whatever pseudarthrosis.
All right. Thank you very much. I think we're a few minutes late here. Now, is Dr. Chabra there? Yeah. On behalf of Association of Spine Surgeons of India, thank you very much. Over to Gautam to go on to the next session. Dr. Chabra, you have a few words to speak on behalf of ASSI.
No, it's, I think it's start of a new chapter in collaboration with DWG, and we hope to take it forward. Of course, Frank will continue to moderate the session, but we have Dr. Sajan, we have Dr. Shankaracharya and Dr. Ram Chadda, who will be moderating the session along with Dr. Marcus. Right. So can we have Shankar? Can you start the proceedings along with Dr. Marcus?
Yeah,
I think Dr. Ram Chadda is running a few
Good evening,
minutes.
everyone. Good evening, everyone. Now I invite the joint case interactive case discussion, and I would request our panelists, Dr. Sarjan, Dr. Karthik, Dr. Frank Kanjiora, Dr. Wolf Lillingquist, and Dr. Peter Wakzoke. Are you all there? I can see most of them. And without much delay, I would request Professor Wolf Lillingquist to share his screen on the case of osteosarcoma of the chest wall with spinal involvement. Incidentally, many years ago in 1999, I did a short fellowship with Professor Lillingquist, and I was really impressed by his work. And I would be happy to see this case and take it further. Professor Lillingquist, are you there?
Thank you very much. I'm not able to Ladies and gentlemen, dear colleagues, it's a great pleasure.
We record it.
So go on. Ladies and gentlemen, dear colleagues, it's a great pleasure and honor for me to present a challenging case of a primary malignant tumor of the chest wall and the spine. And I would like to take you through that case, and we have a 1-year follow-up as well. This was a 18-year-old patient, a male patient, a lumberjack, a forestry worker, with the osteosarcoma of the fifth rib. He had a CT-guided biopsy in October 2018, and he received 2 cycles of chemotherapy, and we were contacted in February 2019. And these were the CT scans pre-chemotherapy. You see the large, extensive tumor mass with affection of the rib and close proximity to the vertebral body. And this was a shrinkage of the tumor just after 2 cycles of chemotherapy. The MRI scan reveals the huge size of the tumor, both in the frontal and the actual planes. With here you can tell the affection of and the involvement of the vertebral body and the neuroforamen. So the big question here is will you be able to achieve clear margins by cutting through here somewhere, or do you have to take out the whole vertebral body to be safe? Again, after 2 cycles of chemotherapy, the tumor shrinked to this size, as you can see here. But also note here the close proximity of the tumor to the neighboring upper and lower rib. Some further details are the following: a close proximity of the soft tissue mass to the aorta, and a potential infiltration of the lung, as you can see here. Surgical planning. Is a partial vertebral resection sufficient? Will that guarantee clear margins? Or should you perform an en-bloc resection on the vertebral body to be on the safe side? How many ribs should you resect? Just the one, or should you resect the neighboring upper and lower rib? Which approach? Only posterior, posterior anterior, and how do you cover the chest wall? What about the lung? What about the aorta? And bear in mind, this is the osteosarcoma. This is a highly lethal disease. If you as a surgeon don't achieve free margins, the patient will have very, very low chances to survive. So free margins are mandatory. And you have to get it right from the beginning. Here again are the pre-op, and I like to look at the pre-chemo CT scans and MRIs because they help you deciding upon the extent of your resection. We opted for a en-bloc spondylectomy. I personally thought that that would be clearly the safest choice. These are the levels that we resect: 3 ribs and 2 vertebral bodies, with the sacrifice of the nerve roots T4 and 5 on the left side, with posterior fixation T2 to T7 and reconstruction of the chest wall with the Gore-Tex patch. We did a T-shaped skin incision in order to be able to, you can tell here, to laterally osteotomize the ribs. We did, of course, here the pedicle screw instrumentation. We did all the release. We encountered a heavy epidural bleeding and very strong trunk muscles. So it was quite a tough surgery. And after having created a free corridor and done all the posterior work, including the rods, we put the patient on the right side and did a high left-sided thoracotomy. Fortunately, we did not find any lung adhesions. We asked the vascular surgeon to liberate the aorta, which was a good idea. So you get a bit of rest as a surgeon. And then we completed scectomies and reconstructed the anterior column with this titanium vertebral body replacement. And nowadays, I slightly changed my technique. Nowadays, I would use a carbon fiber reinforced PEEK cage for that. And this is a resected specimen after 10 hours of surgery, 3 ribs with a tumor here and 2 vertebral bodies. The chest was reconstructed with a Gore-Tex patch, and total blood loss was 3.5 liters, and the OR time was 10 hours. So that was an all-day surgery. He was put on quite a prolonged ventilation for 5 days due to a severe post-op bronchopneumonia, and he stayed even for 9 days in ICU just for pain control. But then he recovered very swiftly, and we were able to send him home after 14 days. But here's the histology report, which is very important. Number 1, free margins. Number 2, full response to the chemotherapy, which means the pathologist could not find any vital tumor cells in the resected specimen. And these are very, very good news, because with these 2 results, free margins and full response to chemotherapy, this patient have a chance of surviving that disease of more than 90%. We sent him home after 14 days. These are post-op X-rays. And here's the clinical picture. You can tell from his muscles, he was a very strong young man, that this was quite a challenge to get through all this chest wall muscles and do the resection. But the wound healed primarily, and he was up and about and was fit to go home after 14 days. We have a 1-year follow-up. There was no evidence of disease. He completed his cycles of chemotherapy. He's now again full-time working as a lumberjack, and he sent me just this picture, a happy young man, and these are the CT scans and the X-rays after 1 year. Yes, discussion of osteosarcoma. Free margins are mandatory for survival. Again, a meticulous preoperative planning is necessary, and an interdisciplinary approach. You have to have a close collaboration with oncologists. You have to discuss all the X-rays and images with your radiologist to make sure how to do that surgery. Never go unprepared into theater if you have such a case on the list. And survival rates, and these are again old literature, I would say, 6.7 years or 5 years survival, 20 to 60%. my personal experience is that if you have full response to chemotherapy and free margins, they have a high chance of surviving the tumor in osteosarcoma and in neurosarcoma patients, probably more than 90%. So thank you for your attention. I hope you enjoyed that case, and I look forward to a vivid and extensive discussion. Thank you, and best greetings from Germany.
Thank you, Professor Lillenquist. That was a brilliant case and very exciting one as well. I think we can take some questions on this case, and any questions from the panelists. Dr. Rajshekharan, Dr. Venkatesh, Dr. Gautam.
Ulf, may I ask you? So one of the critical points in this case is that you decided to take out the two vertebral bodies. Why did you not decide for a split? If I look at the first MRI, I would say that might have been possible as well.
It's just to be. I take that point very well, and I discussed that with my partners. But the thing was to be as safe as possible in terms of margins, in terms of neurology, because if you have to split that third of the vertebral body, you have to quite mobilize the spinal cord up there in the upper thoracic spine. And number three, how do you make sure that you end up with a resection appropriate and doesn't endanger the aorta in the anterior part? So since there was hardly any soft tissue involvement of the vertebral body, it was quite easy to take down those two vertebral bodies. And at the end, I am very happy that I took that decision. I believe this was the best way to solve this problem. I'm not saying that the other way around it might have been possible too, but in my hands, I thought that's the best option.
There's a question from Dr. Jaiswal. Professor Jaiswal, please. And then Dr. Marcus.
Actually, I was going to ask the same question. Why did you sacrifice the other part of the vertebra? The next question was when you release the opposite side, the non-tumor side of the vertebral body, do you release it from the ribs or from the costo-transverse junction if that is intact?
I resect.
Number one. And number two question, do you routinely do embolization of these tumors before going in for surgery?
No. Since we stay out of the tumor, we don't need to embolize them. We do no embolization. And question number one is, this was a left-sided tumor, so you have to do all the right release on the right side from the back. So you cut the ribs close at their necks and leave the heads on the resected specimen, and then you do all the anterolateral release from the back, which is very important because when the patient's once lying on the right side, you have no chance of accessing the right side when doing an left-sided approach. So you have to do all that release from the back.
No. My question was this on the right side where the normal ribs are there. The right half of the vertebral body was all right. So do you have to sacrifice a portion of the ribs on the right side?
Yes.
Or you can get away with just doing at the costo-transverse junction?
You have to cut the ribs on the right side at their necks in order to be able to, or you can even, I'm not sure you might also just mobilize the rib head from the vertebral bodies. That might be another option. But anyway, you have to disengage the ribs from the vertebral bodies, of course. And you do that from the posterior approach.
Yeah, thank you.
Marcus? Yes, Dr. Marcus.
Hi, Wolf. You had a perfect responding concerning the neoadjuvant therapy. If you would have known this before the resection, would you have to done the same resection? And second question would be, I haven't seen a PET CT at the first time of evaluation, because there you could have seen exactly where the active margins of the tumor would be. That might help sometimes to decide for the procedure a little bit. What do you think?
Yeah, well, thank you very much, Marcus. Question number one, yes. I mean, don't mess around with osteosarcoma patients. They have a very high mortality. We all know from the back from the former days. They all died, even though you resected the legs in these patients. So still the mortality is very high in these cases. So we go for really full surgical control and free margins. I mean, just go back to the extremities. You always would go for wide margins. Wide margins is 2 centimeters extra the capsule, which is hardly possible in the spine. So if you take the Anneking rules from the extremities and refer them to the spine, I think that was the right decision to take. And yes, we had a PET-CT. We had all pre-op workout. The patient came from one of the large university hospitals from the south of Germany with all the pre-op workup, just came for surgery to Münster.
If there are no more questions, shall we move on to the next case discussion? It's giant cell calcified thoracic disc herniation, a complicated problem. Professor Peter, please.
Chairman, ladies and gentlemen, so as a follow-up of my presentation on thoracic disc herniations, I would like now to present a challenging case where we have treated a patient with a thoracic disc herniation and not everything went as expected. And I would like to also pose some questions to the auditorium, and you can think about how you would have decided in the individual situations. So the patient that I would like to present to you is a 60-year-old male patient who presented initially not to us but to an outside institution with pain in his mid-thoracic spine and radicular pain approximately around T6. Then the patient deteriorated slowly, first developing slight weakness of his left leg and bladder dysfunction, and then he showed to have a calcified large disc herniation in the mid-thoracic area, and he presented to this outside institution in August 2019. These are the images the patient obtained at that time. It shows the large calcified disc at the mid-thoracic level at T6 and T7, which can be identified over more than one axial section. And in addition, the CT nicely shows the disc herniation, which is really centered in the midline and is of large size and is completely calcified. So it has been a very challenging case for a very severe patient presenting with a very severe neurological deficit. So the surgery was performed immediately at the same institution, and the laminectomy was performed over 2 levels. And the surgical team has performed the intraoperative neurophysiology, and immediately following the removal of the 2 lamina, the patient went into spinal shock and had a bilateral loss of the motor evoked potentials. And this was confirmed postoperatively when the patient presented with a complete motor loss in both of his legs. And unfortunately, the disc was not removed since the surgery was stopped as soon as the patient had deteriorated by a neurophysiological means. The patient first then did not recover, and he underwent intense rehabilitation and slowly showed some improvement. We saw the patient exactly 1 year later in August last year, and by that time the patient had improved and he had a paraparesis with a strength of 3 out of 5 in the left leg and 4 out of 5 in the right leg. He was able to walk a few steps with assistance, and he had also developed severe neuropathic pain, which gave him strong discomfort, especially at night in the left leg. He was able to walk a few steps on his own without assistance, and with assistance a little bit better. These were the images that we had obtained in our institution. You can appreciate the area of the laminectomy in the CT. It's a 2-level laminectomy, and you can also appreciate that the disc is still in its place. It's still the same size, the same calcification, and it's still localized in the center of the spinal canal. And now this is really a very challenging situation. The patient has severe neurological deficits, and the patient had been operated previously, and these are the 2 major determinants, or the 2 unfavorable prognostic variables for the future treatment of this patient. And this brings me to my first question to the auditorium. How would you have decided? What would you have recommended? Number one, do nothing and continue to rehabilitate because surgery might be too risky. Number two, treat the pain, which is really affecting the patient a lot with neuromodulation. Three would have been to readdress the disc herniation by a more posterolateral approach. That means come again through the same skin incision, but now more lateral approach. Four would be to readdress the disc herniation with a transthoracic approach, so a complete change of the approach and of the concept, or simply perform a posterolateral fusion without readdressing the disc. I will give you a few minutes to think about your answers and think about what you would have done.
Can I speak? Dr. Shankar.
So we decided to go for option 4. The idea was to readdress the disc through a transthoracic approach, and we performed the surgery in September of last year. We have performed the transthoracic retropleural approach with a mini thoracotomy on the left side. You can see here the intraoperative CT that we have used for our fully navigated approach. We have identified the level, we planned the extent of bony resection and the surgical strategy to push the disc fragment into the cavity that we would have created with our high-speed drill using a microscopic strategy. We have performed electrophysiological monitoring during the surgery, and everything went well. The electrophysiology was uneventful this time, but when we were mobilizing the disc into the cavity, we realized that the calcified disc was strongly adherent to the dura, and mobilizing the disc resulted in a dural perforation and CSF leak, and we directly faced the spinal cord after removal of the posterior ligament and the disc herniation. They were completely removed, the disc herniations and the posterior ligament at this level, and then we had to patch, glue, and we inserted a lumbar drain. Patient was first doing well, but 6 hours later he was developing a complete motor loss in both of his legs. He was completely paraplegic. We have performed an imaging which shows a good decompression, bony decompression, but we could identify a postoperative hemorrhage, or this was the patch that we had placed for taking care of the dural leak. So we immediately revised the patient through the same surgical approach, and postoperatively the patient was again paraplegic. The patient was admitted to the ICU. We kept the mean arterial blood pressure is 90 millimeters mercury. We performed a therapeutic transcranial magnetic stimulation in order to increase the brain plasticity, and we were lucky. The patient improved after 7 days to a acceptable level. 3 out of 5 in his right leg, 2 out of 5 in his left leg, and interestingly enough, the chronic pain had gone completely. We performed a chest X-ray, which was okay, and removed the lumbar drain. We were able to start a mobilization of the patient and treated the patient by physiotherapy, but then the patient developed a respiratory insufficiency. You can see the chest X-ray showing the effusions. He had a effusion of 1,500 mils, 1.5 liter into his chest, which was punctured and which revealed CSF. And obviously we had a CSF leak which was draining CSF into the thoracic area as a result of the dural tear. And obviously our patching was not sufficient. So what now? We have a dural tear. We have a patient that was treated surgically 2 times. Meanwhile, he 2 times deteriorated surgically. And now I would like to ask you, what would you do next? Would you repeat the chest drains and avoid the surgery? Would you reinsert the lumbar drain and avoid surgery and hope for a spontaneous closure of the CSF leak? Would you address the dural leak through the old or the most recent thoracotomy approach? Or would you address the dural leak now with a posterior approach? And then obviously the prevalent question, how about fusion? So now that we are readdressing the patient again surgically, should we now perform a fusion? Since we have removed quite a lot of bone, there's the laminectomy and the facet joints have been removed. So again, I would like to give you a few seconds to think about your answer. So we felt that the fusion would be indicated, and the idea about the fusion was really driving our approach. So since we were thinking about fusion, we opted for the posterior approach, and the idea was to close the dural leak coming from a posterior approach and opening the dura and taking a transdural approach, as I've shown you, as it has been described, for removing some of these discs. So we went for a transdural approach. We opened the posterior dura, we cut the dentate ligament, we rotated the spinal cord, and then we sutured the dural leak, and we patched the dural leak using an inside-out approach. So midline approach, removal of the epidural scar, handling of the dura and of the spinal cord. We could confirm that there was no mass effect by our muscle patch. We closed the holes, and interestingly enough, we identified a second hole, which was only due to the transdural approach. We could suture both of these holes, and then we placed the pedicle screws and we performed a posterolateral fusion. These are the postoperative controls, the X-ray and the intraoperative CT, pedicle screws in place. You can again appreciate the extent of bony resection and the removal of the calcified disc. The postoperative course was hard. There was no CSF leak anymore. That was the good news. However, the neurological deficits were initially unchanged. There was no pain, and we could discharge the patient to rehabilitation, where he continued to improve. Meanwhile, he's able to walk with some assistance, but longer distances, so he is clearly making significant progress, and his thoracic imaging shows that there is no CSF leak and that the closure of the dural leak has been successful. So looking back on the course of this patient, a critical analysis of this case would number one, in our eyes, show that the transthoracic approach was appropriate. I think it was important to change our approach and to remove this disc herniation, not through a posterior, but through a transthoracic approach. The transdural approach, however, showed to be very sufficient for exploring the dura, and we have learned from this that the transdural approach is not only ideal for removing soft discs, but also taking care of CSF leaks or perforations of the dura as a consequence of lateral approaches. We always believed that the fusion was mandatory, but we were waiting whether we would have to come back in order to take care of the dura. But critically, we have to admit that the dural hole should have been addressed immediately. By losing the CSF and by losing this kind of buffer, we believe that the spinal cord was prone to additional injury. And as a lesson learned from this case, we would now consider taking care of the CSF leak immediately, because the CSF leak is obviously a risk factor for myelopathy and for neurological aggravation, and therefore we should have closed the transthoracic approach, changed the position of the patient, and come in from a transdural posterior approach and take care of the dura immediately, and maybe this would have avoided the initial decline following our transthoracic approach. Thank you very much for your attention.
Thank you, Dr. Peter.
Shankar, can I make a comment?
Yeah, sure.
Peter, this was a fantastic case. In true perspective, the issues with thoracic discs, and of course, the posterior approaches of decompression are definitely contraindicated. My question is, as we do for cervical myelopathy nowadays, we don't go to remove the entire bone in the front, but deliver it into the decompress indirectly by delivering it towards the front, would that be an option rather than try to remove that calcific fragment, just deliver it anteriorly and leave it there?
You mean to say a floating piece?
Yes.
That's an interesting point, because I mean, what you do is you create the cavity as I've shown, and then you deliver the disc and the calcified posterior ligament into this defect. And now you are asking whether it makes a difference to pull it out or to leave it there. In the end, it's a loose fragment, and I would be maybe afraid that it might jump back or might dislocate from there. And I don't really see a disadvantage of removing it. So also from a lateral aspect, different from the anterior aspect in cervical disc surgery, it's always a little bit difficult to assess whether you have a complete decompression of the spinal cord. So while I'm thinking about your suggestion, I would go rather for the conservative way and remove it. But I think the idea that you are saying to leave it there is something I should think about in the future, yes.
Dr. Peter, there's a question from the audience from Dr. Khitish Chaudhary, which says that if you use non-invasive positive pressure ventilation in CSF leaks which have gone into the chest, the CSF leak apparently resolves on its own. What's your views about that?
Well, the patient was spontaneously breathing, so it's...
But we give a BiPAP or a CPAP, and apparently with the CSF leaks do close over a period of time if you continue with this BiPAP or CPAP for at least 4 days.
I see. You mean a non-invasive increase in pressure. Okay. Yeah, but for the first 7 days he was doing fine. So we would have expected that that by trying again on a conservative way. So number one, we would have expected by trying in a conservative way, it would not close after 7 days. Maybe the patch has dislodged and the dura leaks open because there was nothing. The problem is you remove the bone and there's nothing that holds your graft in place. Number two is we anyways thought that we will have to come back for fusion. So we were quite open for readdressing the dural leak from a posterior approach. And number three is that we found a second hole, which we had not patched. And I don't really see that this would close spontaneously just by changing the pressure. And then obviously it's difficult for managing the patient that was a little bit adipose and a little bit impatient with his situation.
Superb case.
Shankar, I think Dr. Srivastav has a question.
Yes, Dr. Srivastav.
No, I just wanted to say all this calcified or ossified disc, which is central, we have been doing regularly from posterior side. Not a big number, but we have been doing the internal gibbectomy. The similar way, I have taken out these calcified discs by tilting the table, taking out the part of the rib, going posterolateral acute angle, burying out the body and taking out the thing. But of course, from the beginning, we have been fixing and fusing that level. And that is the reason I asked question in his last presentation, why did not you fix and fuse that level?
Yeah. So from literature that I've shown you, the lateral or posterolateral approaches are also successful with a acceptable morbidity. We feel they are more invasive, and we are more familiar, or we prefer the transthoracic minimally invasive approach. Given that this patient needed fusion because his facet joints had been removed, I would agree to you that maybe this kind of approach would have had his advantages. However, we felt that the disc is huge. The patient had neurological injury before, so we wanted to go the safe way. And I feel the safest way is coming from a retropleural approach. But your point is well taken, given the whole story of this specific patient.
Thank you, Dr. Peter, for that wonderful case, which evokes so much responses. Our timekeepers, Dr. Dillon, says that we are 7 minutes late, and I request Ram to invite our speakers next.
Thank you. Thank you so much, Shankar. It's been a pleasure. The first two cases by Professor Lillingquist with whom, just like Shankar, I also visited his center about 2 decades back at Munster, and it was a great pleasure being with him. And Professor Peter Walkowski, it's been a great pleasure listening to these very challenging situations. One of a kind, we've learned a lot. And we now have 2 Indian experiences, both from the city of Chennai in southern India. May I first invite Dr. Karthik Kailash, a senior spine surgeon from Chennai, to share his experience on post-traumatic, post-surgical thoracolumbar kyphosis. Dr. Karthik Kailash, may we please see your slides?
Karthik, are you there?
Yeah, I'm very much here. Please share your screen. Lovely. That's great. Full screen. Thank you so much.
Okay, thank you, the outset, to give me an opportunity, and thanks to interact with Wolf and all the people here. Now, this is a very interesting thing here. And 13-year-old girl with a history of fall from the first floor many years ago sustained this injury. And of course, I don't think there's going to be a debate on whether we have to do anything for this. We have to operate. So one of my colleagues, unfortunately, decided that he's going to do this procedure. Okay? Now, what would be your comments? Can I ask some comments and then 1 or 2 and then go on, or should I just finish off with that? Shankar, Ram? Shankar, Ram, could I ask?
Yes, if there are some instant answers, we could take a comment. But
yeah.
Obviously, yeah.
So this is what somebody has done. One of my colleagues done at that point of time. So what is the next thing which somebody would like to do for this?
I think Sergeant wants to say something. Sergeant, can you unmute yourself?
We have moved a long way from these kind of fixations and all that. So there's no point in beating the same old drum. I think, of course, you would. Now, what is the problem that the child has, now maybe a woman, what she come for?
Well, I will come to that in a few minutes. She's got severe pain in the back.
Well, that is evident. So she is mainly having pain of instability.
Right.
So then things are very straightforward, I would think.
Fair enough. So we will all look at in terms of revising this and going posterior. Now, my friend decided that he's going to do something different. So this is what somebody has done. And unfortunately, as Gautam would describe in some meetings, surgical terrorism. So this was done, and this poor patient was led to follow up, saying everything will be all right, and finally landed up on the middle picture with a deformity, with implants both anteriorly and posteriorly, severe pain and kyphosis, not able to even sit properly. So what are the options now?
Karthik, the options are the same. Only thing is, it is more of a challenge. The options are the same that need to be done to correct the deformity from the front and back. But what has been done, you're right in calling it surgical terrorism.
Okay. So without much ado then, as Sergeant very rightly said, our aim would be to get sagittal balance, solid arthrodesis, and to revise the whole thing. So our technique was go in posterior. It's a 3-stage procedure. Go in posterior, remove the heart-shield rectangle, the wires, do an osteotomy, pedicle screw insertion, and then go ahead, do an anterior. The difficulty in the anterior was because the cervical plate was put in, the whole thing had bent in, and the L1 and L2 was one on top of the other, and the visualization itself was not there. So we had to do an osteotomy there and a correction there, and then go back in and do a posterior corrective surgery and complete the osteotomy from behind in a 3-stage procedure, all done in one single sitting. The final result, immediate post-op, where you could see that some reasonable balance has been obtained. And now to my pleasant surprise, this girl is now working in the World Bank as an IT person. She came back about 15 years post-op. The show she's completely fused, no pain, and she is now wheelchair to ambulant with HKFO gaiters, etc. So with this, I would look at some comments from my colleagues, and I wish to say well done ASSICON with this video as they demonstrated this wonderful teamwork.
Salute Bourbon.
Well done to our team. Thank you very much.
Thank you, Karthik. That's an excellent presentation. Now we are open for discussion. Any comments, Sergeant, first from you, because you have already had a first bite at the bullet. Go ahead.
What do you want me to say, Ram?
Okay. Then we have Shankar. Any comments?
I don't want to say too much.
You're on air.
I don't want to say too much.
Yeah, I think this case was, as both Karthik and Sergeant said, is surgical terrorism. Everything, all these principles were violated. But obviously, this case was done many years ago and long time ago when we were doing heart shield for spinal fractures. Obviously, the principles of heart seals were not also adhered to, and you need multi-level fixation when you do sublaminar wiring, and you need to get surgical reduction. So obviously, all the principles were violated. And then somebody put a H plate or some sort of a 3.5 plate system anteriorly with multiple small 3.5 screws. So that obviously also was a failure in toto. And I think let's not discuss too much about the surgery that was done, but obviously I think Karthik did a good salvage procedure, and I'm glad to know that she is now wheelchair to and she's able to mobilize with gaiters.
If there are no more comments, maybe move on to the next case, or would the faculty like to say something on this case?
So can I make a small comment, Dr. Ram?
Please, Dr. Basu, please.
So was it an option, Karthik, very well done, but was it an option not to go anteriorly and do it entirely posteriorly? Because I feel that these 3.5 millimeter Casper plate, whatever was put on, did not have any hold on the bones. So if you approach it from the back like a VCR approach, go in bipedicularly, take out both pedicles and do an osteotomy from the back as is done for kyphosis correction, for rigid kyphosis correction, would it could you have solved the entire issue posteriorly? Was removal of the anterior implants necessary?
Well, I see the L1 was completely under the L2, and I couldn't even visualize it anteriorly. And so it made things much more difficult even then. So I think going posteriorly, and then this is way back in 2001, when osteotomies and all that were not very proficient. So I was not very proficient in that part of it. And then I think, for me, in my hands, I thought going anterior, taking the whole thing out and doing it at 3-stage was a better choice for me.
At the end of the day, the deformity was not very sort of radically corrected, neither was it necessary. So if you could just leave just did an in situ up-down fusion, strong posterolateral fusion, would it have solved the issue? Just take out the posterior implants, go long up, long down, do a very well posterolateral spinal fusion. Could you not do a laminectomy also? That would have stabilized her, and maybe that the fusion would have occurred.
I don't know. I mean, this is a thought process which we went through. Maybe if I had the same case now, I'd have gone all posterior or something different. So
I think there is something that is your answer, there is something that is my answer,
yes,
and there is something which is a correct answer, which is somewhere in between. So we all learn from each other. So thank you very much, Karthik, for an excellent presentation. Maybe move ahead
from the German delegation as to how they would deal with it at this stage, not at the earlier stage. Whatever is done is done.
Would Professor Lillenquist and the entire German team have any comments, sir? Wolf, any comments from you? Marcus, Peter?
Well, I think, do you hear me?
Yes, loud and clear. Please go ahead.
Yeah, well, I think everything has been said, actually. Now, the first, there was no reduction. There was, not implication of the biomechanics of the spine, of the biomechanics of fixation. I think it's a very good case to see how you won't achieve your goals concerning reduction and stabilization. So very good case. Thank you for presentation.
Thank you, guys. Thank you for being very polite. Thank you very much. We appreciate. So we would now invite the most polite spine surgeon from our country, Dr. Sarjan Hegde, who's the most aggressive as far as deformities are concerned. And I'll invite Sarjan to speak on spinal deformity. Is it time to turn the page on tradition?
Ram,
Sarjan, all yours.
Ram, in this, I want to say I am being very much less aggressive than my normal behavior. And I want to put a new concept. So I'm going to take a little liberty, show 3 cases, but quickly, and stick to the time and make like a small presentation. So
all yours, Sergeant. Please go ahead.
So the question I'm asking is it time to turn the page on tradition? Okay, how do we... So for the last 100 years, we have been fusing the spine for instability and deformity. And for the last over 60 years, we have added metal implants to hold the spine in the corrected position till it fuses. Of course, we know that the gold standard was the Harrington for a long time. But since the 90s, there has been an aggressive move to favor posterior surgery and is accepted as standard of care, like, for example, in this Lenke 5CN, where you see there is some degree of flexibility. And this is what I want to use, the term regional iatrogenic ankylosis for a shorter or a longer area of the spine has given extremely predictable results for us. Now, an old fogey like me, Arvind is also there. For a surgeon like me, the early years spent in aggressive management of tuberculosis of the spine laid the foundation for a high level of comfort with anterior spine surgery. And we were able to use that technique for our tubercular spines and put grafts and later on implants. As we are now with the German Society, I would like to thank my mentor, Professor Jürgen Harms, who trained me on anterior correction of deformed spine and its advantages. So I continued to use this technique right for a problem like this boy from Nigeria with a Lenke 4CN. Here you can see that the spine is very severely deformed, 86 degrees, the main deformity, and a counter curve above as well as a counter curve below. Now, posterior surgery would have meant D2 to L4, thoracoplasty, PSOs, blood loss over 1,500 ml. However, we have done a correction of the main thoracic deformity and let the lumbar spine correct spontaneously as well as the upper thoracic spine. So I continue to prefer using this despite an almost exclusive shift to posterior surgery in most centers. And here I come to these deformities like the Lenke 5CN, which to me today, doing a standard posterior fusion surgery, or for this one on the right side, a double curve, doesn't seem to be a very acceptable or satisfactory option. So here I want to talk about non-fusion anterior scoliosis surgery. Let me introduce a new technique which I think will turn the page on fossilized concepts. That is using a polyethylene terephthalate cord which is threaded through vertebral screws. The concept is not new. We used to do it when we were fusing the spine. So let us come to this child, 13-year-old, perimenarchal, Risser 0, Sanders 4. So in this child, do we just wait till she completes her growth and our deformity measures 60 or 70 degrees and then correct it with some degree of chest deformation? Do we brace her, or do we instrument her posteriorly straight away from L3 to D4? So this is an out-of-the-box non-fusion surgery which has been done. As you can see, some of the residual deformity still persists, and that is intentional. And at 2 years, you can see her spine is beautifully corrected, fully corrected through growth modulation. And as you can see on the right side, she has a beautiful position of her spine, a beautiful correction, and she looks very good. Now, this is a child we operated yesterday. I still don't have the images. Normally one would have done a D5, L5 to D2 instrumentation with the possible blood loss of 600 to 1,500 ml, or minimal invasive non-fusion correction, as you see here on the right, which we did yesterday, with a blood loss of less than 100 ml, and she can return to dancing, gymnastics, equestrian sports, as some of my patients have done after non-fusion surgery. And finally, to end, this little child who came to us from the Middle East, a 7.5-year-old child with a severe congenital deformity. Here you can see she has multiple congenital anomalies. The Cobb's angle of the thoracic spine is already 64 degrees. These are the CT scans showing the hemivertebrae at multiple levels. In 2019, just before corrective surgery, she was already severely decompensated. And an artist predicted that if left untreated in a couple of years, she would look like what she looks on the right side. What are the treatment options for her? Do we brace her? Do we serially cast her? Do we put growth rods with all the issues of visits, multiple visits to the OR, planned and unplanned, or do we do something out of the box? And we decided to just modulate her growth in the most deformed part of the spine. Here you see her pre-op and immediately post-op. Imagine this child was operated just before the pandemic. If I had put growth rods, they wouldn't have been able to come for a year, and it would have been a disaster. The parents managed to send me a picture at a recent follow-up, 9 months, and you can see she's holding well. I'm not saying this is the end of the road for her. She may require surgery for the proximal spine, but maybe just one more surgery. For the moment, she seems very well balanced. Shoulders are balanced, and she seems to hold the correction well. Now, when we talk about adolescent idiopathic scoliosis, I think we'll have to move away from the Lenke classification. And here, maybe we will have a different classification as non-fusion scoliosis correction becomes more and more popular. I know in Germany, it is very, very popular. So the lumbar, thoracolumbar curves, the double curves, the long curves with a trunk shift, that's the ones that you may not want to do is those having a high thoracic curve. So maybe we'll have to have a different classification and maybe look at using this very new technique, exciting technique to correct our spinal deformities. But these are early days. The short-term results are extremely satisfactory. Of course, there can be a cord rupture, but the cord rupture can be addressed. For example, in the lumbar spine, we can do a double cord, which makes it a fairly expensive surgery. Alternatively, even if the cord ruptures, as Ahmed Alane from Turkey said, you may not need to revise. Unlike broken rods, which cause pain, a cord rupture may just add to the deformity, but may not need revision. Thank you.
Thank you very much, Sarjan. It's an evolving concept. And as you mentioned, Germany probably has embraced it. So we have the German Spine Society with us. Any inputs on Dr. Hegede's presentation?
I might comment on that.
Please, sir.
Well, thank you very much for highlighting the role of anterior approaches in deformity surgery. You're aware we have the Klaus Zielke, was one of our teachers from our country. So I absolutely agree with you that there is a definite role of anterior surgery, especially in the thoracolumbar region, where you can frequently save vital fusion levels, especially in many cases from the back, you would have to go down to L4, and if you stay in the front, you can end with L3. Now, concerning this new technology of cords, well, we're on the very early phase. I would say it's still somewhat experimental. For the thoracolumbar region, I would be afraid of cord rupture and the curve sizes. In Germany, we have a long tradition of bracing. So those patients where in other countries, maybe a surgery might be an option, we would go for a brace. But we're watching those results very carefully, and of course, it would be great if it works to have a growth modulation and keep the mobility and go away from fusion. So thank you very much for your very wonderful talk and inspirations.
Thank you, Lundquist.
Any other comments?
When you were working with our good friend, the tall guy, what is his name?
Henry.
Henry
was the last fellow of Klaus Zielke.
Yes, of course. It's a small world. Yes.
In fact, Lillenquist devised the smaller mini plate, and I remember that.
Yes,
that's when we were together. I remember that.
Yes, we have a long tradition of anterior surgery. Yeah. But in the thoracic spine, to be honest, I've more or less stopped doing anterior surgery, but I still do all the thoracolumbar cases. And every time I do from the front, it's always nice to see how well the correction goes.
Absolutely. Any other comments on Dr. Hegede's presentation? Dr. Jaiswal, please. Yep.
Sarjan has always a great presentation. I have a few doubts here, as I expressed earlier to you also. When the anterior tethers came into existence, they were not so defined as they are now. Harry Bess and Samdani's report. They were doing it for very early onset scoliosis. The type of indication that you use for your middle-aged girl, young, 4 or 5 years old, they had a lot of failure there because have a long span of growth left, So there were a lot of failures there, overgrowth and failures of tethers and things like that.
Sure.
So I think you did a great job initially to start with 12-year and 11-year, where the growth potential is less there. So you can wide time. So the results which are coming in with the newer tethers and the cords are for the slightly older adolescent groups, right? And so the results are really good. So we need to watch and see what, number one, the results are going to be. As you rightly said, these are short-term results are very satisfactory. I'd be a bit conservative with putting them on right away in very young, like early onset scoliosis, 4 and 5 year old, because they might land up into more problems there.
Any other comments? Dr. Hegde, any response?
No, I fully agree with Arvind. I fully concur with his feedback. But I look at it, for example, that child from the Middle East, what were my options? Doing a growth rod, requiring every 6 months a reoperation. The child has such small bones, such poorly formed bones proximally. The construct could always keep giving way. Also, we have seen a kyphosis developing above the level when we use the growth rod. I have seen it personally. And all these things, issues that I faced with growth rods, made me look at this option. But as Arvind says, these are early days. Some of us will have to come out clearly and tell where we should not use it or where we can use it and definitely give good results.
No, that's fine. You did a great job. I'm not criticizing that. But the question is, we need to have more evidence on this. And be careful. Watch this very young child, the 5-year-old girl, as you go along, because revision of the cord would be difficult anteriorly when you go in again. Number one, and number two, if it fails at 7-8 years of age and it's progressing, then you'd be a bit reluctant to go ahead and fuse from the back. So keep your fingers crossed. Watch her very, very, very observantly. Thank you.
Which we are doing.
I think with that, Ram, we can close this session.
Absolutely.
And if I may have, and I thank all the speakers from the German Spine Society, and I thank the German Spine Society for, as Dr. Frank Kanziro said, that all the top-notch lines, as the presidents, the past president and the future president and the president-elect are there. And it's a privilege for us really to be honored by your presence and that you have taken so much of your valuable time and we have learned so much. And it's always good to see Professor Lillenquist, with whom I trained 2 decades ago, as Ram said. I know he won't remember me, but I have fond memories of Munster, the cycle town. And I still remember he said, one day I take you out for dinner. I thought he will come out with a BMW. He took out his cycle and made me walk to the restaurant. So that is an amazing city. And thank you very much. With that, we can close this session if Gautam says so. Yeah, thank you. And we go on to the next session. And I can welcome, I still invite the German surgeons and the German faculty to stay on for our next surgeon, which is spine surgery, navigating the future. And I request Dr. Chabra, Dr. Sarjan, and myself who are there. Dr. Chabra is there? He's not there. So shall we go ahead? And I can see Dr. Andrea Luca there already. I just saw him.
Yes, thank you very much. I'm here.
Okay. So you have a great talk. I think virtual reality, augmented reality, and 3D are all coming in. And your first talk is virtual reality for remote education and future of augmented reality in medical care. If it's okay, we will start straight. Go ahead with your presentation.
For me, it's perfect. Can you see the video?
Slideshow you need to go on to, I think. Yes, we can see you, but you need to put it onto the slideshow.
Can you see the slides now?
Yeah.
Okay, sorry.
Yes.
I was not prepared for that. Okay. And good afternoon, everybody. Thank you very much for the invitation. My name is Andrea Luca, and I work in Milano in the Galeazzi Hospital. It's a privilege to be here today. First of all, please let me thank the chairman who allowed me to stand even if only virtually in this exceptional context. First of all, I have to disclose my position as co-founder and chief medical officer of a small startup named Hypersurgery. In this brief presentation, we are going to talk about 2 technologies, virtual reality and augmented reality, and their application in the educational program that we are running and their use in the daily clinical practice. We would also like to share our thoughts with you regarding the application of this technology in different contexts and environments. And in fact, our aim is to make those technologies affordable, interactive, and democratic, fulfilling the advocatic principle of inclusiveness and equality that allows us to break all the socioeconomic, cultural, and geographical barriers. The acronym of the program we launched is not by chance AID. Beyond the specific technical aspects that make each computer technology more efficient for specific tasks, such as training or direct clinical application, they are all closely linked, and their integration is, as usually happens with technologies, produce further improvement of the global system. This technology also offers the possibility to instantly create accurate and measurable outcomes. And this allows us to generate, and it will do more in the future, a critical mass of data, which will feed what is nowadays the superstar among all the technologies, that is the artificial intelligence, of course. Regarding specifically the VR, our hypothesis is that virtual reality can positively impact on the healthcare professional providers' performance through the improvement of their skill and knowledge that are known to be two main determinants of competence. For this reason, we built a VR training program based on the Dreyfus model of skill acquisition. Each level has its own specific pattern, thus allowing to tailor the training to the pre-existing level of expertise of the user. For example, an advanced beginner, users are primarily taught to follow a specific workflow, applying it to clinical situation, and so will do the simulator. For competent users, the simulation provides a free-run procedures without any interference. The possibility to measure the final outcome and potentially identify the mistakes made during the presentation by the effect they produced enhance the skill transfer, according to us. And this is what we call learning from mistakes. In our experience, this is the closest way to learning in the real clinical setting. In this short video, you can see the simulation of the well-known surgical procedures, the X-lift procedures. The user is, in this case, an advanced beginner. First of all, has to prepare the OR according to a specific pattern. The user has to move the object in the room, to correctly position the patient, and to select the appropriate X-rays projection. Once all those steps are accomplished, the evaluation form will be displayed. And then, once the OR setting has been correctly performed, the user will access the surgical approach. We built an immersive environment with all the feedback that you can experience in a real OR. In this case, the approach is guided, and potential mistakes with their explanation are shown. The simulator will provide tricks and hints. For competent users, we planned a free-run procedures without interference. For proficient users, the simulator will randomly generate unexpected situations such as intraoperative complication or anatomic variants. We tested our simulator on our residents, and the results have been recently published, showing encouraging perspective for this technology. We believe that this technology may be attractive for educational providers such as the European Spine Society and institutions with high educational vocation like our center, Istituto Ortopedico Galeazzi, which welcomes students, residents or specialists for basic or advanced training program. But the mission of the AID campaign we launched is to make this technology available also for peripheral centers which may benefit from its educational program to ensure a quality standard for the healthcare providers. For this reason, we developed a smart suit, VR suit. The equipment is quite affordable and it's not necessary to have a large of permanent dedicated areas for the training session. In the video, I'm running the procedures at home, and it's a kidney biopsy, by the way. The simulation is preloaded in the workstation, and virtually you don't even need an internet connection to start the training session. Finally, we have foreseen the possibility to run the training session with multiple participants, even in remote modality. In this test that we ran a few months ago, the developer and I were performing a training session simultaneously from 2 different places in Italy. In the simulation, as you can see, we were both working on the same virtual room, on the same procedures, sharing the surgical tools. In conclusion, VR allows us to efficiently transfer competence through an immersive and engaging experience, simulating ordinary conditions, but more importantly, even extraordinary situations such as complication. The possibility to analyze data, the outcome to build predictive models is still under evaluation. Other pros are that this approach is affordable and, if needed, it can be remotely run. In addition, this training program respects the highest ethical standards, being cruelty-free and avoiding the sacrifice of animals as happens for live tissue training. Regarding the drawbacks, for sure, to develop a single procedure is a long process and requires high professional profiles. We did not experience motion sickness, and the haptic feedback still do not allow a full sensorial immersion in the procedures. Let's move to the second subject of this presentation, the augmented reality. Its popularity in medicine is constantly growing, as this PubMed research clearly shows. One of the potential applications, definitely very close at hand, is to redesign the medical environment, reducing, for example, the OR equipment. The surgeons may recall the patient information, including imaging, CT, MRI, in sterile fashion by voice control or gestures. In the near future, the process of redesigning the OR might go further to the point that not even the patient will be in the OR. This is in the case of telemedicine and telesurgery, with the possibility to remotely co-act with multiple operators simultaneously. We are testing its use in the spinal navigation, and several studies reported the use of AR to identify and more accurately resect tumors. And also this, according to us, sounds very attractive. In our opinion, this technology may be prerogative of Center of Excellence, which routinely deal with highly complex procedures with multiple different professional profiles might be involved in the procedures. To be honest, according to us, there is less room for its application in peripheral centers because of its costs and the need of stable and high-speed connectivity. It may replace the current tool used for telemedicine. This technology allows us to have simultaneous access to the medical procedures by multiple specialists. The hands-free control is particularly helpful in critical situations such as the operation room or COVID-positive patient department. Once again, this technology allows us to store data that can be thereafter analyzed and manipulated. On the other hand, the devices currently on the market are still somehow primitive, and the technology itself has substantial costs that might hinder its diffusion. In conclusion, a scientific approach to study the application of new technology in the medical field is necessary, both to test their real efficacy in our daily practice and to ensure the highest safety standard for the patient. Diligent scientific research approved by deputy ethical committees should be encouraged to answer the many questions still pending regarding the potentiality of this technology. An additional effort, according to us, should be made both from the scientific and political communities to ensure a wide diffusion of this technology, even in remote or peripheral areas. To make this possible, the technology should be affordable, ready to use, suitable for different socio-economic contexts. And this is exactly the philosophy behind our project that leads to a smart VR suit. It can be installed virtually in any place, allowing high standard and measurable transfer of competence, enhanced by the possibility to remotely connect specialists. Aiming for this purpose, we call upon academic institutions, public or private organizations to join us in the challenging project to make this technology available to everyone. Thank you very much for your attention.
We can take any questions for Dr. Andrea Luca.
Thank you very much.
Hello. Thank you. So, Dr. Luca, we have a capacity building program where we are trying to take up centers and with the help of mentors, have them upgrade their capacity and clinical skills. So in this era of the pandemic, I believe this would play a big role, right? So do you suggest this could be useful in also intraoperative surgical monitoring also?
That's a good question. I think at the moment the augmented reality technology is, as I said, is a little bit primitive. The device is not the best solution for its use in directly in the OR, even regarding the certification. But for sure, it will change very fast in the future. We will have better devices, the one the military use, for example. So I think very soon on the market there will be augmented reality. But we are focusing mainly on the training of the surgeons. And that's why I think this is a very powerful tool that allows to give something more to our residents and to the young surgeon, even to experienced surgeon, because we can create complications, we can create new scenarios that actually you cannot find in any of the educational platforms that are already available.
So there's another question. What is the actual difference between augmented, virtual, and mixed reality?
Actually, this is, I think they are all computer-based technology. Virtual reality allows us to create a new world, create a new environment in which you can have different sensorial feedback. And this is what we think is the best for the training. Augmented reality in the technology give you more feedback from the reality. So you can, I think all of you knows Google Glass. It was in the past very, very popularized. You can see your environment, but receiving more feedbacks from the computer. And this is so you can see the reality with is exactly the more of this technology working together to give different patterns. But I think it should be clear what is goal for, according to me, for clinical application. I think augmented reality will suit better. For training, I think virtual reality is the best solution because you can create exactly what you want your user to learn.
Dr. Andrea, can I ask you something?
Please.
I last in the Global Spine Conference, I heard a couple of lectures, and there was Dr. Goel who was saying that they compared cadaveric training versus virtual reality training. And they found that the learning curve post-cadaveric training was longer and people made more errors than on the virtual reality training, because you could in real time do the virtual reality training multiple times and get more accurate than you would do on a cadaver, and you never got that feel. What do you have to say on that?
Thank you very much for the question. It's great, I think, this comment. And please let me invite all of you to join us in this project. We are trying to build a big library of the virtual reality procedures. It's exactly the same. We have several advantages using VR training program. First of all, you can repeat all the time, 7 days, 24 hours, 7 days, the training. So you can access the training whenever you want, wherever you want to actually. You can do even at home if you have the workstation. But I think it's uncomparable the benefits, this is my personal opinion, with cadaveric, against cadaveric training, because you can not only do the procedures, let's say put the pedicle screws, but you can learn why you should do this, the setting to be the best setting to do that, the procedures, and then you can do the procedures, but you can simulate also the complication and trying to overcome the complication and or unexpected situation. When we do a cadaver lab of scoliosis, this is what happened to me actually. I couldn't have a scoliotic deformities cadaveric spine to do that. So I put screws, pedicle screws on a straight spine. On virtual reality, you can simulate exactly the type of anatomic condition that you require to do that presentation. So I think the benefit of virtual reality are several comparing with the cadaveric. Nevertheless, we have also to consider that many times the quality of the material that you use, the cadaver, is not good enough to allow you to have a good training.
Thank you very much. I have one small more question is, do you think people younger are able to pick up these technologies better than people older are more disabled in that, or somebody like me would take more time than somebody like...
This is a great question. We investigated in our paper, we investigated this aspect because we had junior residents and we have senior surgeons doing the same. What took more was we developed a demo, a tutoring before, virtual reality tutoring. So after that, it was comparable the time needed from a senior surgeon versus young surgeons to do the procedure. So I would say no, the age or the ability to use technology is not affecting at all the virtual training. We are safe.
So another question, Dr. Andrea Luca. Do you think the virtual reality has a definite role to play in the rehabilitation of the patients?
This is another interesting option. We are testing this. I think we are using on, for example, for low back pain, we are using the virtual reality training program. I think in this case we should more take care about the one of the complications of one of the problems that you can have with virtual reality, that is motion sickness. This is something that we are studying to be avoided in the rehab patients, but I think it's going on. So even for paraplegic patient, we are building this VR room with quiet environment, and I think it could be good. The only problem might be the proprioceptive feedback, that it's not the same with virtual reality and reality. But we are testing this.
Thank you. One more last question, Professor Andrea, is that we, ASSI has a membership list of 2,772 members, a large organization. So before all of us get exposed to it, are there any video games we can play to make ourselves better in training ourselves? Because my youngsters tell me, you don't do any video games, you're not good in your phone, and you take so long to type a WhatsApp message.
No,
do you think there are any video games, or you can tell us some tricks or tips?
Actually, I was formerly a video gamer. I still do a little bit with my children, and I think the best way, if you want to really, and this is how I started. It's available on the market. A lot of not expensive VR suits. You can buy one of these and try some very easy video games. That is a Saber, for example, or there are a lot of the Eagle Eyes, and you fly with the VR. And if you don't get motion sickness, because in this video game you can have motion sickness, you will enjoy it very much. I'm doing dinosaurs environment with my children, and it's very funny. So if you want to be a good father with your children, you can play with this dinosaurs game as well.
I think, thank you, Dr. Andrea Luca. We know you have a flight to catch, and we had to reschedule this session for some logistical reasons, and all of you cooperated with us.
Thank you for your answer.
For joining us, taking questions, and we would wish you a safe flight.
Thank you very much, and please join us in the project. I think we will do a good job. Thank you very much for the invitation. It was my privilege. Thank you.
Definitely. I think we have Dr. Alok Sharan here. He will be talking on, will daycare spine centers take precedence in the future?
Hello, my name is Alok Sharan. I am an orthopedic spine surgeon in New York, New Jersey, and I am the Director of Spine and Orthopedics at NJ Spine and Wellness. I am truly honored to speak today about this topic: will daycare spine centers take precedence in the future? We have seen tremendous advancements in outpatient spine surgery here in the United States, and I know in India there have been a lot of advancements leading to outpatient spine surgery as well. So the first question is, will daycare spine centers take precedence in the future? I would argue that the answer is, it already is. We've already seen that many orthopedic procedures like knee replacements and hip replacements, which are commonly performed in the hospital, are routinely being performed on an outpatient basis in ambulatory surgery centers. With spine surgery, we have been seeing over the past decade a trend leading to more and more outpatient spine surgeries. Here's a paper that was published a few years back that looked at laminectomies and ACDFs. The line in red is showing how many of these procedures are being done on an outpatient basis. The lines in blue are showing the transition from the hospital out towards the outpatient arena. So you can see how there's been a decrease in the number of these cases that are being done in the hospital and an increase in the number of these cases being done in an ambulatory surgery center. Where this hasn't really changed much is with lumbar fusions. In blue, again, are the number of cases being done in the hospital. Red and green are the cases being done on an outpatient basis. So there's still a gap over here. But as I mentioned earlier, the outpatient spine surgery has seen tremendous advancements in the last decade. Many surgeries which were routinely performed in the hospital are now being performed on an outpatient basis. This is because there have been tremendous enablers of outpatient spine surgery. Number one, of course, has been the change in surgical technique. We're seeing more and more endoscopic and minimally invasive procedures being done. Of course, improvements in anesthesia protocols have made a big difference. The use of spinal anesthesia and regional blocks have enabled many of these patients to be able to go home the same day. And even more so, there's been a tremendous acceptance by patients that spine surgery can be done on an outpatient basis. And what we're seeing now in this post-COVID period is that many patients are actually demanding for the surgery to be done on an outpatient basis. So there are many enablers of outpatient spine surgery at this time. So the first question again is it safe? Should we be doing outpatient spine surgery? In this paper that was published in 2019, Dr. Del Sol and authors looked at a meta-analysis of papers and tried to understand whether or not surgeries such as ACDFs, lumbar decompressions, and fusions, are they actually safer, or do they have higher complications when they're performed on an outpatient basis? And they demonstrated very clearly in this paper that many patients who are discharged the same day have little reported risk of complications. So for the proper patient, outpatient spine surgery is safer. Is it cost effective? Well, in the United States, the cost of doing a surgery in an ambulatory surgery center is about 50% less than when it's done in a hospital. So clearly, as costs become a major issue, moving these cases towards an outpatient center will make a big difference. And so, yes, it is cost effective. But it's not always easy to do. Doing outpatient spine surgery doesn't mean that you just go from the hospital to an ambulatory surgery center. It's really important that before you start to build an outpatient spine program, that you have proper selection criteria on who can be performed on an outpatient basis. Doing outpatient spine surgery certainly requires a lot more education of the patient. They have to understand what they should be watching out for, what they should be worried about, when they should notify you. And it becomes really, really important that when you start doing outpatient spine surgery, that you have more touch points with the patient. Because if not, the patients will have surgery, and as soon as they begin to feel pain, they'll be scared, and they may even go to the emergency room, which really defeats the purpose of outpatient spine surgery. So one of the major challenges of outpatient spine surgery is having more touch points with the patient. Question then is, how do you establish an outpatient or day surgery program? Well, for us, there's been a tremendous development of surgical protocols. I perform a lot of my surgery using minimally invasive techniques and some procedures using endoscopic techniques. As many of you know, we have been performing a lot of our spine surgery awake using both spinal and regional anesthesia. So anesthesia protocols is really critical. And I think it's really important when establishing a day surgery program that you have good preoperative and postoperative coordination. It's important to have a coordinator who can do proper preoperative teaching, and perhaps the same individual can postoperatively have multiple touch points with the patient so that you can have the ability to remotely monitor these patients. Otherwise, the second they begin to have pain or have a complication, they may end up going to the hospital. But is it worth it? Is it worth going through all this? I would argue that outpatient spine surgery is the next major advancement. And that if you can achieve it, it just leads to better outcomes and better satisfaction. This is a patient of mine who we just recently operated on. She had spinal stenosis. She had undergone an awake laminectomy procedure. And we had asked her to make a video of how she's feeling 3 days after surgery. And you can see here the results.
Hey, feeling good, like I should. When in circle, walk around the neighborhood. Feeling black.
So as you can see, she did very well with the surgery. And I think that was because of a combination of good surgical technique along with good anesthesia. And because of that, she did really well. So I would argue that awake spine surgery and day spine surgery is the future. And that if you're not performing outpatient spine surgery right now, I think that going forward, as long as you can follow certain principles, it can lead to greater patient satisfaction and certainly better patient outcomes. So I thank you for that. And thank you again for the invitation to speak today.
Sir, you're muted.
I think we can take some questions.
Yeah.
This is a very interesting concept.
Alok, what is the kind of anesthesia that you generally use for such patients? You're muted, Alok.
Can you hear me now?
Yeah, right.
Okay, for the laminectomies and the spinal fusions, we use spinal anesthesia, and we use isobaric spinal anesthesia. There are two types of anesthesia you can give by spinal. One is isobaric and one is hyper. So we use isobaric spinal anesthesia. In addition, we performed a regional block called a TLIP block, TLIP. I'm giving a talk later today, my time, I think it's tomorrow for you, where we go through how to perform the TLIP block. So it's isobaric spinal anesthesia, and we use the TLIP block, TLIP.
Alok, Gautam Zaveri here.
Hi, Gautam.
Hi, Alok. How do you manage the challenge of postoperative pain control in patients? And number two, a lot of our postoperative patients after lumbar spine surgery get constipation. And that's one of the problems. How do you overcome that? Those are challenges, and often when you send them home early, these patients have constipation and they keep on bothering you. What are how have you solved these problems?
Yeah, that's a great question. And that's why I was trying to highlight the challenges of outpatient spine surgery. You have to have more touch points with the patient. So pre-operatively, we start them on some type of bowel regimen or some type of medicine to make sure they don't get constipated. And then post-operatively, we make them continue. So we use Colase, for example, and they often started 2 to 3 days before the surgery and continue it for up to a week sometimes after surgery. That minimizes the constipation. During surgery, during the actual surgery itself, we minimize any narcotic given by the anesthesiologist so that they don't post-operatively get any kind of constipation. And then critical to all this is pain control so they don't need narcotics, so they don't get constipated. The spinal anesthesia as well as the TLIP block, when performed properly, can help minimize narcotic usage, not get rid of it, but you want to be sparing. Often they'll be taking narcotic pain meds for just a couple of days. And if you, I'm not saying all the time, but if you do it properly, you start them on a bowel regimen before the surgery and then during, it minimizes how much constipation they have.
Right. There is also a question from one of the audience, and that is, does it need a learning curve for spine surgeons to learn protocols for outpatient care or to refine techniques or learn new techniques? Do these patients chosen for outpatient surgeries, are they screened in any particular different way? And do the anesthetists also need to be trained differently?
Yeah, those are great questions. So, it's actually interesting. In my next talk, I'm going to talk about how I'm working with a group in Oxford, England right now, and helping them develop an outpatient spine surgery program. And what I recommended to them is that they first start doing ambulatory surgery on just simple laminectomies on people who are age 30 through age 50. And what you want to do is be predictable in how long it takes you to do the surgery. And so I would argue that the learning curve should start with easy laminectomies, complicated laminectomies, and then you can move towards fusion. What was the second question, Gautam?
Are these patients chosen for outpatient surgery, screened separately and planned for in a pre-admission differently? And do the anesthetists also need to be trained, talked about, I mean, do deal with these things differently? Are they specifically trained for outpatient anesthesia?
They're not specifically trained for it because most anesthesiologists are very comfortable doing a spinal. But if you have a preference, you want to start with an anesthesiologist who has extensive experience with OB-GYN cases because they know how to give a spinal anesthesia for very complicated situations. So that to me is how I would do all that. In terms of selection criteria, I think that you just have to be careful. You have to speak to the patient, make sure they're healthy and that they want to go home the same day. That's critical because you don't want to do it on a patient who doesn't want any of these procedures. But from a medical point of view, I would argue that most patients qualify for outpatient spine surgery if you ask them the right questions.
I have a question, Alok. My question is that I find that if you do a discectomy post-spinal or a to get post general anesthesia, as we are doing a randomized controlled trial in our institution with single level discectomy with epidural anesthesia versus general. I find the ones who have an epidural anesthesia have some retention of urine. Do you have a trick or a tip how we can avoid this?
So I would consider doing a spinal versus epidural because with a spinal it's a single shot and it's more predictable how much dose you get versus the epidural where it's more unpredictable how the medicine diffuses. So I would consider that I would first consider spinal versus epidural. Second of all, it's critical, just like I was talking about with constipation, that especially elderly men who have BPH problems, it's critical that they take their medicine on a good regimen before surgery. What I find is that if the patients skip their doses before surgery, those are the ones who have problems after surgery. A spinal in itself should not cause urinary retention if they're already on medicine. But it's the people with undiagnosed BPH or the people who are not compliant, they're the ones who typically have problems post.
So do you have a protocol? Sorry.
No, go ahead.
So do you have a protocol? Because we have instituted a protocol now that all these patients who have spinal or versus in the randomized that they will have an ultrasound and a residual urine. So only if the residual urine is less than 50 ml would we then introduce them in this study. Do you think that?
Perhaps we can talk offline. I would love to help you. I can show you some of our data around that, about how we've helped with minimizing urinary retention.
Look, there is another question. Can they tolerate prone position? And if there is a complication, how to top up?
So they can tolerate prone position, but of course, again, you have to educate the patient. This is what's going to happen. I use a Wilson frame with a pillow. They actually, if done properly, tolerate prone position really well. It's almost like sleeping on their belly. So most patients can tolerate it. You just have to tell them that this is what's going to happen. And your second question, Dr. Chabra?
If there's a complication, how do we top up?
That's always a challenging situation. I think that like any situation, you have to make sure you have a bed available. The anesthesiologist would have to be ready to do a MAC anesthesia, not be able to intubate, but be able to do MAC and then be able to turn them supine. But it's a situation where oftentimes when you do general anesthesia, the tube is in and the anesthesiologist let go and they're not really paying attention. In this particular situation, the anesthesiologist has to be more involved during the case to make sure that there's no complications and they can convert if they need to.
You said that you would want to start in patients you would suggest that we start in patients between 40 to 50 years of age and then take more complicated cases. But would you agree that the ideal patients who benefit the most for this would be geriatric patients, especially who have cognition and dementia problems?
No, I appreciate that question, Dr. Chabra, because that's what started me on all this. I initially did a study where we looked at the rates of general delirium in elderly people in general versus spinal anesthesia. And we showed and we published very clearly, convincingly, that the rates of delirium after general anesthesia are significant, and that delirium leads to significant complications. So I would argue that for an elderly person, which in our study was over age 65, that you really should think about not doing general anesthesia on these patients. But even more so, during this COVID period, we understand the complications of intubation in general. So if you can do a surgery where you don't need to intubate them, to avoid delirium as well as avoid complications of intubation, I would argue that you should do it. And in our opinion, the elderly people are the best candidates for this kind of procedure.
Yeah, that's what I was saying, that we should start in the young patients, but the ideal patients would be geriatric patients with cognition and dementia issues, right?
Right. And then the one point I want to make is that, for example, with the group in Oxford, I recommended them to do the young patient because it's a more predictable surgery.
Right.
So it's about the issues around the surgeon, how to set up the OR and whatnot. And so so we say young people because then it helps the OR staff get ready.
Thanks, Dr. Alok Sharan. Thanks for joining us and taking all these questions, right?
Thank you.
We have now Dr. Karan Singh, who will be talking on prospective application of virtual reality in improving access to quality and affordable spine care.
Thank you, everybody. My name is Karan Singh. I'm a full professor in the Department of Orthopedic Surgery at Rush University Medical Center here in Chicago, Illinois. It is a pleasure and honor to provide this talk to you today regarding prospective application of virtual reality in improving access to quality. I think we need to understand the originations of virtual reality. Dr. Furness was considered the godfather of virtual reality. It was initially developed for the United States Air Force in order to allow pilots to access avionic data. Understanding what virtual reality is, it's essentially a computer-generated, simulated environment that recreates three-dimensional space. Most of the early development was restricted by the computing power and imaging processing. However, now computing is cheap, and the efficiencies have opened up significant opportunities for a wide variety of applications. Video games have become the #1 trending application for virtual reality, and as technology has improved, so have other applications. Now medicine has an invested interest, in particular with education, telemedicine, surgery, and simulation. Initially, pioneering developments pushed the virtual reality platform into medicine. In the early 1990s, general surgery and orthopedics started to explore the utilization of this technology, which created new opportunities for surgeons, in particular with its application for advanced three-dimensional imaging, robotics, simulation, minimally invasive techniques in particular, as well as for telemedicine and web-based informatics. So what is the current use of virtual reality? General surgery has used virtual reality for the evaluation of surgeon competency. It's been also applied for recertification using virtual reality modules. In particular, there has been an increased interest in virtual reality for spine surgery purposes. In regards to training, it helps avoid the use of cadavers, theoretically decreases the number of hours spent in the operating room, and it can be helpful for preoperative planning as well as for procedural rehearsal. In regards to training purposes, it can extend to residents, fellows, young graduates, and even established attendings. The training program can be customized. Residents can gain familiarity with spine cases, and it can reproduce certain procedural applications involving pedicle screw placement. Younger surgeons can simulate minimally invasive surgical techniques to help flatten the learning curve, and established attendees can adapt new techniques using training modules in a safe environment. So where does this lead us in regards to its prospective use, and how can virtual reality improve spine care? Well, virtual reality improves training. There are low stakes and low risk, so it allows for participation in a new technique. It allows for surgeons to learn at a quicker pace with repetition. It can be applied in a specific training pattern, which can be applicable to fellows and young attendings, and allows for visualization of anatomic structures to help understand anatomy, in particular for minimally invasive techniques, and there's a significant cost savings versus cadaveric models. Virtual reality clearly improves quality of care. It allows for preoperative mapping, particularly for anatomic and for planning purposes. It increases the efficiency due to repetition, reducing errors, potentially decreasing operative time, and can overall improve the accuracy, in particular for pedicle screw placement. What about increasing access to quality care? We need to understand what the barriers to care are. Access to advanced medical care can be limited due to geography, that is being a remote or rural area. It can be limited due to the complexity of the case and the inability or difficulty with the hospital to manage that. There's also a supply-demand mismatch. There may be limited spine surgeons in growing particular patient populations. Virtual reality can help make care more accessible. Preoperatively, it can help provide preoperative assessment. Travel to multiple appointments may be challenging for some patients. It decreases the overall burden to patients. It can be integrated seamlessly with telemedicine visits, providing for a remote physical examination, evaluation neurologically, including range of motion, strength. Can also, with haptic technology, which allows for feedback, reflexes could potentially also be assessed. And it also allows for immersive instructive material for patient education. It can also help improve post-operative rehabilitation. There can be an increased engagement in physical therapy, occupational therapy with the patient. There's real-time feedback. There's also a dynamic and quantitative monitoring for the examination component itself, and the potential promising application for pain management in regards to helping patients understand their current situation holistically and helping address some of the biopsychocognitive feedback patterns. There are extremely significant opportunities for collaborations, in particular shared decision-making with remote colleagues, including preoperative planning, potentially intraoperative consultation, and successful virtual reality collaboration potentially have been done between neurosurgeons in Alabama and Vietnam. So this technology is definitely expanding and is being applied in real time currently. What obstacles do we face for integration of virtual reality into our current clinical practice? Well, the first thing is the technology itself is rapidly evolving. There are different systems that are being implemented. As such, standardization may be difficult. One software platform may be completely different than the other, and this may raise compatibility issues between institutions, regions, and even devices within the same institution. Let's be clear, there is a price to new technology. The cost may be passed on to institutions for the upfront cost of the virtual reality system. These can be significant, upwards of $10,000 per unit, and there are multiple units that may be required depending upon the number of surgeons and the frequency in which the technology is being utilized. There's also the additional cost of the upkeep, the maintenance, and the training of the staff. This also leads to downstream costs to the patient. As the institution acquires these technologies, increasing cost of delivery of healthcare increases, and ultimately this is borne about by the patient. Furthermore, the patient may be involved in the virtual reality platform, and that may require them to obtain their own personal devices and software, adding an additional cost individually. There is no doubt that virtual reality will be in some part of our practice. There is growing physician familiarity and confidence. Patients are very comfortable. As I mentioned before, video games have become commonplace with virtual reality platforms being introduced into the household environment. There is both local and national availability of the technology. Unfortunately, there is some pushback from the insurance and payers. They are struggling with the additive value of this because there's additional costs to procedures that don't typically incur these costs. and they're trying to understand and balance out that additional value of technology with the incremental cost to the institution, the payer, and the patient itself. And lastly, we should not overestimate that there is no current, or underestimate, I should say, the current oversight or regulation. There may be varying regional policies in regards to its application in healthcare. The challenge is standardizing this across all payers, platforms, regions, and nationalities. There is no doubt that virtual reality is here. It's currently being implemented in the household environment, as I mentioned, with video games. It's also being implemented potentially in the automobile industry and the aviation industry. There are a lot of synergies associated with virtual reality and the delivery of healthcare, both in the United States as well as internationally. Simplistic fashion in its utilization would be for training of residents and fellows, as well as young attending surgeons. And a more complex application would be intraoperative training, as well as patient education to improve outcomes, as well as to improve the overall satisfaction of the surgical experience. The biggest challenges will be payers understanding the additional cost and the value that would be added to the patient and the delivery of care, as well as the institutions acquiring this expensive technology. And then lastly, we have to struggle with the standardization of the differing virtual reality platforms as they become applied to different institutions, different geographic regions, nations, and countries. Regardless, I believe virtual reality will be here to stay, and it will become an essential component of our care in delivering the top-notch outcomes to spine surgical patients. I want to thank you for having me. Once again, it's a privilege and honor to be here today, and I appreciate you allowing me to participate in this esteemed program.
Thank you, Dr. Kansing. That was a wonderful presentation. I was reading a review where they said that the role of virtual reality-based simulators in some surgical subspecialties is standard, but in spine surgery, it is still a bit unclear. What do you have to say in this regard?
Well, I guess, let me clarify. So augmented and virtual reality are two separate things. Augmented is the addition, the overlay of images. Virtual reality is the recreation of the environment. Currently, virtual reality has no role in probably any operating room theater, but augmented reality does. Its incorporation, we were one of the first, I think we were the first institution in the world to use the Augmetics platform. It's still a work in progress. There's some surgical kind of ergonomic issues, workflow issues that are not still kind of intuitive to the surgeon. Looking through the lens, trying to overlook through the lens and look around the lens. The accuracy, the processing generation of the image and overlaying it, the real-time feedback, all that is still challenging. It's no different than navigation as it currently stands. It's a similar technology, so its accuracy is very similar to that. It's no different than a robot. In the robot that, once again, navigation-based. So I think it's going to be incorporated. The question is cost and standardization. There's so many platforms, and when you have so many options and so many treatments, it means that none of them are really good. Eventually, a market leader will emerge. And I think once we have standardization, I think its incorporation to the operating room can be more efficient.
So when you said remote support for spine surgery, so would that be through virtual reality or augmented? What is the system that is used?
So I was actually, I participated in a preoperative evaluation with two surgeons in, I want to say somewhere in Europe. I want to say in Brussels. And we essentially walked through the imaging, and this was intraoperatively, and I could see the deformity of the patient. And this was through a augmented reality. So they were actually physically seeing, I could see the overlay with the glasses and everything else. And I could walk through kind of surgical procedures, walking through the steps. There's definitely a delay in kind of the real-time feedback. So it's not necessarily practical as far as actual live step-by-step application. But the fact is, I was actually seeing the surgery. I was seeing what was being done and then the overlaid images. So, I think as our broadband capabilities increase, as the standardization of the AR, VR increases, I think it'll be incorporated to collaborate with surgeons across the country, across the world.
So ASSI has started a capacity building program, and we have adopted one center in Gujarat in Bhuj, and we have mentors in Ahmedabad, in Chennai, and in Mumbai. So because of the COVID, they could not visit there, but one of the industry partners are helping us getting virtual reality support. So would that be virtual reality or actually augmented reality?
Well, it sounds like it's training modules. So training modules typically are virtual reality. And if you look at the United States, the American Board of Surgeons, or American College of Surgeons, so that's the General Surgery Board, from when they take their recertification exam and their initial board certification examinations, they now train on an augmented reality module. So, I think we are probably a little bit behind some of the other surgical specialties, which have been heavily navigation or imaging based, ENT in particular, potentially even neurosurgery. So I think that training is going to be the easiest implementation because you can standardize the module, and that would be based via virtual reality. Surgical based collaboration, surgical based interaction would be more augmented reality.
There's a question from the panel. Will humans be taken over by machines and robots in the future?
You have to look at what we do. I think that the utilization of navigation and robotics for pedicle screw placement has been way overblown. That's its current iteration. That's the vast majority of the utilization of navigation and robotics currently. Until decompressions, until dural work or neural work becomes standard in place, that's another challenging. I have my own company that I'm working on for lateral-based access that uses ultrasound guidance that has a robotic application. So the robot docks the tube in the lateral position. So I think that the scope of the robot is actually increasing, but it's nowhere near close. I can tell you I will be retired before that happens. So I'm not worried.
Okay. Any other questions from the panel for Dr. Kansig?
Do you think, Dr. Karan Singh, that navigation and robots will be replaced by newer technologies in future where radiation would be eliminated by in the operating room?
Yeah, so I'm not sure if people are very familiar, but Google and Johnson & Johnson have a private collaboration. It's called Verb Surgical. I happen to help them out as a consultant. Google and Johnson & Johnson together can be a massively disruptive force in healthcare. If you really look at what Google is trying to do, and they're saying that the current medical device and technology implementation, the costs are way out of market. And so, yeah, I think robots will be more commonplace. They're developing a $20,000 robot, not a $500,000 robot. The cost of medical devices is based upon the ability to extract money from the healthcare systems, in particular the United States and somewhat of Europe. And that no longer is going to be present. So I think disruptive technologies as cost affordable pricing will enable adoption. And I think that as these other kind of traditional strategic companies get involved, we're talking about Amazon, we're talking about Walmart, we're talking about Google, they're all entering into healthcare. I think you will see disruptive technologies at cost-effective price points that will change how quickly we adopt technology. So I think that is coming.
Thank you.
Shankar, would you want to introduce the next speaker?
Next speaker is Dr. Suken Saha. We all know Dr. Suken Saha. He needs no introduction. I've met him several times in India as well, and he's a great friend of the Association of Spine Surgeons of India. He is always helpful to us, and he is one of the most prolific speakers in scoliosis surgery. But today he is going to talk to us about telemedicine to improve access to quality care and affordable spine care, as you spoke about capacity building, and it may be very relevant to our country. Welcome, Dr. Suken. And
Well, thanks very much, Shankar, and thanks very much, Dr. Chabra and the organizing committee for this meeting. And just as we can't be with you in India for this meeting, telemedicine is just an extension of that same virtual technology that we've just been speaking about. You don't need to be present with your patient to still do an excellent examination and convey information. And that's what telemedicine should really be thinking about. And it took a pandemic for us to get here. We had concerns last spring. We didn't know what this virus is all about. We had patient safety concerns. We had provider safety concerns. How do we keep our employees safe, but still deliver quality medical care and mitigate the revenue loss that was happening when we closed clinics and closed operating rooms? The solution was telemedicine and digital health coming together to help everybody from a safety standpoint and delivery of care standpoint. And if you look at this data, we had already been doing a fair amount of telemedicine for a pediatric specialty care enterprise. But look what happened in March, April, as the pandemic crisis was raging on the eastern United States. We quickly pivoted to all telemedicine visits and skyrocketed the adoption of this technology to people who had never used it before. And then as we started opening the clinics again, you see the fall off. So clearly there's a role for this. And you see the sustained effort well above levels previously seen, where people are still doing telemedicine despite the fact that our clinics and operating room are wide open again. And I think a great example of why this works is looking back at value and how healthcare is delivered. Most of our healthcare actually occurs between visits. We're not with our patients every day, every week, every month. There's some preparation before the visit. You have the visit, it's a very short period of time, and then there's some work they have to do or we have to do after the visit. And then long swaths of time occur between the next visit, which is the same pattern. We have to disrupt that. We have to have continuous interactions with our patients, and preventative medical care can result in better outcomes. So this paradigm of care we're currently doing, where we have acute care hospitals, high complexity and cost, and very little patient participation, are going to shift into decreasing complexity and more patient and family-based participation, which they really want. They want the care where they work, play, and live, rather than travel long distances to tertiary care hospitals, which have very inefficient models of care. This is the least costly, the least complex, and provides the best patient satisfaction. So some things to consider for telemedicine are: what is the patient's experience? Are they going to feel like they just saw a doctor in real life? What hardware do you need? What software do you need? What practical workflow issues do you have? What are some innovative case scenarios? We can go over some of the things that we do here at Nemours. And how do you bill for it? How do you make it worth your time? And how do you provide quality care within regulatory issues? I understand that our regulatory situation in the United States or Europe and India are going to be vastly different. I'm going to speak very briefly about the regulatory environment in the United States, and you can choose your own situation for your country. What do you need as far as hardware? It can be very simple. It can be a phone, a laptop, or a tablet, but we also have these mobile workstations that we can use during clinic so that you don't have to disrupt your clinic workflow. I can come out of a patient room on Monday and still do a telehealth visit with someone who lives in Ohio, and then go back to seeing live patients. Or you can set aside a template of a half day a week where all you're doing that morning is telemedicine. And that really depends on what your workflow and preference is, whether you want to segregate it or whether you want to include it in your normal patient workflow, or at the end of your patient day, or at the beginning of your patient day. The software platforms are very diverse. There's a new software platform coming out every day. I think what you want to consider as the minimum bar for this is healthcare security. In the United States, that law is HIPAA, which provides for healthcare protection and personal information. You also want a platform that integrates with your electronic medical record. So as you're doing the visit, that case can be documented. As they come into the virtual platform, the electronic medical records show that they did appear for their appointment, and it also allows for ease of scheduling for follow-up or new patient visits. Now, during the pandemic, when a lot of these platforms didn't really exist to provide high output, we were using Zoom or FaceTime, which was a very unsecure connection, but still provided for a good patient experience. So that's available to you for those people who can't have access to this platform. What does your patient need? They literally just need a phone or some device for two-way video and audio communication. Again, they can go up to a tablet or a laptop as well, but then they need the actual software. This can be two ways. They can download an app or link to a service which would provide a secure VPN network or some secure connection. Sometimes, and as we've gone to, that app for telemedicine can be embedded into a larger app that they also use to view their patient records and schedule appointments. Again, a one-stop shop where they can use their phone, schedule the appointment, do the appointment, and receive information and instructions on what to do before the next appointment. Some practical tips, and I think for early adopters and people that don't have experience in this sort of environment, take this to heart because these are things that we learned and are currently using. Involve your staff, your assistants, your trainees with the pre-work necessary to upload x-rays, MRIs, and CT scans. So you're not wasting time while you're with the patient to look around and search for these diagnostic tests. Have everything uploaded beforehand. Prepare for that visit just as you were prepared to go into the patient room where you already have an understanding of perhaps the diagnostics. Over-communicate with that patient to ensure a good experience. No one likes the stress of having a poor connection or having a disruptive connection during an actual meeting. Prepare the patient the same way and use your staff to do that. Ensure proper tech support. Maybe even do a rehearsal with your staff. Do they have that link? Have they downloaded the app? Are they ready for the visit? And then how are you alerted that they are in fact ready for that visit and in that patient room so then you can go into that room? And then again, we spoke about this earlier. How do you want to integrate this into your workflow? Segregated on Friday afternoons or sprinkled through your normal template on Monday and Thursday and going in and out of that? And then how do patients know that you're doing it? Spread the word. And if they can't hear by their other patients and word of mouth, social media is the new paradigm for word of mouth, and make it known that you're seeing patients virtually and they will come. Some people after the pandemic have switched their practice entirely to telemedicine in areas such as dermatology and psychiatry. They can work from home and they can do this very effectively and very efficiently. I think for orthopedic surgeons and spine surgeons specifically, what type of patients can you see with telemedicine? Obviously, you can't see everybody. The ideal patients to start are post-operative follow-up. They know you, you know them, you know what you're checking for, and the visit can be done very effectively in 2 to 5 minutes. Now, granted, if they needed x-rays, they may have to get the x-rays outside, upload them to your site, and you can review them. Simple follow-up. How are they doing after physical therapy? How are they doing after the injection? How are they doing after bracing? Patients you know, again, and who know you, will be very familiar with you when you appear on the video screen. Quick checks of the incision, comfort, range of motion, do you need another refill of your prescription, are well done through telemedicine. And at least in the United States, the global period after surgery, we don't get paid for 90 days. And so this is a very effective use of our time without receiving additional revenue. What about if they're a known patient and they went to get an x-ray or they had an MRI, you just want to review the findings and schedule surgery? Again, an excellent use of telemedicine. Review the findings, show them what you see on the MRI, and then they understand that they might need surgery. A surgical discussion becomes a next level of complexity. Again, if you've never met the patient, but you're seen as an expert in the field, they don't have to travel to see you. This can be a good use of their time. Avoid expensive travel and that face-to-face interaction and get the answer they need, and then they can see you for a pre-op consultation later. New patients, and this comes into that second umbrella, once you're facile with this, move on to new patients that you can see. And this is what Dr. Chabra asked me to talk about. How can we use telemedicine to increase access and improve care? It's really expanding that patient base. So go to outreach clinics. Don't leave your home in Mumbai or Delhi. You can go to central India virtually and expand your reach and improve access to patients who cannot travel but who still need your care. Virtually triage and pre-screen those new patients before they make the trip to the large cities and expensive hospitals. Help them understand that they can stay in their local environment or they do need that tertiary or quaternary care and have to travel. Perhaps you can see an entire family with one telemedicine visit and explain to the caretakers that when your mother comes home, they will need this, this, and this. And the pre-op consultation before they travel, again, is very important. What about emergencies? A traumatic car accident, 4 injured victims. Maybe this one needs to come to the central hospital and the other 3 can be triaged to local environments. And it can really streamline that emergency transfer. Rather than have them go to 3 hospitals, have them go to the hospital of their destination the first time with the first transfer. What about specialist to specialist consultations? Perhaps a deformity surgeon can speak to a general spine surgeon, or minimally invasive surgeon can speak to a general spine surgeon, help them understand how these techniques might be used in their practice for this patient. And those are called e-consultations between provider and provider. And certainly, patients can seek second opinions virtually without having to travel, even from India to the United States. This virtual triage or pre-screen can be very effective to save time. So here we have a patient with a problem. You can use telemedicine to talk to your nurse or assistant, get the basic history, demographics, what type of insurance, and where are you located. And then they can say, okay, you don't need to see the spine surgeon, you need to see your physiatrist or rehab or pain medicine doctor. Or you don't need to see the spine surgeon, you need to see our bracing specialist for your mild or moderate scoliosis. This increases satisfaction and decreases expense and avoids the error of going to the wrong doctor the first time. You can involve multiple family members who live in different locations. If they're children in the United States and the parents are in India, you can involve them into the care rather than taking phone calls in the middle of the night because not everyone is integrated into the same care plan. And again, these second opinions can become very effective for patients to seek the provider who's an expert in that very rare condition and get convenient access to that specialist. I think we should spend a minute on how to examine patients virtually. Do you have the studies uploaded? We spoke about that before. Is the patient prepared for the exam, or are they dressed in a suit and tie? No, they have to be dressed just like they would be in the examination room. Do they have a gown? That's okay. Use a bathrobe or some kurta or something like that that can cover themselves but still examine their back or neck or feet for a neurological examination. So for girls, we prefer sports bra or bathing suit. For boys, just simple shorts. The exam is likely to require somebody's assistance. Maybe they need to hold the camera while you examine the patient or vice versa. So have them help out, and they need good lighting. Just as you need to see the patient with good lighting in the office, they need good lighting at home so you can examine them virtually neurologically, see skin lesions, see the contour of their back, see the incision, and so forth. I think I'm going to go very quickly through telemedicine compliance and billing. In the United States, we have Medicare, which really dictates the healthcare laws. Where is the care being provided? Where is the care being delivered? Is it live face-to-face? That's called synchronous. Or is it asynchronous? I reviewed the studies last night, and I'm going to email you or send you a recording of what I think you need done. That's called asynchronous. Typically, Medicare didn't pay when the patient was at home. Now that's changed. Typically, Medicare doesn't pay if you have these other sites. You really need to be in the physician practitioner office or in a hospital environment to deliver that care. And really right now, only physicians or nurse practitioners can deliver that care. But maybe in the future, you can have other medical care providers that can deliver that care. There's a lot of difference in whether our insurance companies are paying 100% of this visit or decreasing reimbursement. Check with your payer about how this is going to work out for you. And if you're billing for cash, then you can make that arrangement with your patient as is. So there's a lot of cost shifting and laws to keep in mind. So study the laws in your local environment and make sure you're doing this properly or you will not get paid. Now, in the COVID health emergency, we had payment for all areas of the country. I don't have a license to practice in Illinois, but I could practice in Illinois during that emergency visit. We were getting reimbursed the same for in-person. Is this here to stay? I don't think so. I think the laws are going to change a little bit in favor of telemedicine before the pandemic, but not as good as it was during that emergency. So I think I'll summarize now that telemedicine is a definite tool that you should incorporate into your practice. It's not for every patient or provider, but has tremendous power to increase access, which for India is so critical to expanding specialty care to the rural environments. Expand your patient base to neighboring countries even, perhaps, and provide expert evidence to those doctors who are not trained as well as you are to provide similar quality of care with your help. Check your local country information for reimbursement and healthcare laws and licensing. You have to be flexible and patient when you first adopt this technology, but it's been an ideal way to handle the COVID-19 pandemic without exposing your staff or your patients to an environment that they feel uncomfortable with. And it's a great way to reimagine how we can deliver healthcare in the future. Thank you.
Thank you, Dr. Sukensha. That was a wonderful talk. We have now telemedicine guidelines in India. And as per that, if you do a video consultation, vis-a-vis if you do email or a telephonic consultation, there you can prescribe only certain drugs per se. So you can't do overall prescription unless you have a video consultation, and there too there are drugs that you can prescribe. What are the liability rules like there in US? In India, they are liable as an in-person consultation. So is that a limitation? The other question that I have is, how do you overcome the limitation of not being able to perform a hands-on examination in these patients?
Yeah, great questions. I think right now our biggest limitations are licensing. So after the emergency crisis was resolved, we went back to, in the United States, I can only practice in states where I have a medical license to practice. That protects me from a liability standpoint and also allows for billing. Now, if I choose not to bill, I can provide medical evidence to a limited fashion to anybody. We used to do that with phone calls all the time. And that's up to your provider. If you feel comfortable providing medical advice without billing for it, you cannot be called into court or you cannot be accused of practicing without a license. But when I try to bill for that, I could be. So right now, the limitations are legal. We don't have any limitations on who we can prescribe drugs to or physical therapy or provide advice except for that legal limitation right there. And then the physical examination is really one of the provider to patient issues that we have trouble with the most. I provided you some advice on how to do that virtually, but that's why this right now is just going to be focused to simple problems or patients that you know. Or, okay, now I understand you have a severe spinal deformity. Let's take the next step for you to travel to Delaware and have your care here. And that's what you can use this for. You can use this to triage the patients in the rural areas who need to come to the cities for specialty care. But in the future, and in some aspects, we still have this. The cardiologists and transplant surgeons do this very well. They have limited modalities where they can do pulse oximetry and EKG and heart ultrasounds and measure body fat and measure some other issues like labs with a finger stick. They can walk into a pod, have all these tests done, and then do the telemedicine visit later. That's really amazing. And that's going to be difficult for orthopedics because we do a lot of manual measurements and range of motion and side-to-side bending and do this. But we're only limited by our creativity and the innovation in technology right now.
I believe you can do knee examination now by sensors, and that's how in UK, the British Orthopaedic Association, post-operative knee replacement consultations are totally by telemedicine, right?
Yeah.
I was going through, and in Australia, they started a telemedicine network, referral network for pediatric cardiology in 2000. And they have a very well-established pediatric referral network across Australia. So it helps in access becomes easier and people don't need to travel. So any burning questions? We are running a bit late. Any burning questions to Dr.
One question, Chabra, I have to Suken and to you as well. One quick question is, when we do a telemedicine call on the telephone, the patient on the other side can record your call. And what is the legal liability of that? And when he replaces that call with another third opinion or fourth opinion, and sometimes I see in WhatsApp messages that the court has said that WhatsApp messages are liable to be actual legal evidence, and then you can do. So we do a lot of telemedicines on charity, on just Good Samaritan, or sometimes on payment. And so there is a lot of confusion at the moment. So would you, since you have a lot of knowledge on the advocacy and things in the legal aspect, would you throw some light for all the audience?
Suken, go ahead.
Yeah, I think, obviously I'm not an attorney, but you need to know your country's laws. We in the United States are protected when we do charity work and Good Samaritan work from being sued. Many of us also work in healthcare systems where the institution stands behind us from a legal standpoint. But if you're off on your own and practicing in an environment not supported by your institution, I would be very careful to provide medical advice, especially in very complex problems. As far as phone call recordings and so forth, unless you were notified that this phone call is being recorded, that evidence cannot be used in court, at least in the United States.
Shankar, I will let you know about the Indian telemedicine guidelines which were implemented last year. And as per that, in fact, you need to record all video consultations that you do. It is mandatory.
Ourselves.
You need to record them and you need to keep them. And your liability is as much as an in-person consultation. So that is as per the telemedicine guidelines. So we need to be careful when we do this. We need to be aware about all the guidelines that are prevalent. So
Can I ask a question to Suken?
Yeah, sure, Samajit, a quick question. Yeah.
Hi, Suken. Great talk. So I was doing quite a bit of telemedicine during the peak of the pandemic in our country. Now the pandemic is receding. And I do find that a lot of patients are refusing telemedicine in spite of the fact that they're 500 kilometers away from my place. So they want to come in more rather than get into telemedicine. So are you facing the same, or is it the same before the pandemic?
No, I would agree with you completely. You saw that graph I showed you. That's real data, that fall off. And as soon as we opened, yes, they did want to come back. But that's okay. The ones that want to come back, you see in your clinic. The ones that don't want to come back or can't come or want to see whether they should come, that's where this technology is most useful. It's expanding access. Don't worry about the patients that are already coming to you. This is a way to see more patients that can't come to you.
So it is much better if they could, because the post-operative follow-ups and the long-term follow-ups do not really need to come in. They can get an X-ray locally and get to transfer that X-ray to us, and they can just speak on a video, but they just refuse to do so. So what I mean to say is that the comfort level of seeing a doctor by a patient is much more than whatever telemedicine can reach.
I agree, but think about it from their perspective, just as our perspective. Our comfort with telemedicine is improving. Their comfort with telemedicine will improve also. Yeah. We didn't like to talk on the phone before. We didn't like to do Zoom calls before because we were in person. Now we have to, and it's worked out well.
Yeah, I'm sure it will take time for the people also to get used to telemedicine, as Suken said. So we thank Suken, Dr. Karan Singh, Alok Sharan, and Andrea Luca. It was a wonderful session here, and we'll look forward to having you again for our next conference and next events as well. Thank you. Shankar, would you want to introduce the next speaker?
I think the next speaker is, we have heard Dr. Sami before on the future of robotics in spine care. This is another exciting field which we know very little about. And I welcome, he's ready with his talk, and I welcome him to give his lecture.
Yeah, thank you very much, Dr. Shankar, for the introduction, and thank you to ASSI for having me here today. So it's a great pleasure, and I already was able to listen to some very interesting talks, and I will use my time hopefully wisely to kind of give you a little bit of overview on the future of robotics in spine care in the next 10 minutes and for the foreseeable discussion. And I'm looking forward to the questions in this context. And I'll try to kind of reach a little bit further away so that kind of also the potential applications that are maybe not yet established in the field become at least parts of our thoughts. So it's always a great pleasure for me to talk in front of medical doctors, because obviously this bridge is very important, especially for us technologists. I was hearing a lot about discussions on robots and AI possibly taking over. So I think it's very important that there is a tight bridge to kind of come to this future of AI and robotics really supporting us in the daily care, daily medical treatment, and really as a kind of a service, as a tool to the medical staff, in a sense that it really kind of relieves from burdens and gives new abilities. And I think this is very interesting, especially with the recent rise in robotics and in particular also AI, so perception and making use of data, and then obviously kind of closing the sense plan act loop as a potential tool for various applications. I think it's very well known, obviously, in this esteemed circle that the surgical robotics development has tremendously progressed over the recent years. It kind of, in a way, started with the Da Vinci system really becoming the state of the art in various kind of application domains, in particular in urology, and then also later on going to surgery, cardiothoracic, and so on. So what is kind of interesting is this idea of giving a doctor a tool that is able to kind of operate remotely via kind of a pretty big robotic system, but with very cleverly designed end effector tools, and then giving the impression of an avatar, one could say, so bringing the skills of the doctor to a remote location that he is not physically at. So very related to the talk we saw before in terms of telemedicine, one could say, but with physical remote possibilities on site, in this particular example, in the body. And obviously surgical robotics have also entered neurosurgery with various procedures in DBS and SEEK. And in particular, these so-called position-controlled devices were so far mainly used for navigation tasks, for so-called position-controlled operations. So no feedback of the haptic sense of touch to the surgeon so far. But over the last years, various hundreds of thousands of patients being treated in various applications ranging up to radiosurgery. So what is kind of interesting is in particular the idea that not only the robot, the physical object, but also the registration and the sensory setup on site are supposed to support, for example, I heard something about the pedicle placement, I think 2 or 3 talks before, where in particular the robot is essentially kind of a flexible tool that you can position in order to support you with a kind of a very strict positioning constraint, so that the surgeon is really empowered to kind of use his dexterity, his sensitivity, but the nice navigation properties and stiffness of the system to really place the particular objects in the body. And these kind of systems have become kind of reasonable and standard. However, they are in some form dependent compared to industrial robotics for the classical industrial robotics in car manufacturing. So very strong position control devices, not yet tactile sensation. So the interaction with the physical body is still limited and not yet displayed to the surgeon. In particular, another kind of rather recent direction in surgical robotics is what happens if we come into curved and in particular unreachable situations. Then obviously we need to think about fundamentally new ways of designing robots. So the mechanical systems, so one could say the body of the artificial intelligence of that kind that is able to kind of sneak around the cavitations in the human body and really be able to explore in a safe, however dexterous way, and obviously into the smallest ways possible. So these so-called continuum robots are in some form, one could say, the next generation of endoscopy snake-like systems that are typically controlled via what we call bio-inspired control systems. So the idea is to have remote actuation, which makes it possible to really have very small and delicate structures exploring the human body and giving a kind of a new way of really having a continuous or continuum avatar in the system, in the human body for the doctor. Various systems have been designed up to the smallest scale, so really orders of magnitude smaller than typical surgical robotic systems. We heard also about the Verb Surgical as the kind of unification of Google and Johnson & Johnson that try to kind of make surgical robotics available and affordable. I think it's very clear that the miniaturization and the kind of new way of designing robots in a much more bio-inspired way that are compatible to the human body seems to be the very direct next extension, and giving robots a new way to explore not only the human body, but also place novel types of sensation and giving feedback to the surgeon at hand. So very different applications can be thought of. Here we can see in a form that the end effector has some functionality. So in this particular example, it's an optic catheter with a directional fiber, so we can essentially have controlled thermal energy at the particular site where we want to implement it. So it's not always about getting feedback, but also about getting the treatment there. And then obviously you could also apply MR thermal imaging with this novel kinds of ideas like LIT, laser interstitial thermal therapy, which we see here. And then obviously over the next years to come, there has been new prototypes that kind of bring also two hands into the body. So not only various robots coming from different sides, but actually having kind of multi-port systems that are able to really give a miniaturized representation of the surgeon into the body and give them the feedback to the system. And there's this kind of evolving further and further into the field of what we call nanorobots, medical nanorobots, where small capsules can be basically brought through the body, typically at the moment still externally controlled via electrical or magnetoelectrical fields, and however thought to be self-propelled over the course of action. So with these kind of thoughts, it's very clear that with the next generation of robots, in particular with an artificial sense of touch, we can think about new types of systems that do not only give you visual feedback or are able to steer around the body, but in particular with an artificial sense of touch that is typically being realized by what we call strain gauges or optical technology to then display the forces that are felt in the body, plus certain model-based control and AI algorithms, to then have robots that can be taken by the hand that really have a sense of touch, that are able to essentially render human interaction, human safety, and in particular the human neuromotor control system to then be able to be safely interacting with potentially fragile objects with the sense of touch, and really being therefore also a tactile feedback system if you want to use it for a similar application as we see with the classical surgical systems. So with these systems, regardless of the environment, whether it's spongy, whether it's very rigid, the robots are able to show and render very high performance force rendering. So the tactile sense of touch is in fact much more kind of reliable and repetitive compared to human sense of touch, obviously. So higher quality and higher monitoring of the particular operation could be done in principle. Still, however, mainly in the lab and not yet have reached the operation room. Another important aspect, if we think about the future of robotics, is how do the human models, the kind of not the static visualizations, but really the human models into the kind of thought of the robot, how can they make use of this? So the human visualization obviously has made tremendous progress over the last 3 years, coming up to the kinematic renderings where we can really see almost at kind of visual video level really into the human body. However, this is not yet the functionality, so the functionality has to be coupled with the robot. And for this, we need to understand in a real-time fashion, giving external sensing, how does the internal neuromechanics or other internal body functions interact. How do they kind of change over time? The internal functionalities, the forces, the chemical process, and so on have to be rendered in real time in order to then be able to use to understand not only the control principles of the human internal, to then design systems that can be compatible with that, but really be able to also kind of understand in some form the programming of the human neuromotor control system, for example, to then bring that kind of understanding of the human dynamics, kinematics, but in particular control principles, such that they can be used to program essentially virtual humans, one could say, to not only do motions, but to actually produce the forces, the interactions that really are necessary to drive the human body in a sense. So it could be kind of the motors of the human body really being well understood, and then make out of the body a robot that basically can be programmed to then finally not only have this for the upper body, but also for the legs, and then really make intelligent exoskeletons, for example, that then can make use of this kind of neuromechanical models of the human to make model-based control, to give assist as needed in various applications, and really with this understanding of the human body, make the robot understand what the right treatment in an adaptive and kind of intelligent fashion could be, to then really be of a better assistant to the particular human need. Obviously, there's many applications in this direction. The last one I just want to point towards is so-called brain-machine interfacing, which I think it's very clear, especially with the recent kind of announcement from Neuralink of Elon Musk that you might have seen, where the idea is to not only interface the human brain, the spine, or other kind of parts of the neural system, but then also use these neuromechanical models and the understanding of the human body to then be able to control complex robotic or assistive devices with the understanding of the human, not only brain, but also with the motion mechanics and the neuromechanics, then be able to connect brain-machine interfacing with robotic devices and then be able, this is a very famous video kind of almost 10 years ago, which we did together with John Donoghue at Brown University, which was the first continuously controlled robot arm. And the lady we see here in the image was able to control just with up to 10 neurons that were directly interfaced a 19 degrees of freedom robot system just by thought and in a continuous fashion. So really, she thought in some sense this is her arm. These experiments are currently for the next years are being recreated again in our labs and obviously on larger scale. But the idea was really to fuse robotics, AI perception, plus the understanding of the human body to really bridge the gap between these kind of the embodiment of the human itself, the robot as the potential avatar of the human, obviously in the context of neural control, telemedicine, and rehabilitation. This is kind of the key technology that really might be a game changer in that respect. So I would like to thank not only ASSI for having invited me, but also would like to take the chance to thank all the generous support that we received over the years for our funding. And yeah, thanks a lot for your attention, and I'm looking forward to the discussions and questions. Thanks.
Thanks, Dr. Sami, for this mind-boggling presentation. I think what you spoke in 10 minutes would take us at least one day to basically understand what you're talking. It's so much of information and so much of knowledge at the moment. So I would welcome questions because I believe there will be a lot of questions. So we are a little short of time. Questions from the audience? I think all are spellbound.
Dr. Sami, you had mentioned about the application of robots, but they are more towards neurosurgery. When it comes to the spine, when do you think will we have a proper application in the cervical spine? It will take time because you are not able to control the movement there, and right now the robots available are not approved for use in cervical spine.
Well, I think there is a fundamental technology gap that we are still facing in a way. So thanks for this question. Because I think it's very clear that we need very flexible and dexterous systems. So this idea of continuum robotics that I was showing, I guess there is still a lot of development that has to be done there. And then there is also the important aspect about online navigation. So in order to really have robots being able to be as dexterous and flexible in the cervical spine, I think it's very important that the registration and the online navigation, similar almost like an autonomous car, one could argue, have to tightly integrate with each other to really be of a very precise and also dexterous system at hand. So I think this will still take several years to get to that level that it really becomes clinically widely used. So there are still very basic questions to be asked. In comparison, one must admit to the rather classical way of surgical robots. Yeah, indeed.
Bhavuk informs us that the Globus Robo is approved for cervical use as well, but I'm not sure if Bhavuk has used it in the cervical spine. Because even, say, when you use it in the thoracolumbar spine, because with the slightest of movement, the registration may get affected and you may not have the precision per se.
It's to be honest, actually, the cervical instrumentation is quite different, and they have different instruments for this. We are just in the process of purchasing that. Dr. Sajan Hegde, as far as I know, probably he has those cervical instruments.
Dr. Sarjan would like to comment? No.
I'm not sure if he's there. Sami, you were saying something?
Well, I think I just wanted to support what you were saying. I mean, of course, it's always possible to kind of design very specific applications. But if we think about what you just said about the registration process, in order to get to intelligent robots, and not only, I mean, a robot, if it's just a tool in a way that is barely a kind of a positioning device, then it's still at the bridge between being a pure machine or a mirror machine and an actual robot that really has a certain level of autonomy. So I think this is kind of the question also on the definition level. So I think it's as always, the more flexibility you want, the more advanced, but also the safer the technology needs to be. So, and I really think that this combination of imaging, model-based complementation of kind of human models and the tight interaction with the robot are really vital, because we have seen over the last 20, 30 years in various applications that these kind of limitations have already been creating various problems also in spine surgery, right, in all the clinical applications we see so far.
Dr. Drazen wanted to make a point on robotic use. Please go ahead, Dr. Drazen. Dr. Daniel Drazen, you wanted to make a point? Yeah.
Yeah, sorry about that. I'm still starting my video. I would just say that in the cervical spine, yeah, the Globus robot is used regularly. For Mazor, it is off-label currently just because of the mobility in the cervical spine. They are working on trying to get that sort of proven as an exemption. And so I think that's sort of a futuristic possibility.
But you have, it is being used in the cervical spine with precision and, right.
Yeah, I've used it for the Globus, mostly for like C7 pedicle screws and a C2 screw, but most of that stuff I just use freehand, but I have used the Globus robot for the cervical spine.
T1, C2.
Haven't had any issues. I've had issues in the thoracic spine with that robot a few times.
And no issues with deformity use where the anatomy gets changed and you have, for example, in a kyphotic deformity, registration sometimes becomes a challenge.
Yes, exactly. The registration becomes a problem mostly for the obese patients and patients who have severe deformity. And those are the patients that you have to decide whether to continue using the robot or to kick it out, which I've done on occasion.
So thanks, Doctor. Thanks, Sami, joining us. And we heard you also during Spine 20. And I thought we can have the ASSI members listen to your mind-boggling talk. Thanks, and we'll look forward to long-term collaboration and having you again and again. With that, we will move forward to Dr. Daniel Drazen. He'll talk on potential of big data, computer vision, artificial intelligence, and machine learning in spine care.
I'm Dr. Daniel Drazen, and it's my honor to be speaking to the Association of Spine Surgeons of India. Here's my disclosure. Of note, I have greater than 35 papers using national databases. Robots and artificial intelligence are here. In parts of the world today, they are scanning people's temperature as part of pandemic testing. The future of spine care will utilize artificial intelligence and robotics to reduce costs through accurately predicting who will benefit from interventions and support spine surgeons in performing a safe and human error-free surgery. You can envision a time where a patient comes in with back pain and their medical chart, guided by AI, helps tailor the specific treatment pathway that minimizes the risk of complication and maximizes their outcomes. We are currently in the midst of a data explosion, unlike any other time period in human history. Continually increasing computational power, advancements in analytical methods, and widespread interests are driving technology forward at an incredible pace. At the crux of this is our ability to leverage powerful tools to learn from and act on the massive availability of digital data. Big data is characterized by 5 V's: volume, velocity, variety, veracity, and value. Due to the challenges of volume, velocity, and variety, many healthcare organizations simply ignore or discard potentially informative data. If we think of organizations as creatures, most healthcare systems are at the primitive level of life. Their IT systems are not up to the task. Perhaps the biggest benefit of big data in healthcare is the possibility to obtain individual treatment effect. Randomized clinical trials produce average treatment effects. However, individual responses depart sometimes widely from the average treatment effect. Isn't it important for any treatment to know who benefits, who doesn't, who is harmed? We want the right treatment for the right patient at the right time. The right treatment involves discovering an individual patient treatment effect, the essence of precision medicine. Randomized control trials have restrictive inclusion-exclusion criteria, optimizing homogeneity. This restricts some patients eligible for the treatment. Real-world data is needed. In the medical field, there are a lot of big data sources: claims, databases, databanks, electronic medical records. And interpretation of databases is difficult without data on indications, specific procedural details, comorbidities, and patient-reported outcomes. The major concern with these databases is a lack of granularity and the high likelihood of errors in coding. Here's an example. An article was published in JAMA in 2010 on trends, major medical complication, and charges associated with surgery for lumbar spinal stenosis, used a Medicare Part A claims database from 2002 to 2007. They looked at 3 categories of intervention: decompression, simple fusion 1 or 2 levels, and complex fusion greater than 2 levels. ICD codes identifying the number of levels fused were not available until October 2003. So a multi-level single approach surgery in 2002 to 2003 would have been coded as simple. Now, these same surgeries were considered complex in 2003 to 2004. So if you look at this figure, there was a majority of increase in reported complex surgery that occurred between 2002 and 2004, with only a minimal increase between 2004 and 2007. This change in coding methodology could account for a substantial proportion of the increase in complex fusion. The limitations of this data was delineated in the discussion. I highlight a few of them on the slide. Diagnosis and procedures may be miscoded. The level of detail in ICD-9 spine surgery codes is limited. Appropriately, Dan Resnick responded to this article and said, overinterpretation of such data is potentially misleading. Now, some of these issues have largely been addressed by ICD-10, but we are still using databases from ICD-9 coded patients. To address the lack of granularity, registries were developed in spine surgery. In the US, the QOD and the American Spine Registry are the most robust. There are many international registries as well. Challenges with data quality and collection are reduced with a shared data collection platform. Big data analytics is a shift from traditional statistics. Statistical modeling is designed for inference about the relationships between variables, while machine learning is designed to make the most accurate prediction. Predictive models using machine learning techniques enable surgeons to anticipate everything from the best course of care to operative complications. The complexity of these tasks render them poor candidates for traditional statistical methods and more promising candidates for machine learning. Indeed, studies have shown that statistical predictive models of complications in spine surgery often perform poorly on external validation, indicating that the corresponding results are representative only of a specific cohort and cannot be generalized to the patient population. Analytically, individual treatment effects are obtained from predictive modeling. Patterns are learned from large amounts of data, and for an individual, based on the characteristics, predictions can be made. This is what is known as machine learning. A graph of the machine learning process is depicted from the learning phase to the prediction phase, and a more complex one on the right. The most used machine learning model in spine surgery is supervised learning. For example, a database of lateral x-rays has films pre-labeled as either fracture or no fracture. A portion of this data, the training data set, is analyzed to build a model that synthesizes the pattern between independent variables, example a pixel in an image, and dependent variables, the presence or absence of a fracture. Individual radiographed pixels in this example are known as vectors. The remainder of the X-ray films, the untrained dataset, are fed to the machine, which is then assessed based on its ability to accurately predict a fracture. Accuracy of these algorithms are often reported as area under the curve, or specificity percentages. Now, this was very timely. An article on machine learning was published this week in JAMA Surgery, and it's a randomized clinical trial of 683 surgical patients undergoing colorectal and gynecologic surgery. The primary outcome measure was accurate prediction of the duration of each scheduled surgery. And the implementation of a machine learning model significantly improved case duration accuracy, reduced patient wait time, effected no change in time between cases, i.e. turnover time, and reduced the use of pre-surgical resources. We are seeing an increasing attention toward machine learning in spine surgery. In 2018, there were less than 40 articles, while in 2021, there's greater than 160. Machine learning has been used to predict patients most suited for outpatient surgery, identify risk factors for complications such as readmissions or adverse events, or predict preoperatively the length of stay following different types of fusions. A lot of these studies, I have to mention, are conducted retroactively using national data sets. There's an interesting article out of Harvard that was using computer vision to identify the manufacturer and model of anterior cervical spinal hardware. Now, not all predictive models work. For example, we identified a cohort of 30 validated predictive models of complications following spine surgery, including degenerative conditions, deformity, infection, and trauma. And we found that models in the deformity subset that included radiographic and anatomical grading features reported higher areas under the curve values than those that included only patient demographics or medical comorbidities. In an analysis of 59,000 patients, this article looked at patients undergoing spinal fusion, and they used multiple machine learning algorithms to reliably predict the risk of a discharge to other than home. And yet another article looked at radiographic automated machine learning algorithm for detecting vertebral compression fractures. They had a sensitivity for 95.7%. Surgical robotics and computer-assisted navigation are especially well suited to AI. Image processing is a key strength of AI programs, and navigation stands to particularly benefit from evolving AI techniques. Furthermore, AI can facilitate surgical planning to each patient by accounting for anatomical variations among patients. The image processing prowess of AI allows exact reconstruction of relevant spinal anatomy during surgical planning. And in addition to navigation, surgical robotics have the potential to transform the field of spine surgery by increasing precision, thereby lowering complications from human error and inefficiency. I have published on databases for years, and I am very excited that machine learning algorithms will help lead precision medicine into the future. By catering outcomes analysis to a specific patient, we have the power to supplement years of clinical experience and knowledge with robust mathematical estimates, augmenting our ability to counsel patients and focus more closely on the individual needs of patients. Robotics are helpful and are here to stay, not replace us. The technology will continue to evolve, and it's important that we surgeons remain in the driver's seat. Before I close, I want to highlight my course in Seattle that is in its 6th year on robotics, endoscopy, emerging technologies, and navigation. It will be a hybrid virtual and in-person course. I hope to see you there or online. Thank you very much.
Thank you, Dr. Daniel. And that was an excellent talk. And I think We don't have big data in India, so I would be happy to take some questions from the audience, and we look for a way forward because, as you said, your ICD-10 coding is quite standardized in the US. We don't have a very good standardized coding system as yet for surgical documentation, and we are just new in making our spine registry. And so at the moment, may I ask Bharat to comment on the challenges we face in the big data collection?
Dr. Daniel, my question is, how do you track the follow-ups? Do you have a special system where, the patient follow-up is taken because the registry needs follow-up?
No. So, for example, the large databases track patients. So, for example, we've published on patient data for tracking patients for 5 years. So in the national data sets, there is that. In terms of the spine registries, one thing they do is they ask for follow-up for the patients. It's very attainable to create a spine registry among like a multi-center group of surgeons to say, okay, we're going to just, the biggest impediment is creating the form and getting permissions. But it's totally possible to track a patient. Obviously, the biggest issue is a patient goes to a hospital outside of any of the hospitals that the data is included, and those are the difficult ones. But for a lot of our studies, we were able to track patients for greater than 5 years in the national data sets.
Yeah, and is it a challenge to have the data confidential? How do you manage that?
In the registries, it's not complicated because the way it's entered is it's all confidential. But it took a while for them to set that up. In terms of the national data sets, those are all, de-identified. So, those are all paid. A lot of those are paid databases. So, the money was put up front. Mm-hmm.
So there are questions in the chat box. Yeah, the question is from Dr. Tarush to Dr. Daniel. He says, machine learning to assess patient outcomes would be reliable within a country or a region within a country. For a large country, how much can it be extrapolated for the world? How much time do you think it would be before we have reliable machine learning, say in the US, as we say in the US?
Yeah, so that's definitely an issue. The practice patterns just across the United States are very different. The types of surgeries that are done, I live in Seattle, types of surgeries that are done within, 20 miles is very different. So that's one thing that's helpful, I think, when we're looking at national data sets is the regional variations. So it definitely can't be extrapolated. There's no one answer for one problem for one patient. And that's what I think machine learning helps, is to sort of take all that data together and put it in and see how you could learn from what other colleagues are doing. For example, some people are maybe getting away with anterior-only approaches for some sorts of degenerative disc disease and not relying on doing anterior-posterior, and they have very good outcomes. And so, minimally invasive techniques, for example, is also a great one to look at. Again, the biggest issue is the continuity of patient-reported outcomes. The issue with a lot of database research and a lot of papers that get rejected by us is because there is a lack of granularity and you don't have that data on outcomes. So that's why the benefit of registries, where it includes patient-reported outcomes, is really helpful. I see, a bunch of people here who've also published on registries, so that they could also chime in. I know Neil Anand's, he's published on that as well. So, it's a complex issue that we are continuing to work for. We're definitely not through it. It's sort of the beginning age of it. There's still a lot of data and a lot of time that needs to be spent on clearing this up.
One advice I want from you is, for a country which has poor resource allocation and fund allocation like India, how much resource allocation or manpower allocation do you think is required for registry and large big data collection?
Right. So, yeah, it's a good question. I think the biggest issue, as I mentioned, is the IT infrastructure, creating a platform that across disciplines that could work out for everyone, and that is the biggest impediment. especially with, say, primitive infrastructure that may not be similar electronic health records. So that's the hardest part. And I think as surgeons, you sort of have to be the leaders and push forward as best you can. And how do you do that without funding? Is there some outside, organization, or like, Dr. Singh mentioned Verve, where you have a Google and Johnson & Johnson. Is there some sort of, outside industry that could help lead you forward? Because that would be helpful in terms of regional variations in your country.
Thank you very much.
Do you have, Daniel, the person who enters the data, do you really train them, or do you have some courses where, you have the person who enters the data is trained?
Well, so there's different sides of that. What we found is when you have people who aren't spine surgeons entering the data, there's a lot of issues because that's where the miscoding happens. So what happens with the registries, it ends up being either the surgeon or a resident or a fellow that ends up entering a lot of the data, or a trained coordinator. As the issues with coding, as I mentioned, is such a complexity that you really want someone who really understands the patient characteristics to enter the data. Is there a future idea that the patient enters their own data? Possibly. That could be a solution.
Thank you very much, Dr. Daniel. We are running a little late. If there are any burning questions, I'm sure Dr. Daniel will be available on the chat box to answer those questions. We move on to the next talk and invite Dr. Laheri Lenki, who is going to talk about 3D printing in spine care. Before he starts, let me tell you, Dr. Lenki, that we tremendously enjoyed your interview. Everybody had a great time, and I think it was tremendously appreciated. We'll ask you the questions for your interview. Since you escaped that part, we are not going to leave you. We are going to ask you some questions at the end of this session. Right?
No problem. Sure, you're welcome. Sorry I couldn't be with you yesterday. Sorry about that.
Yeah.
Glad to join you today.
Yeah. Can we have his talk playing, please? Sushil, can we have the talk?
Hello, I'm Laheri Lenki, and I will be discussing the role of 3D printing in spine care. Here are my disclosures. 3D printed models are created from fine-cut CT scans. We find that the 3D printer quality equates to the 3D model quality that's produced. Pre-op, we use these for pathoanatomic study of the spinal column, intra-op as a navigation tool, and also as a vertebral pathoanatomic view and guide. And post-op, we either save the models or give them to the patient as a souvenir following their spinal reconstruction. Here's a current view out my office window showing the hundreds of 3D models that have been created for my use over the past 5 years. Looking specifically at one of the models here, you can see from the left on C2 all the way down to the right, S1 in the pelvis. We note things such as a laminar defect in the lower lumbar spine in the black circle. We note the fusion mass that is located from the mid-lumbar spine all the way to the proximal thoracic spine. And obviously the deformity of the spine in both the coronal and sagittal planes can be evaluated three-dimensionally. In this model, we view it from the posterior, anterior, and sagittal perspective. This is a patient with neurofibromatosis. And you can see dural ectasia that's expanded to dissolve the posterior lamina throughout several levels in the cervical thoracic region and created a basically spinal dislocation and bayoneted spine in the anterior and sagittal planes. So again, the fine details of this very severe deformity are quite illustrated through this 3D model. We also can basically take this model and evaluate it in real time, obviously, rotating it in all dimensions, getting a firm view of the spinal column, something obviously we cannot do intraoperatively in the spine, but we can do this pre-op through this model. What are the benefits seen by using these 3D models? Well, we become familiar with the posterior anatomy prior to the dissection, again, referring to things like laminar defects and fusion masses. We can understand the 3D deformity in real time pre-op. It's especially helpful in revision patients, those with fusion masses, and also those with congenital deformities. We can also plan our complex 3-column osteotomies going from posterior spine to the anterior spine on the model in real time. We also can have our pedicle screw starting points marked out before surgery. This can help with freehand or even navigation screw placement. We understand the pedicle size and deformation on the model even better than a CT scan. And some models can be created that actually you can simulate performing the surgery on prior to going to the operating room, which is great for trainees as well. So here's a model, basically, from left is cephalad, right is caudad. You see the red dots that I've placed on all the potential pedicle screw starting points, which are complicated not only by the deformity in this model, but also by the long fusion mass, which distorts some of the posterior anatomy. So again, we simulate this pre-op, and we have this model in a clear plastic bag, sterilely wrapped in the OR to use it intra-op as our navigation tool. So I place all my screws freehand, no matter what the condition, using these models. We recently published a paper on the utilization of these 3D printed spine models for freehand pedicle screw placement and complex spinal deformity correction, where we evaluated 513 freehand placed pedicle screws from T1 to S1 in 23 patients. Overall, we had a 96% accuracy and acceptable position according to preoperative plan on post-op CT scanning, and intra-op CT scanning. And we concluded that these 3D printed models can make freehand pedicle screw placement safer in severe spinal deformity cases with acceptable accuracy and no neurologic or vascular complications encountered. I'm going to go through two illustrative cases of how we use these models to make spinal deformity surgery safer. In case one, this is a pediatric revision kyphoscoliosis case. This patient, an 18-year-old male, presented following 20 prior spine surgeries performed in an outside institution for early onset kyphosis, now with severe progressive kyphosis and shortness of breath. Here's his pre-op sagittal MRI scan showing the tenting and stretch of the cervical thoracic spinal cord over the apex of the severe cervical thoracic kyphosis. Here's his 3D CT scan showing the anatomy from the anterior and sagittal perspective. And in more detail, here's his 3D printed model, showing again on the far left, posteriorly, he's severely rotated such that during posterior exposure, you're entering into his foramen because of the severe rotational malalignment. The anterior perspective is seen as well as obviously the sagittal perspective from the right and left sides, respectively. He underwent a posterior procedure from C2 to L3 with a 2-level apical thoracic VCR. Here are his pre- and post-operative AP and lateral x-rays showing the instrumentation placed as well as the correction obtained following his VCR procedure. He did very well post-op without complications. And here are his pre- and post-op clinical photos demonstrating the dramatic improvement in his severe cervical thoracic deformity. The second case is an adult primary kyphoscoliosis patient who had neurofibromatosis and presented with severe pre-op myelopathy. Here's his pre-op AP and lateral x-rays demonstrating severe thoracic kyphoscoliosis with vertebrae that are almost uninterpretable due to his severe deformity. This pre-op sagittal MRI demonstrates the severe thinning and tenting of his spinal cord at the apex of the deformity with cord signal change. Here's his 3D CT scan showing a severe deformity. And again, the 3D printed model, again, from top left at C2 to bottom right, L4, demonstrating the markedly severe kyphoscoliosis. Impressively, when we look at his vertical model and measure the distance from the inferior aspect of T2 to the superior aspect of L2, it's only 2.5 centimeters in height. I want you to think about that for a second. That's his entire height of his thoracic cavity preoperatively. So following halo gravity traction, he underwent a posterior procedure from T1 to L4 with a 3-level thoracic-based VCR for a very nice correction of his severe thoracic hyposcoliosis and marked improvement of his trunk height as seen both radiographically and clinically. He also did very well without any complications postoperatively. So in conclusion, we have used 3D printed models for over 20 years to help plan and execute complex spinal deformity surgery. The pre-op planning assists in individual vertebrae analysis and overall deformity description. Pre-op planning and intra-op execution of both pedicle screw placement and PSO and BCRs are also benefits gained from the 3D model. We find this as a useful adjunct no matter how surgery is performed intraoperatively, either freehand or navigated screws, and can only help understand and perform these complex operations. And I thank you for your attention.
Thank you very much, Dr. Lenke. That was a wonderful presentation, and those two cases were amazing. Any questions? We will allow 2 questions from the our panelists here. Dr. Lenke.
Did you use 3D printing for pre-operative planning only in these cases, or did you also use customized implants or drill guides to help in the insertion of pedicle screws?
No, as I mentioned in my talk, for the last 20 plus years, I've placed every single screw through freehand techniques. Again, with or without a model. I don't make a model, obviously, in every case. Normal idiopathic scoliosis with a 75-degree curve without any anomalies, I do not make a model. But again, obviously, the more complex the deformity, the more often I am to create a model. And honestly, it's interesting that my fellows always prefer to have a model, even on more simple cases of deformity. They prefer to have it because they can study it and, again, truly understand the 3D dimensional deformity pre-op. Even if the vertebrae are, quote, more normal, it still, I think, helps them understand and comprehend, the true lordoscoliosis that occurs at the apex of an idiopathic curve and things that we assume that everyone understands, but some of the trainees, especially some of the neurosurgical trainees that we have now that don't have the same orthopedic background when they start a fellowship, they truly appreciate these 3D models from the deformity perspective.
Thank you. Any more questions?
There's a question in the chat box. The printing of models with pre-existing implants, is it a challenge?
Yeah, it is. And so actually sometimes this week alone, I had a very complex case with multiple previous surgeries and implants in place with pretty much a solid fusion. I actually, the patient I was going to put the patient in halo traction. So while placing the halo, I also took out the implants while the patient was already, anesthetized. So and for the sole purpose really of creating a better 3D model, because you're absolutely right. The artifact, just like we see on a regular CT scan, the artifact does limit the quality of the 3D printed model. So occasionally I will take out the implants in preparation for creating the model and then preparation for doing the revision surgery.
Right. And there is a question regarding your method of that you wrap them in plastic, whereas these models in India, we are sterilizing them with ETO or plasma. Why is that?
I honestly, that's what I wanted to do, but my OR, both in St. Louis and now in New York, will not let me do that. They said for some reason it doesn't pass their, quote, sterility test of the committee that assesses things like that. Even though the company that makes the models feels they're able to be sterilized appropriately, my OR committee won't let me do that. So I'm not going to argue with them. I put it in a clear plastic bag. It works very well, but yeah, for some reason my OR committee won't let me do that.
Dr. Lenke, there are some associated questions which are there in the chat box, but which are not directly related to this specific talk. I would be grateful if you could answer it. And in the meanwhile, I would like to move on to the next talk, and that is from Dr. Neil Anand, who is going to talk about single position surgery. Neil, can you slide share, please?
I'm doing it right now. Thank you. Can you see it? Hi, good evening, everybody. Can you see my slides?
Yes.
All right. Okay. So good morning from the U.S. and good day wherever you are. First of all, it's such a delight to be invited and see all of you. Really miss you guys, and I'm glad we can see each other this way. So single position surgery, this seems to be a huge topic all of a sudden. And I kind of want to set the stage as to why we're even talking about it. And these are my disclosures where we are. And really, what is single position surgery? In simple terms, just the idea that we can do a 360-degree fusion in one position rather than flipping the patient. That's all it truly is. And you can ask yourself, why is that a big deal? And we can sort of talk about it, because I agree, I don't think it's a big deal. But it has become a very common topic of discussion of late. And I think the reason it's happened is, one, because of lateral fusions. A lot of us are doing lateral fusions in the lateral position, and call it what you want, with numerous names that have come up with it. And then today we have navigation, robotic assisted placement of screws. And I think the combination of the two has led to this topic or genre of single position surgery, because the idea that we could now do it in one position with these technologies that are available today. And I think that's what sort of led to it. And there seems to be this talk and drive leading to it. But why is it even important? I think, does it really change something? I think the biggest thing it is probably improves operative time and efficiency. But then let's see to what extent. This is directly from this paper. And you can look, what really changes is basically that part of the flipping where you got to take everything off, redrape the patient, obviously putting a new OR bed if you're going prone or Jackson table. And you are reattaching lines and neuromonitoring leads and so on and so forth. And it's anything between probably 30 to 40 minutes in terms of the time spent, depending on how efficient your operating room is. I'm sure some places in 15 minutes you could do it. So it's something you need to ask yourself, how much you're really saving. But anytime you look at the data, it does seem to be in operative time. As you can see, it's 103 minutes in single position. And you flip, it's about 307 minutes on average. And I think it's a little excessive, but I think there's somewhere between 30 to 40 minute difference I think you could make. And in terms of the correction, we seem to have a similar correction, whether you do it in single position or flip the patient. And complications, again, seem to be pretty similar. But interestingly, ileus was significantly more in the flipped patient, that someone who had anterior lateral and then was flipped to posterior, which is sort of interesting and pretty high, actually, 0 and 5.54%. The rest of it are reasonably the same, I would say, across the two. So again, here's another one versus lateral and then prone positioning. Another paper, similarly, same thing, where you're again looking at essentially operative time being about 44 minutes longer if you flip the patient. And I'd say you can ask yourself, really, is that such a big deal? But that's something I think each one of us can decide. Is it that important for you to go to a new technology and do it? Or are you okay flipping it, depending on the efficiency of your OR? And we can discuss that, what a big difference does that truly make? So here again, the same thing, you can see the operative time here is somewhere in the vicinity of 40 minutes. So the average is 30 to 40 minutes. So if you, again, look at another paper looking at that, again, same thing you're seeing is that same difference. So most papers are exactly the same in terms of the time limit. That seems to be the real difference between the two. Efficiency-wise, it seems to be good enough. We seem to be getting the same results. We seem to be getting the same correction and seem to be doing the other things. So just a case example of how we go about it. I've certainly done a few of these. Am I a big fan? I'll openly say I'm not. I don't see a big difference between the two. And I think time will tell whether this will really stay over the course of time. And this will be a straightforward case where we had 4.5, 5.1. 5.1 is only degenerated. 4.5 had a spondy. And you can see the MRI there, if you will. That's the 4.5 axial MRI. And here's the CT scan. So it's indicated for a 2-level fusion, severe back pain and leg pain. You can see the axial with the sublux at 4.5. And so we indicated a 2-level fusion. So we had the robot, assisted, self-navigated robot. And it was easy to sort of plan the screws out preoperatively on a CT scan. I gave a talk on robotics a couple of days ago at your meeting. And so we've been using this really in pre-op planning through your pre-op CT scan. And so what we normally would do is use the robot to place the guide wires in the spine in the lateral position. The patient's in the lateral position. My co-surgeon is literally doing that while I'm doing the lateral approach at the same time. So that again is a little added advantage. You save some time in surgery itself. You can have two teams working simultaneously. So the robot's helping put the guide wires in. The guide wires are already in place, and then we do the lateral fusion in the traditional lateral manner. And you can see here's the ALIF being done in the lateral position, ALIF graft being placed. Similarly, you do your lateral interbody fusion at 4-5. And here's the interbody at 4-5 going in. So you've done your interbody fusions here, and now you can go back to put the screws over the wires that are already placed. Again, all quickly at the same time as I'm literally putting the last device in, the screws are already going in the back. So again, you save sort of another 10, 15 minutes, I guess, in doing this. And it's all percutaneously, minimally invasively done. Rod is threaded in, put in position, and you can get a 2-level fusion done in a single position manner. So yes, it's sufficient. Yes, you save some time. Time will say, are we getting the appropriate lordosis we really need? Would I do it for multi-levels? No, we'll talk about that later. For me, it's really a 1 to 2 level surgery, even 3 levels. I'm a little reluctant. I've done 1 3 level. I usually don't unless I got good alignment already in place. So here's a CT scan of him to show screws in place, and that's your post-op x-rays. Another place I found really useful, another technology that I'm finding useful now is someone who's already had screws placed. This is just to go historically. That's a Delisys, by the way, placed in 2005 with a fusion at 5-1 and a non-fusion at 4-5. But as you can see, the years went by, went on to an auto fusion at 4-5. But she was doing great for 13 years and literally came back with adjacent segment disease at 3-4. And that's what we did. So now you got an adjacent segment 3-4 that's unstable, stenotic, and you got screws in the back. We don't even have the tools available today to remove the Delisys. I literally would have to hack that out. It is already out of the market. And even if I had it, it would be a huge adventure to take this out and put that in. So it's another technology that's available today. And since we're talking of the future, this is rather interesting, and I've used that quite a bit. And here's a CT scan to show you the same thing, solid fusion, 4-5-5-1. Here's a clinical status, the severe back pain, neurogenic claudication as you'd expect, EOS films. This is a technology that's actually a spinous process fusion clamp, not to be confused with an interspinous process spacer. Very different. It's actually a fusion device. And just to quickly talk about it, it goes right percutaneously between the spinous process through the interspinous ligament, but keeping the interspinal ligament intact. It's in the interspinous space. It actually has room for grafting. That's what it basically looks like. It's a clamp that goes across. And it, as I said, in the same lateral position, once we've done our lateral, we're able to now do, this is just a quick animation of what really happens. The lateral fusion goes in as we would go, and then you literally get a guide wire between the spinous processes in the lateral position through the same incision, another small 1 centimeter incision, dilate down to it. There's a broach and a reamer that creates the space between the spinous processes. Basically, it's a pure adjunct to your lateral fusion. As we know, lateral fusion by itself, standalone, works 89% of the time. It is just to bump that 10% more, give it a little more stability, at least in my plan, to allow that lateral fusion to heal. So I want to make that very clear. We're not using this as a fusion device by itself. It basically is an adjunct to a ALIF or a lateral interbody fusion you've already done, just to give you a little more stability to allow that fusion to occur. As you know, standalone laterals don't do as well. You got a 10-15% non-union rate. So that's what it really looks like. And let me just go off to the next slide. So it turned out to be a really good way to do a stabilization fusion at an adjacent segment without ever touching your previous screws. And again, it's a very efficient way to do that. It changes the way we do it. And to me, these are technologies that help us in the long run. And similarly, you can see the 2-year post-op CT scan, the lateral fusion has gone on to heal solidly. So this was just something good for this patient, I think, was a good way to tackle it. I find this useful for adjacent segment. Here's another patient, and we see this all the time, adjacent segment screws. Otherwise, you're going back to take those screws out or domino, it just changes the operation. And this suddenly becomes a big game saver. So at the end of the day, yes, operative duration is probably important. I think we're increasingly getting data now how OR time singularly may be one of the biggest reasons for our complications. And this is just a paper on single-level lumbar fusion, and you can extrapolate that to multi-level big surgeries. And when you go beyond 5 hours, 9-fold increase in surgical site infection, 9-fold. So, and this is a single-level fusion. So I think we can sort of extrapolate where we are, 10 times wound adhesions. So I think there is some truth to cutting down operative time, being more efficient, and that's where, to me, single-position surgery is sort of making sense. Where am I today? 1 to 2 level, I think an MIS TLIF is the best single position surgery. Where one position prone, take care of it. Or do your lateral and navigated percutaneous screws robotic. If it's greater than 3 levels, usually I'm staging them and doing laterals, and 2 days later, perc screws like we published from lot on it. If it's an adjacent segment, I found this percutaneous interspinous fusion clamp really useful. We've done about 9 now, so we'll talk about it as long-term results. And if it's spinal deformity, as you all know, without a question, it's staged, and I will not do a single position beyond 3 levels, but I really don't think you can get the alignment you need in that sort of position. Thank you.
Thank you, Neil. That was eye-opener in terms of something different happening all the time as far as spine surgery is concerned. Whenever we visit you, we see you doing something new. We are always trying to catch up with you. You do something new, we try to catch up. We probably catch up in 3 years. By that time, you're doing something else altogether. Let me put the question, the talk open to the house. Any questions? We will take 2 questions from the panel. Well,
so you are doing these surgeries in the lateral position, Neil. There have been some publications where they're encouraging prone position, single position surgery also. What is your take on that?
I've never done it. I have no experience with it. I know exactly what you're talking about. And like I said, it's become almost a mantra now that everybody jumping on the single position surgery. And as I said in the beginning of the talk, I'm not sure why such a big deal is being made of it. I think there are other incentives to that. Honestly, I don't believe it's a huge difference. If you're efficient in your OR, as I'm sure many of you are, you probably can do the same job well. So as long as we can get the job done and do what we need to do, and it's safe, I think it's fine. And so I'm looking forward to results on that technique. I certainly know what you're talking about.
Right. I think time to move on. Thank you very much, Neil. That was a wonderful talk. And we move on to the next talk. And we have Dr. Aditya Gupta taking us to the future of neuromodulation. Where is it headed? I'm sorry, neuromonitoring. Where is it headed?
Neuromodulation. Gautam, it's neuromodulation.
Yeah, where is neuromodulation headed? What is the future? And we've got Dr. Aditya Gupta giving us this.
Good evening. Thank you so much for the kind invitation to participate in the ASSICON, and thanks to the ASSICON organizing committee and Dr. Chabra specifically. I'd like to be talking on neuromodulation in spine care. And as we know, neuromodulation is an important modality which helps us out in different scenarios. And what we have available with us is spinal cord stimulation, dorsal root ganglion stimulation, and some intrathecal drug delivery systems. But I would basically be talking about spinal cord stimulation. Now let's begin with spinal cord stimulation for pain. This has been in vogue for almost 5 decades, and the initial use was developed by Sheely et al. In 1967. And basically, to put it simply, it depends on the inhibition by the large diameter sensory fibers which exist in the posterior column. So basically, posterior column was the first site of stimulation, and large fibers exert an inhibitory influence on the dorsal horn of the cord, which is really the main pain area. So the concept, as I have mentioned it here, is that dorsal horn of the spinal cord is the main sort of gate pathway which controls the propagation of the pain impulses to the brain. And what happens in spinal cord stimulation is that stimulation of the dorsal column results in action potentials which go spread to both the directions. So they go to the dorsal horn and also orthodromically in the rostral directions to the supraspinal centers. And therefore, spinal cord stimulation really acts on multiple sites within the neuraxis. Now, in the Indian scenario, it is less practiced despite many good results reported from the West. And probably the 2 main culprits are the high cost and the limited availability and awareness about this technology. But I think of late, it has certainly started gaining popularity. Now, spinal cord stimulation for pain, the main indications are failed back surgery syndrome, and there was a good trial for this in 2005. Chronic regional pain syndromes is a very, very big disease category in which spinal cord stimulation really does wonders. Apart from phantom limb pain syndrome, neuropathic pain syndrome, and also some ischemic pain syndromes coming from peripheral vascular disease and even intractable angina. Now, the other uncommon indications we'll be touching briefly are spasticity, paraplegia, bladder control, and neurogenic incontinence. The basic contraindications for the spinal cord stimulation are the presence of an organic lesion like a spinal stenosis or instability, which produces the pain. Presence of infection also is a relative contraindication because one would not like to put implants in the presence of active infection. Patients who have severe psychological issues and substance abuse are also precluded from this because this needs a regular follow-up and evaluation. And of course, any patient who has contraindication to a surgical procedure per se, like a coagulopathy, would be a poor candidate. Now, this is a patient assessment for spinal cord stimulation, and really the attempt is to weed out patients who have one of these contraindications. So I will not go into this in detail. The device has basically three components. One are the different kinds of leads. Then there are connectors. And finally, there is the implantable pulse generator. Now, apart from these basically three things, there is also an external programmer which is available to the physician to dial up or dial down the amplitude and the frequency of the stimulation. So the leads come in different sizes and varieties, and there are three main vendors, as the slide will show you. And of course, these are the implantable pulse generators, and the ones which are in vogue currently are the ones which are rechargeable ones. So they have a life of at least 15 years, and they can be recharged easily by the patient at home, typically on a weekly basis. So these are the patient programmers, and the exciting advance is that some of this programming can even be done remotely by a pain physician. So in the procedure workflow, there is a trial lead placement in which we put percutaneously 2 8-channel leads, and these are like wires, and the patient is paced for a week using an external stimulator, and on a successful trial, then we do the permanent lead placement. So these are typical steps of a lead insertion in which a lead is passed through a 2He needle, but I would rather take you through a short video to bring home the salient points of the surgical procedure. So this is the introduction of the electrode through the needle. And on the AP view, important thing is to check the trajectory of the initial few millimeters of the lead, which we check periodically both in the AP and the lateral directions. And sometimes we find the lead is not going freely in that it sometimes gets stuck in the anterior epidural space. So we want the lead to be in the posterior epidural space. And in that situation, it goes freely. And the other important thing, it has to be paramedian on one of the sides. So typically in trial stimulation, we put in 2 leads, and that has certain advantages for achieving pain relief. And repeatedly, we check the position of the lead as we keep on advancing it. And here you will see that a good length of lead has been inserted, and we introduce through a separate entry wound for the other side, so that you have these 2 leads with the electrodes staggered with respect to each other. That increases the field of coverage of the stimulation, and that is the ideal final lead position. So these are the typical lead stimulation parameters. The burst suppression is known to be the most effective, and this is what is being used by majority of these systems today. And the results are actually very good. For failed back surgery syndrome, there is a level 1 evidence of the efficacy of spinal cord stimulation across the randomized controlled trial. And for the complex regional pain syndrome, there is again a level 2 evidence, but several trials have noted that a dorsal root ganglion stimulation may be more beneficial than a spinal cord stimulation. So as with any implantation of a pacemaker or an implant anywhere in the body, there are typical complications which are mentioned. whenever we use these implants, which are neurostimulators, there is a definite risk of electrode migration, breaking, and basically, with a higher degree of stimulation, patients sometimes have some painful paresthesia. So that basically means that the stimulation has to be reduced. Now, coming to the second point, spinal cord stimulation for spasticity, that is something which has been investigated quite a bit, and there is conflicting data. And basically, there are mixed results from various studies, but there has been some recent interest in use of spinal cord stimulation for spasticity. This was a Russian study in 2015, which showed that the effect of spinal cord stimulation is very good for spasticity. But since then, if one analyzes the other published literature, there is a recent study, not very recent, but 1981, in which for 160 patients with cerebral palsy, 94% showed improvement in spasticity. So for spasticity, I would say it's a mixed bag. I would not really propagate purely for spasticity, but yeah, a patient who has pain and spasticity probably would be a good candidate for this. Now, spinal cord stimulation for paraplegia is a very new, exciting use, which is being very actively investigated in United States, Europe, and also in our country to a limited extent. It's not FDA approved, but there are very, very encouraging anecdotal case reports of how voluntary movement can be achieved in patients who have spinal cord injury. And this needs, of course, a detailed evaluation and also a detailed physiotherapy post-stimulation. And basically, time doesn't permit me to go into this in detail, but this is probably one of the most exciting uses of spinal cord stimulation. Now, finally, a few words about spinal cord stimulation for bladder control. This is something which is being used clinically for patients with spinal cord injury, and with a very, very promising data coming out. And retrospective and prospective studies have shown that majority of patients do exhibit significantly alleviated symptoms post-spinal cord stimulation. And there is even a report which says that it may even help the bowel incontinence in patients with spinal cord injury. So to conclude, spinal cord stimulation and neuromodulation in general is an established modality for chronic neuropathic pain, but its efficacy in spasticity, paraplegia, and neurogenic bladder is yet to be established, although it is very promising, likely to find wider use, but economic limitations in India compel us to ethically and carefully select these patients. Thank you so much for your patience.
Yeah, thank you, Dr. Aditya Gupta. Just one quick question. Are the electrode placements for when we use it for spasticity different from that when we use it for pain?
The placement of electrodes is not remarkably different. Basically, you put the electrodes on these segments which are showing the lower motor neuron manifestations, because below that will be segments which will be generating spasticity. So the levels are basically not very different. It just depends on the exact level of the injury, and you basically put it across the segments which are showing you the lower motor neuron kind of manifestations.
Any other questions? Gautam, you are muted.
Is there a time limit within which you would recommend that if a patient with paraplegia comes with a neurogenic bladder, should he come within the first 3 months after the problem? Should he wait for 1 year, 2 years? How soon should he be treated with this stimulation?
So for sacral nerve stimulation, the best results are within 1 year of the injury.
Okay.
And obviously, for the first 3 months, we don't really gun for these kind of implants to take place because we want some spontaneous improvement to happen. And most of our patients pay for this stuff out of the pocket. So I would say within the first 3 months, maybe better to evaluate and wait, spend the time and carefully laying out what kind of bladder dysfunction the patient has, but definitely do it within the first 1 year.
Thank you very much.
Yeah. Just one quick question. I was under the impression that this for sacral root stimulation, this has mainly an action for hyperactive detrusor.
Yes.
Whereas when it comes to bladder neuromodulation, the real one is the Brindley stimulator, right? Rather than the one that you demonstrated. Would you tend to agree with that?
Yes, I agree with that. And I must also confess that as a neurosurgeon, I do not have much of personal experience with using it for continence, to be honest, because my major practice and my major use is basically for the pain.
So thank you very much, Dr. Gupta. And
thank you so much for having me.
Yeah, and we move on to the next talk, and that is on targeted and molecular therapies. And we have Dr. Prabhat Bhargava, who's going to speak on this topic. Dr. Bhargava, all yours.
Good evening, everyone. This is Dr. Prabhat here from Tata Memorial Hospital. I am a medical oncologist in Tata Hospital, Mumbai. Today, I would like to thank the organizers for giving me this opportunity to present to you the targeted therapies in cancers. I will start my talk. So, giving you a brief introduction, we all know the stem cells are the reserves of our body, and they are used whenever it required, and they can specialize in whatever cell type the body needs. Like when blood is deficit, it transforms into RBCs or platelets, and thereby we can replenish our body requirement and maintain a hemostasis. Similarly, cancer also has stem cells, and not that all the cells are dividing at one point of time, and that is the reason why we have recurrence in cancer. The conventional chemotherapy can only kill those cells which are dividing, because they go and act only on the dividing cells. So there was a need to improve the outcome of cancer, and further improvement is in the form of targeted therapies. So before understanding targeted therapies, let me take you inside the cell. So this is a cell membrane, and these are the receptors on cell membrane. Once there is signaling on the receptor, signal is received, the cell starts send signal inside via the various signaling pathways into the nucleus, and thereby the cell proliferates. So when there is a problem in the receptor or in the signaling pathway or in the nucleus itself, the cell turns into neoplastic cell, and thereby keeps on replicating even without the signal. So this is a diagram of a melanoma, of mutations that are seen in melanoma. So we can see one of the example is c-KIT mutation, which is mutated in 0 to 39% of the melanoma, or NRAS may be mutated in around 20% of the melanomas, and so on and so forth. So what are the targeted therapies? What in targeted therapies are we doing is when we know that the c-KIT is mutated and this is overactive, leading to proliferation, sending downstream signals in the cell and into the nucleus. So why not inhibit the c-KIT itself, the mutated c-KIT? Or if we cannot inhibit the mutated c-KIT, why not inhibit NRAS? So that even if the c-KIT is mutated, the further signaling will not go downstream, and thereby the cell will not proliferate, and leading to the inhibition of the cell proliferation. So these are the various examples of inhibitors or targeted therapies that are being in the pipeline or being approved. So the first targeted therapy, why I chose melanoma, is because imatinib is among the first targeted therapy to be approved in cancer treatment, and it has done wonders in cancers like CML, where around 70 to 80% of patients are doing well since 5 to 10 years on oral tablets. Their cancer is controlled just like the way we control diabetes, similar to something like this. So this imatinib is a specific inhibitor of BCR-ABL, PDGFR receptor, and c-KIT tyrosine kinase, and produced by the genes which are responsible for growth in CML and GIST. It is effective in CML, GIST, melanoma, wherever there is c-KIT expression. Side effects compared to chemotherapy are very minimal: nausea, myalgia, edema, diarrhea, myelosuppressions, and sometimes deranged LFTs. So you can see a drastic difference between a GIST patient who was given for 2 months imatinib. You can see this is what a huge GIST lump he had, and within 2 months how it disappeared as the proliferation had stopped. Now coming to second one, this is breast. Breast, you would be seeing many breast patients present with bone pains because they commonly present with bone metastasis. This is one of the pathway which is active in breast cancer, HER2. HER2 is also lies on the cell membrane. Why it is commonly over amplified in around 15% of the breast cancers. Once over amplified, this does not require signaling from above, and it keeps on sending signal downstairs, and thereby the cell keeps on proliferating. So what the scientists did was to inhibit the HER2. So the first and foremost drug which was found was trastuzumab. This is a humanized monoclonal antibody specifically inhibiting HER2. It either binds extracellularly on this subdomain 4 of HER2 and thereby flagging them for destruction by immune cells, or it inhibits the dimerization of HER2, or it can inhibit the signaling, downstream signaling. So this is monoclonal antibody. Now, how do we further improve the therapy by this monoclonal antibodies? By flagging them with the chemotherapy. So this monoclonal antibody trastuzumab is now linked with various types of chemotherapy. So once the monoclonal antibody binds to the cell, the chemotherapy is selectively delivered to the cancer cells, thereby targeting only cancer cells and sparing the normal cells by the side effect of the chemotherapy. This is another way how we have improved the targeted therapy, by just targeting the cells, chemotherapy directly through the targeted cancer cells. Even after this is breast cancer survival over the period of years. When there was not even surgery was found, the survival was minimal. Compared to more and more patients are surviving as and when we discovered that only mastectomy, further with chemotherapy followed and anti-estrogen agents, and now with targeted therapy. But however, we still know that not all 100% patients are surviving. So there are reasons why targeted therapy is also failing, that we will come to in later subsequent slides. Let me come to breast cancer, lung cancer. So this was a patient who was treated with geftinib. Till that time, it was not known why the drastic response came to this female with geftinib. Later on, it was found that the selective response was coming only in few patients, and this was those patients who had EGFR mutations. So further molecular testing revealed now that lung cancer is not just one cancer, but it can be subdivided into various types, like squamous cell carcinoma or adenocarcinoma. This adenocarcinoma can further be subdivided into so many subtypes, where KRAS is more common in smokers, and still therapy is undiscovered, is discovered, but in initial phases of clinical trials. While EGFR is more common in our South Asian females, it is found in 17% overall. And this is how we can divide cancer, lung cancer, from histology based to molecular based now. And we have array of drugs to target each of the mutations. This is how. So once we diagnosed a lung cancer patient in stage 4, where we cannot cure them, we first have to wait for this mutation reports to come, and then only we can start them on, based on most of them are oral therapy only. With just tablets, we can control that disease for months to years. This is how targeted therapy has evolved in lung cancer. Further, let me come to further how things are evolving in targeted therapy. So now this is NTRK gene fusion is found in many cancers. In lung cancer, it is only found in 0.3% of the cancers. So these two therapies have been discovered, entrectinib and larotrectinib. And this is how, when we give a patient of 55 patients were given with NTRK fusion, were given larotrectinib, the response rate, this is how it is seen depicted in a waterfall plot. You can see many patients achieving 100% response with larotrectinib, followed by 90%, 80%, and very few patients progressed on therapy without showing any response. So now further and further targeted therapy may not even require what is the diagnosis of cancer. It will only require what is the mutation going on in the cancer. This is a perfect example, which is upcoming still in phase 2 trials, and phase 3 trials are still awaited. Are this, as I showed, imatinib also has few side effects. Are this TRK inhibitors very much having very significant side effect? No. You can see most of the grade 3 side effects are less than 1%. Very few are only transaminitis was seen in grade 3. Similarly, with entrectinib, only 5% patient had weight loss. Otherwise, most of the side effects are less than 3% of the population. Another way is to target those antigen on the cell and may generate the T cells of the body to target this antigen. So these are this is the slide of B cell membrane antigen in myelomas, and how is the targeted therapy evolving. So these are chimeric antigen receptors on the T cell. The patient T cells is drawn out in the blood. They are infected with lentivirus, which has cells to recognize tumor cells as foreign body. This is injected into the T cells. These T cells are proliferated in vitro, and then they are injected back to the patient, so that the patient's T cells, this artificial T cells, will recognize tumor cells as foreign body and target these tumor cells. So the process is remove these T cells from the patient's body, deplete the normal T cells in the patient's body, and then after proliferating this T cells, these artificially manufactured T cells, they are injected back into the patient's body, and thereby attacking the cancer cells. So is targeted therapy, what I have demonstrated, so good enough? No. The truth is the patient's cancer cells are initially dependent on one pathway, but if you keep on blocking this pathway, it will go on to the second pathway, and if you block the second pathway also, it will go on to third pathway. So most of the targeted therapy are able to achieve response only for a limited period of time, and later on we lose the response. So just targeted therapy is not enough, and maybe we will need further therapy to improve the outcomes of the patients. So conclusion, targeted therapies which improve the therapeutic index are future of anti-cancer therapy. Advances in molecular pathway will provide the means to identify the targets and will be used to subtype tumors, and will predict response to therapy and provide prognostic informations. Thank you for your patience listening, and I'm open for the questions. Thank you.
Thank you, Dr. Bhargava. That was amazing. I'll open the house with two questions to you. The first is, how does this molecular therapy translate in terms of how we plan our surgery? Because what happens is, when we think about surgery, we think about patient survival in a metastatic tumor. So is the survival 6 weeks? We probably won't do anything. If the cervical bill is 6 to 3 months, we'll probably do a simple decompression or something. So that what happens is that, as per the traditional chemotherapy, these were the goals that we had. Now, with these targeted therapies, I think the survival has significantly improved, changing the normal paradigms by which we judge survival of a patient. So how would you advise us to go about when we think about surgery now in terms of all these tumors, if a patient can afford the all this targeted therapy? That is one. And the second question is that the targeted therapy is great for systemic control of the disease, but the local control at the site of in the vertebra where there is cord compression or anything, what is the role of targeted therapy in local control of the disease? So suppose a patient comes to us with a typical lung cancer with metastatic to the spine, and it's metastatic to the brain. We traditionally would have avoided surgery in such a patient. We would not have touched the patient. This patient is going to die in 6 weeks. Why touch him? Now the question arises in our mind is, with targeted and molecular therapies, are we refusing? If he survives 6 months, we will have made this guy's life miserable by not operating on him. So how should we go about thinking on these issues?
So I would like to quote my sir, my professor. He used to always teach us while he was doing his medical oncology. He used to be taught stage 4 lung cancer, send him home, no survival. And now the survivals of stage 4 lung cancer is also reaching 5-year survival that we normally talk about is 50% of even stage 4. If the patient is affordable for targeted therapies or any molecular immunotherapy, which I have not touched in my session. So it depends. Your question was right. It depends upon the affordability of the patient. If he is affordable for everything, then even in stage 4 lung cancer or many of the stage 4 cancers, now I will advise, let's go ahead with surgery first. If there is cord compression, which is leading to paraparesis or some focal neurological deficit. If there are no focal neurological deficit, then it will depend upon what mutation does the patient have. And some targeted therapy have an overall response rate around 80%. So in those patients, if patient is asymptomatic, even I will say don't touch right now if he progresses. So 20% may progress even in targeted therapies, as I showed in my NTRK slide. In those patients, if focal neurological deficits occur, then I will return back this patient for surgery. Otherwise, asymptomatic patients, we can start them on targeted therapies first and see whether they are in those 80% who are responding with the targeted therapy.
But we have after you and right next to you on the screen two legendary oncosurgeons, spinal oncosurgeons, Dr. Stefano Boriani and Dr. Ehud Mendel, who are going to be here after you. So if you can stay for another half an hour or 45 minutes online, when we question them, I'm sure your inputs would be very, very useful. And I would like to, without much ado, move on to the next talk, and that is from Dr. Ehud Mendel. And he will be talking about what lies ahead, the future of management of spinal tumors. Dr. Mendel, I don't know whether you would remember that we spent some time together in 2005 in Los Angeles at an AO Spine International Tumor Board meeting. And since then, it's been a long time I've not met him. So Ehud, please go ahead.
All right. Can you guys hear me okay?
Yeah, we can see it fine. Please go ahead.
I'm trying to get my talk. Can you see my talk?
Yeah, we can see that.
We can see your talk. Yeah, that's great.
Okay, great. All right, well, thank you so much for inviting me to give this talk. I'm going to talk about just basic principles and maybe answer some of the questions that came up during the previous session. I really want to thank you guys for inviting me to give this talk. Spine tumor is my passion, and hopefully I can share some of my thought process. And I wanted to start with just basic principles that I follow and then move into some future trends in the management of spine tumors. So I'm just going to show you 5 quick cases that I'm sure a lot of you guys are dealing with patients with spine tumors. See, here is a patient with multiple myeloma, 57-year-old. You can see that there is an L2 pathologic fracture on a patient with multiple myeloma. No neurological deficit, just back pain. Question is, just think about how would you, in your own practice, would manage this particular patient. Here's another patient with renal cell carcinoma, very similar presentation, L1 pathologic fracture, metastatic renal cell carcinoma, very similar presentation to the multiple myeloma, similar location of pathology. How would you manage a patient like this? And is the difference between a multiple myeloma L1 fracture or L2 fracture versus a renal metastatic disease with a fracture? Would that make a difference in your practice? Here is a third case. Again, patient just with back pain. All of these patients have no neurological deficits, they just have pain. But in this particular case, you're dealing with an L3 chondrosarcoma. Presentation is the same. Location is lumbar spine in all of these patients. How would you manage this particular patient? Here is a patient with thymic carcinoma. And when you look at the MRI, there's new lesions of T11 and T12. Patient, again, presenting with similar location, lumbar, thoracolumbar mets or lesions with back pain. How would you manage this particular patient? So I'm throwing this out there because I'm showing you 5 cases of patients who are presenting clinically the same with presentation of lesions in the same location. And how would you manage each one of these patients? Do all these patients need surgery? Does the difference between the difference in the biology, the type of tumor makes a difference? And if you do decide to do some surgical intervention, what would you do here? And when it comes to what is available for us as surgeons, we have these options. We have intralesional resection options. We have an en-bloc options. We have adjuvant therapy, chemotherapy. Now, as was mentioned before, immunotherapy has a huge evolution. Radiation, stereotactic radiosurgery, and minimally invasive like vertebroplasty and kyphoplasty. And I wanted to present this particular case because I think that ultimately will lead to what I'm trying to deliver here. Here is a young lady who coming to the emergency room who has no diagnosis. And she's coming in with back pain, and she has a little bit of weakness in her legs. And you can see that her exam just shows slight weakness in her iliopsoas. And here is the MRI. And she's in the emergency room, and you guys get called to see this patient. And so where is the pathway of what actually needs to be done with this particular patient? She has very minimal weakness. There is no diagnosis, and she has severe spinal cord compression. So I would like to ask all of you, how many of you will take this patient to surgery from the emergency room, considering some weakness in the legs, considering the fact that there is severe cord compression, but you don't have a diagnosis here? This patient, is few more slides, you can see here the cord is severely compressed. There is tumor wrapping all around the thecal sac, the vertebral body. And ultimately, what I want to show you here is this patient was taken to surgery, and this is what was done. A laminectomy was done, the decompression was performed, and the pathology came back lymphoma. So now that you know, in retrospect, that this was lymphoma, was that the right management scheme for this particular patient? And I just want to throw it out there. So if each one of you can think about that for a second. Now let's take, and this is the post-op MRI, and you can see a lot of the tumor is still there. The patient got better after surgery with improvement in the strength, but this was a lymphoma. Now let's take the same case, but instead of 4 out of 5 strengths, let's say she's coming in with very severe paraparesis in the lower extremities with 2 out of 5 strengths. And the question that I have for you again, would you take then this patient for surgery? And the question that I want to throw at you is, how much of a deficit in a neurological exam you're willing to accept, and how much you're not willing to accept? And that is where it gets to be a little murky when it comes to taking this type of patient to surgery from the emergency room or not. Here is another case on a patient who comes in with progressive foot weakness and intermittent bowel bladder dysfunction. And this is the MRI. Again, no diagnosis, but in this case, significant neurological deficit with bowel and bladder incontinence and foot weakness for over a week course, progressive in nature. And this is a patient who had no diagnosis, was taken to surgery immediately to decompress the thecal sac, and intraoperative biopsy came back as chondrosarcoma. And once it came back as a primary bone tumor, the patient was followed with stereotactic radiosurgery. His symptoms have all resolved. His bowel and bladder symptoms have recovered. And he's done well for about 3 years, only to then present with that in his skin. And what you see here, he thought that one of his screws is poking up to the back of his back and his construct is failing. And when you look at the MRI, you can see a massive recurrence at the operative site. And you can see what he thought to be a screw where the red arrow is actually a local recurrence right underneath the skin. So, and in addition, yes, he was right. There was a fracture of the rod there. And we ended up taking this lesion out, taking it in some sort of an en-bloc fashion and revise his construct. And he ultimately needed to have a big reconstruction with plastic surgery to be able to close this wound. So clearly chondrosarcoma, primary bone tumor, that was not likely the right surgery to do, maybe for both of these patients. And I wanted to present all these because the take-home message and maybe future trends in spine tumor surgery is that there's some mismanagement related to sometimes the bad timing of operation or operation when you don't have a diagnosis. And so I want you to be aware of the triple W, which is the wrong operation on the wrong patient by the wrong surgeon. And I want to stress again, these are all patients that have multitude issues, and for the sake of time, I'm going to go quickly, but they are immunocompromised, they are nutritionally deficit, most of them are on steroids with multiple of side effects that could be related to it. A lot of them are coagulopathic with thrombocytopenia and platelet count that's low. A lot of these patients are hypervascular, the aneurysmal bone cyst, giant cell tumor, and all long laundry list of patients who are very vascular, where you have to think about preoperative embolization. And then, as some of my slides show, you have to think about wound management. A lot of these patients may have seen radiation, and so there are significant issues with wound complications. So, we are upfront very quickly get plastic surgery involved in order to maximize our ability to close this wound. This is a patient with a sarcoma that presented. Here is another patient with a sarcoma that presented. So clearly we can do big en-bloc resections, but ultimately you have to get multidisciplinary involvement on a lot of these cases, because once you do these surgeries, you got to be able to close this wound. And the surgical plan is very critical as to whether you're planning on curing them or palliating them. Clearly, you got to establish a primary bone tumor for metastatic disease. But I think one of the future trends and the key aspect for any patients with cancer is make sure you know what you're operating on. Try to make sure that you get biopsies up front before you proceed with any surgery. Those are the kind of things that are very critical. Here's a patient who was sent to me for schedule for an en-bloc resection for a sacrectomy for presumed sacral chordoma with no diagnosis. And as you can see, that ended up to be an ependymoma, which require a completely different surgery. The biopsy is very critical. Make sure that you are upfront with your interventional guys patients like this, you want to stay away from a transoral biopsy or a transrectal biopsy, which would be the quickest way to establish a diagnosis, but then you are unable to remove the track with it. So make sure that you plan your track in such a way that you can include the track to minimize seeding along the track itself, include the track with your specimen, and you can see a couple of examples here where we are including the track with the en-bloc resection. Make sure that those biopsies are done from midline and not done far lateral to not being able to allow you to take this specimen out. We're now moving toward the artifact and carbon fiber rods and carbon fiber screws. And I just want to show what's happening here. When we put in doing all these big reconstructions, when you end up trying to get some surveillance, you can't see anything on all of these reconstructions. So there's now evolution toward moving toward the carbon fiber screws, carbon fiber rods, which then when we follow with the next thing that I want to talk about, radiosurgery, we typically do radiosurgery on a lot of these cases who get separation surgery for metastatic disease. We follow it with stereotactic radiosurgery. And once you use these carbon fiber screws and rods, there is no necessity for myelogram. Typically, with titanium rods, we do myelograms on these patients so that the radiation oncologists can really map all around it. But now with carbon fiber rods and screws, we can rely purely on just the MRI. Stereotactic radiosurgery is very critical for any practice with they deal with a lot of spine tumors. So we have a very robust program at Ohio State where we go through either preoperatively or patients like this. This is a patient with single met, has a little bit of pain. This patient doesn't need surgery, and radiosurgery would be a very good option. Or sometimes residual disease after surgery in critical areas around vertebral artery, things like that, where radiosurgery comes to be very helpful. So we talked about a little bit the intralesional, the radiosurgery. I want to mention the vertebroplasty ward with the vertebroplasty or kyphoplasty, which is a very powerful tool for a lot of these patients. I've looked at a lot of these data all throughout my career at MD Anderson at Ohio State. We did a lot of comprehensive reviews. A lot of these patients are unable to go through big surgeries, but are in a lot of pain. And so we really push the limits on cement injection. Sometimes there's a lot of contraindication or presumed contraindication for bad fracture, canal compromise, back wall that's missing with risk of cement leakage. And we have looked at it and refuted a lot of those proposed contraindications, though these are the things you don't want with cement leaking into the canal or some injections that look like this where cement is just pouring everywhere. Cement, can end up in the lungs, can end up in the brain, can end up in the canal. So you got to be very careful about this. We're pushing the limits about these. A lot of patients that have high C2 lesions, we start looking at transoral vertebroplasties that save them potentially occipital-cervical fixation. This is a case of a C2 renal met with a transoral vertebroplasty was done and fill up the area. So we have looked at our data and actually show that we can refute a lot of the proposed contraindication for cement and that some of these contraindication can really be relaxed. Dr. Boriani obviously talked a lot about en-bloc resection, and these are really the more challenging cases. These are mostly for the primary bone tumors. So en-bloc resections are really to alter prognosis. That's one of my indications for surgery. Spinal instability is critical for the metastatic ward when it comes to if spines are stable or unstable. I'm sure most of you are familiar with the spine oncology study group where we came up and developed this criteria of establishing what spines are stable, what spines are unstable. This is a patient with an L3 met. And if you, for the sake of time, if you end up all the points here, you're going to get to SIN score of 9, which is potentially unstable. Neurological deficit is a third criteria. Clearly, if you have somebody who comes in like this with a huge bone in the canal with neurological deficit, or somebody like this with severe cord compression, these patients would benefit from surgery to help with neurological deficit. And I just want to throw it out there that pain by itself, axial mechanical pain related to fracture that gets better when they lie down, gets worse when they get up, is also an indication for surgery. So just briefly, when it comes to surgery and then future plans, plan it wisely. These are big surgeries. Think about what kind of approach. Here, I showed this slide before on a patient with a huge sacral chordoma. a lot of the mid-thoracic area, we do transpedicular ovarectomies through the back. We ligate the nerve roots. And then Tarush, who was my previous fellow, and I have looked at cement reconstruction versus cage reconstruction. And we found out that the cement reconstruction is a phenomenal workhorse for all those thoracic cases. And there's no necessity to put any cage in the front. The cement works very well. I want to lastly talk about some of the primary bone tumors. Again, these are cases that are challenging when it comes to figure out how to get to the point where you can get these tumors out in one piece. There are lots of techniques that have been described on how to do it. Here is a quick case of a sacral chordoma here. And ultimately what you want is be able to remove this tumor in one piece without entering into it. So the idea about these cases for all these primary bone tumors and some of the solitary mets, like maybe renal cell carcinoma, pancreas tumors, to be able to maximize treatment. Keep in mind that some of them are very sensitive to some radiation or chemotherapy options. So sometimes you want to start with that before you proceed with surgery. So perioperative chemotherapy for the Ewing sarcoma, osteogenic sarcoma, the high-grade chondrosarcoma, the differentiated chordomas, all of these are important. The giant cell tumor have seen huge revolution when it comes to the denosumab, the monoclonal antibody. And I'm just showing you some cases over here. This is a lady, 32-year-old, came in with a giant cell tumor of L3. Just pay attention to L3 completely missing here and broken in the canal. And you can see 3D reconstruction of this giant cell tumor. And in this particular case, I've elected to just proceed with stabilization from the back. And then she was placed on denosumab. And you can see that the bone is completely filled in within 6 weeks. Here is a lady with a pharmacist with neck pain who came in with a giant cell tumor of the cervical spine. It's C2, broken. We stabilize it from the back. And again, I want to get your attention to the C2 vertebrae that's completely missing and broken. And within 3 months, the entire vertebrae have completely filled with bone. So denosumab definitely revolutionized treatment options for patients with tumor. Just keep in mind that some of those tumors, again, even the primary bone tumor, they require preoperative embolization. Some of them could benefit if you cannot do an en-bloc resection with intralesional resection. And when it comes to those that you can do an en-bloc resection, Dr. Boriani obviously is going to talk later, but really he was the key person who led our thought process about considering these big surgeries with en-bloc resection to be able to resect the sacral chordoma, sacral chondrosarcoma, because the results are, the disease-free survival is what it makes the difference. We do it in the sacral spine, and we can do it anywhere. There's a mid-thoracic sarcoma that underwent an en-bloc resection to the back with reconstruction, and you can remove these vertebrae in one piece and create very nice chance for this patient to actually be cured of cancer.
Dr. Mendy, can you sum up, please? We are running a little late.
Yeah, so I'm going to skip on the sacral lesions. Sacral lesions really require a different thought process. Just want to throw this out there that on the sacral lesions, there are lots of technique we have developed for placement of wires in the belly that allows us then a quick resection of these sacral tumors, pulling the wires to the back, and then perform a secrectomy and be able to remove these tumor quickly in one piece. And we have published it trademark technique. And there is the last case here on a huge chondrosarcoma that again, we looked at ability to increase the rate of fusion on a lot of these cases where we actually reconstruct these with autologous bone graft in order to maximize our fusion. And all of these patients has massive fusion at the end of these cases. And you can see right here where we use this vascularized graft to close the pelvic ring. And this patient within 6 weeks to 2 months, you can already see bone growth that's going. So, we sacrifice the limb. These patients already presented with significant deficits. We are able to use the bone, vascularized bone graft that's intraoperative pictures with the vessels. And then we are able to implant these in to close the pelvic ring itself. We get nice fusions and, these patients are actually doing pretty well. I just want to throw the last thing about our cancer engineering program. This is a huge team where we are looking at personalized models for patient, 3D modeling, vertebral fracture predictions with animal models and En-bloc characterization. This is some of our personalized models for patients, including patients with cancer, where we, similarly to what Dr. Lenke discussed, we're doing it now in spine, where we create the tumors, we can create 3D reconstruction of these models, and that allows us then to do a lot of the stuff up front as to the extensive reconstruction that we need, how many levels above, how many levels below. A lot of this stuff is done through supercomputers through the university to create modeling of the spine. And with 3D modeling, we can create now complete vertebral bodies that are perfect fit for these en-bloc resection, where this is patient-specific vertebral bodies. We can create hemisacrum 3D modelings to fill in those huge gaps that are left once the sacrum is being resected. And then we are looking at different shape modeling for a lot of these patients using artificial intelligence and actually trying to create modeling of the spine and try to predict fractures after radiation and whether there's some role for prophylactic vertebroplasties to prevent further fracture of this vertebra after. So in conclusion, the management is challenging. These surgeries can restore and protect neurological function, improve pain, and a significant impact on quality. The key is really to understand the biology of spine tumor, which is critical in defining the goal of treatment. And surgeons who are dealing with this spine neoplasm should be familiar with various surgical approaches, as well as complex anterior-posterior reconstruction. So be godly, try not to be God. And again, thank you for your invite, and I'm open to any questions.
Thank you, Dr. Mendel. There are a number of questions which are there on the chat box. I would be grateful if you could stay back for 5 minutes and answer them. We are running 20 minutes late, so I'm afraid we'll have to move on as it is. Dr. Boriani has been waiting for quite some time. So thank you very much, Dr. Chhabra, Dr. Shankaracharya, for moderating this fantastic session on the future of spine surgery. And I thank each and every speaker from across the globe who has come and enlightened us on what spine surgery and spinal management of spinal problems is going to be over the next 20 years. So I think we've learned a lot. We've enjoyed this session tremendously. Thank you, Dr. Chhabra, for thinking about it and organizing this. And we now quickly move on to our next big session, the journey with legends. Interviews with legends in the field of spine surgery. Today we have got three great legends. The starts with Professor Stefano Boriani from Italy, who is going to be interviewed by Dr. K. Venkatesh from the CMC Vellore. That is going to be followed by an interview with Dr. Michael Fehlings from Canada, and he is going to be interviewed by Dr. Rohit Amaritanand, who is again from CMC Vellore. And the final talk in this session, the interview, is going to be with two legends of India, the people who described what is called as the Harms Goel technique, but which is actually the Goel Laheri technique originally. And we have both these gentlemen, Dr. Vijay Laheri and Dr. Atul Goel, and they are going to be interviewed by their student and a very dynamic spine surgeon, Dr. Samir Dalvi. So without wasting any more time, let us have the first interview. Sushil, can you place the interview of Dr. Boriani?
So good evening, everyone. And here it gives me indeed a great privilege to welcome Professor Boriani, who is a doyen of spine tumor surgery. He doesn't need any major introduction. In fact, no introduction at all. Everybody knows about him, but still, as a routine, I will say that he's a very senior orthopedic surgeon from Italy. So after finishing his specialization in orthopedics, so he worked at the Rizzoli Institute with Professor Mario Campanazzi in the subunit of oncologic spine surgery. So after that, he has held many prestigious positions, and currently he is the director of spinal teaching program and the head of spine tumor surgery in the spine surgery division at the Galeazzi Institute at Milan. So Professor Boriani has more than 430 articles which are in the peer-reviewed scientific journals. He has conducted many programs and courses and he is the chairman of the Module 3 and the Master Course of the European Spine Foundation. He has authored many textbooks and he has 9 monographies to his academic bank. He has been a visiting professor for more than at least 14 major universities, which includes the Harvard Medical School. And Professor Boriani, I would like to welcome you for the annual conference of the Association of Spine Surgeons of India, and which is being conducted virtual this time because of the corona pandemic. So welcome, Professor Boriani.
Thank you very much. Thank you. It's a very great privilege for me. Thank you very much for this invitation.
So to start with, most of us like spine surgeons, most of us try to avoid doing spine tumor work. So it's a very challenging issue. So, but how have you taken interest in doing spine tumor surgery as your exclusive work? And when most of us think that we have to move away from it and do the other works. So what made you to get such an interest in this field?
Thank you very much for this question, and let me know that it's really a great privilege for me to be here, to be invited to you. And let me try to give an answer to this question, just to show my slide and introduce by imaging what I want to tell you. So first of all, on the left, you can see Italy, and you can see that Bologna is here, just in the north part of Italy. Is not a big city, but it's a site where in 1896 was founded the Rizzoli Orthopaedic Institute. It was the first orthopedic institution in Italy. And I was born in Bologna, and so I did the medical school in Bologna, and later on I started as a student in 1976 to attend that Rizzoli Institute. And in this institution, most of more difficult cases, degenerative but also tumoral, were referred since the beginning of the century. So at that time, more than 20,000 bone and soft tissue tumor cases, fully documented, were collected. And Professor Campanacci was my mentor, was working on this subject. He was a pathologist originally, and then he became an orthopedic surgeon. He became the director of the Rizzoli Institute, and he had the opportunity to study all this material and to write a lot of papers about new cases and a big book. He was a very famous pathologist on bone tumors. And he was the protagonist, together with Henneking, on the revolution of bone oncologists at that year. And there was really a great changing at that time. The combination of a new system to stage the tumor, this didn't exist before, together with the chemotherapy, the neoadjuvant chemotherapy, and the new surgical technique like En-bloc resection, allowed to obtain great results in osteosarcoma of the limbs, for example, as the amputation went down to 95% and the survival at 5 years raised up to 70%. So really great results. The question was, is this applicable to the spine? And this is a question that Professor Campanacci proposed me in a day of the spring of 1994. It was a day that changed my life. He called me in his office, and all of the other colleagues were working on the limbs, on joint replacement. I was the one dedicated to traumatology. And he told me, Stefano, why don't try to deepen the knowledge in bone tumors in the spine and give an answer to the question, are the criteria accepted for bone tumors in the limbs applicable to bone tumors in the spine? So this is really great job. And it really changed completely my life. So first of all, I tried to study the spine. I didn't know anything about that. So I was a fellow in Paris at Rocamille and in Marseille at the Louis Center and in the States. And there was already some great surgeon working in bone tumors, but there were very few. The pioneer was Professor Steiner, that in the 70s, he was a general surgeon. So he started to apply to the spine what he was doing in the bowel. And so he described some very interesting case of En-bloc resection. And you know that later on, Rocamille and later on Tomita popularized the technique of En-bloc resection. But my idea was to create a complete and multifocal approaches to bone tumors, try to define the way to perform diagnosis and categorize the tumor according to staging, try to understand the biological behavior, and then decide the treatment according to that. So the first point was to translate the ethnic incision system, which was dedicated to the limb, to translate in the spine. And so we translate completely this technique, this system, which was previously dedicated in the limb. And so we found the indication to En-bloc resection for aggressive benign tumor, for low-grade malignant, high-grade malignant when combined with chemotherapy. So it was a great job to try to organize all this activity. And so finally we arrived to perform the first En-bloc resection in October 1991. Those was the first vertebrectomy performed at Rizzoli, but I think also in Italy. It was a chordoma of L3. At the time I was at the age of 39. And we started with a posterior approach, removing all the healthy part of the vertebra, and then separating the dura from the posterior part of the vertebra, so separating from the tumor, starting the discectomy, and do the fixation. You could recognize the very old Isola system. And then we positioned the patient on the lateral side. We approached it from anterior, and we entered in the retroperitoneal cavity, and then combining anterior and posterior approach, once leaving the psoas over the tumor to have a good margin, we succeeded to resect and block this tumor. You see here the first specimen of a vertebrectomy. And we were quite happy. This patient survived for 8 years without any evidence of disease. And finally she died for another disease, but without any local recurrence. So it was the first time, was really successful. We were very happy. And so we went on studying and working on this subject. And since at that time, I had the opportunity to collect, to observe and treat more than 2,000 cases, first at Rizzoli Institute, later in other two hospitals, in a great hospital in Bologna, and now at Galeazzi Institute in Milano. So this is my career, which was mostly dedicated to bone tumors in the spine since the time that my mentor told me try to work on the subject.
It was wonderful, Professor Boriani. Actually, we have really explained us that what made you to take the interest, probably the great doyens you have worked with, especially Professor Campanese and with Anyking and all those people, has made you really a wonderful person in this field. But how was the evolution of this WBB classification? Because we considered it one of the gold standard. Okay, so how did it come into your mind? Like, what made you to think about this classification?
Thank you. It's really, so as I told you before, the idea was not only to perform surgeries, but to understand when to perform surgery, which kind of surgery to perform, how to standardize the approaches. And the idea was really to balance the aggressiveness of the surgery and maybe the combination with other treatment with the biological behavior of the tumor. So at the time, the only one surgery was done for any kind of tumor, benign, malignant, metastasis. The idea was indeed to standardize, to stage. So stage means to create categories. And once that we have achieved the diagnosis, we have to understand the biological behavior of the histotype of the tumor, and this is the target of the Herniation staging system. But when we have to decide which kind of treatment, we need a system to stage the extension of the tumor. So this was the reason why it was really useful to have a relationship, a friendship with Jim Weinstein. You can see Jim Weinstein here on my slide?
Yes.
Okay. Jim Weinstein, you know, it's a very famous guy. He is till now the editor-in-chief in Spine, but it is a great friend of mine. I was visiting him several times. He was visiting me. He had already the idea to stage the tumor extension. And this was his former system, which was a little bit complicated with different, with a coronal plane and the sagittal plane to divide the different part of the vertebra. As the idea of the staging of the tumor is to have a better sharing of information among different groups, to file the database, and finally to plan the en-bloc resection. And so he accepted my idea to consider the tumor and the transverse section as a pie and to cut slides of the pie, as we do on the tumor, on the vertebra. No? We have the center of the vertebra where there is the canal and the content of the canal, and then there is all the vertebra around, and all the surgery in the spine is limited by that problem. So that's the reason why I suggested this, and together with Biagini, you can see here was my fellow at the time, and so Weinstein, Boriani, and Biagini are here, and we proposed officially this system to the literature. And it really was a great success, as there is a lot of quotation, a lot of citation in the literature. And more recently, the SOSG, which is a society, a group of spine oncologists, spine surgeon oncologists, decided to understand, to assess the reliability of this system. And the conclusion was that it was reliable, but maybe it was better to rotate it in order to have it exactly like you see in an MRI or on the CT scan. It is the same, but just rotated to have a better view of the staging. And you see here the result. We had an inter-rater reliability in the group of 75% and intra-rater reliability about 90%, which is a very good result for a system. And since the time, most of the paper dedicated to tumor use this system, and really now they use even without citing the original paper, and this means that it is a little bit entered in the mentality. And based on this system, we can plan the en-bloc resection. As I wrote some years ago this paper, proposing the application of the system to decide if it is better to perform only anterior approach, only posterior, or combination of anterior and posterior. So I think that this is, the validity of the system today.
So, 2020 cases, it's a phenomenal number. So you must have seen a lot of cases, and almost all variety of cases you must have seen. So can you share some of the challenging cases which you have encountered in your life?
So as I told you before, now I have the idea to show you two cases. So I can show how we plan and perform surgery.
So you're going to start with the slide showing the en-bloc resection WBB system?
Yes.
Which was the last slide in the previous question?
Yeah. You can see, you see now?
Yeah.
Okay. So let's consider to have, we have different possibility. Obviously, when you have to perform en-bloc resection, you must think in 3 dimensions. And you must imagine that there is a tumor, and you must remove it with a good margin, with a shell of healthy tissue around it. So you must think in 3 dimensions and decide it better only anterior, only posterior, first anterior and then posterior, or different combination. So the idea is to define the criteria of feasibility. So for example, the combination of anterior first and posterior second is a good option, for example, for eccentrical cervical tumor. But we need that there is a part of the anterior of the vertebral body, sector 76, tumor-free. Obviously, we have to consider, if it is eccentric, to sacrifice nerve roots and vertebral artery. Obviously, if the tumor is inside the canal, we have a high risk of contamination. And another criteria, very important, which is a basic criteria for having en-bloc resection, we need that at least 2 or 3 sectors in the posterior vertebra should be free of tumor. So let's see an example. With an example, everything is easier. So this is a recurrent chondrosarcoma in the cervical spine, C5 and C6. So you can see that is going from sector 11 to sector 8. Okay, so we have sector 7, the sector 6, which are tumor-free, and the vertebral artery and nerve root will be sacrificed necessarily, otherwise we enter in the tumor, so they should be sacrificed to have a good margin. It's a Bitsky one, so the risk of contamination in the canal is very low. And a big 3 or 4 segment of the posterior elements are free, so we have a good access to the canal from posterior. So let's see how we perform. So first anterior approach, right anterolateral approach, and this allow us to do a typical release of a neurovascular bundle, but then we have to go all around the tumor without touching the tumor. So we have to leave muscles over the tumor mass, and then from posterior and anterior to have a very wide approach, as you can see here. And then we reach the anterior part of the vertebral body, and here we use an ultrasound scalpel to create a groove in the vertebral body, okay, reaching the canal. Then we can position as a bridge a plate, but we have not detached anything. It is still there, okay? And then we rotate the patient. Here you see what we have already done. A long posterior midline incision, so we can prepare the lamina from one side, but on the other side, we have to go over the muscle again, never seeing the tumor, and to touch where we have around from anterior part, where we have reached from the anterior part. Then we can do the laminectomy, enter in the canal, sacrifice the nerve root. You see here, these nerve roots must be sacrificed completely in order not to enter in the tumor. And then sacrificing the nerve root, we can displace the dural sac and arrive on the vertebral body and finalize the sagittal resection. You see here the sagittal resection, the posterior part, the posterior wall, and this is a huge tumor. You can imagine that the vertebral artery is some part here, and the nerve root have been cut inside here. So this is the specimen. You see that it is completely covered by tissue. Here the osteotomy. There's a 3 vertebral body resected en bloc with a good anterior and posterior fusion. And this was a quite good result even from an oncological point of view, as we have a 5 years follow-up without any evidence of disease. Let me show quickly another case of combination of anterior and posterior approach, which is always a good idea when the tumor is growing anteriorly. If the tumor is growing anteriorly, you cannot go only by posterior, otherwise you enter in the tumor. So you must always remind that this is an oncological procedure. So we must first think to the tumor. We must remove the tumor, but covered by healthy tissue. So the criteria was fulfilled, for example, in this case, with the thoracic case, 4-5 levels. The sector involved are 9 to 5, layer A to C, okay, the canal is not involved, and one of the pedicle is free from tumor. So first we started with anterior approach, separating the aorta, ones that ligated and sacrificed the segmental vessels, and then the esophagus anteriorly. You see here that the pleura has been left over the tumor, and this is the aorta. And here you can see the chisel here and here that start the osteotomy from anterior above and below the tumor mass to have a good margin. And then we can go posterior and perform a wide laminectomy, as I showed before, sacrifice the nerve root, and finalize the en-bloc resection. You can see here, you can see the nerve root that has been sacrificed, the reconstruction with a cage and a rib. And you see here the 4-level en-bloc resection with the canal, and the tumor is still covered. It's very thin, but it is covered. And see here the CT scan. Here we had a problem in the reconstruction. Later on, maybe we can speak about problems, complications. That we have always some problem. If you don't think something you are punished. For example, in this case, we have used a too thin cage anteriorly, so there was not a good anterior construction. So we have a breakage of a rod. We doubled the rod, but it broke again after 6 years. And then we used a much stronger rod with some grafting. And hopefully, and thanks to God, we had 9-year follow-up without evidence of disease, with a stable situation. So it's a success from an oncological point of view. But the success is really connected with a good planning, which I think is the most important point.
Amazing cases, and it shows the master in action. Like seeing all these things, what would be your advice to the young spine surgeons who want to take up spine tumor as their career?
Well, as you told before, this is not easy. This is not an easy field of application. It's something that take you all the day in the operating room, all the day in the hospital, but especially also out of the hospital. You arrive at home and it remains in your mind. And if you have to plan a surgery like this, it takes a lot of time. And usually when I have a En-bloc resection, since the beginning, and even now, I spend 1 or 2 weeks always thinking to every step of the procedure, and so you have not even a time where you are free. So you must have a passion for that, and the passion should drive your work. And once you have this passion, it is a great satisfaction to do this difficult job. But you must be prepared to the complication that you can have, which are really very severe, and it is something that takes you so much. So I hope that there will be some young surgeon willing to take this road, and I am willing to help in any way if I can be helpful. But I think that if one has this passion, he should use this. He or she should use this passion to improve on this way.
I think that is the answer. Passion and dedication is the main thing, which I think will. But the problem is, when you have failures, especially in the spine tumor surgery. So you actually go back, like you climb 2 steps and then you go back by 4 steps or 5 steps when you have a failure. So how do you and especially these failures are quite common with spine tumor surgery. So how do you face the failures?
Well, failures are really a daily problem, as this surgery is so complicated, involved so many different organs, that you have to be prepared. But even if you are prepared, you have to suffer for that. And what is really the big limit? That even after so many years, you can have a different complication. As experience is not enough to prevent other mistake, or even forgetting a small detail. And the small detail is something that brings you away. So if you want, I can show you one of my nightmares, and really something that has remained in my life. But I have, unfortunately, many cases where we had the problems. But the point is not only to have the problems, but to be able to solve it as soon as they arrive. This is, I hope you can see this slide. A 61 years old, so a young man, but is a cardiovascular pathology is already present. He was a professor at the University of Milano, and he had some pain 6 months, and I saw him 13 years ago, 2007. So it's a small tumor. You see a lesion with a good margin, and you see in the MRI that it's entering the canal. So it's not a big tumor, and it's very, very difficult to understand it is benign or this malignant. So we did a biopsy, and the biopsy result is low-grade malignant tumor, is low-grade central chondrosarcoma. And so the question is what to do. So sometimes there is people that in cases like this would like to do mini invasive surgery, or maybe wait if it grows, or only radiosurgery. There is now the willing to do maybe some local surgery and vertebroplasty, local mini invasive surgery, or intralesional excision, or finally En-bloc resection. So we try to find an indication from the experience. This is what we do every time. And this is our collection at that time of chondrosarcoma in the spine was 47, 13 years ago. And from the experience we had till that time, that only En-bloc resection with a good margin could guarantee a good result in terms of local recurrence and survival. You can see that all these patients submitted to En-bloc resection with a good margin are survival, disease-free, with a maximum of 282 months, so more than 20 years. Otherwise, if we do mini invasive surgery or intralesion and radiation, maybe you can have some good result, but the rate is lower. So the indication to En-bloc resection is evidence-based and should be performed every time is possible. So the limit is that sometimes an En-bloc resection, even if relatively easy, like in this case, can have some surprise, and would like to show you. So for this case, it was a T12 tumor. You know that in T12, there are the attachment of the diaphragm. And so only by posterior approach, you can have problems to separate the diaphragm from the vertebra. So the idea was to do first an anterior approach. You can see here, we have done the discectomy here and here. We have already released the diaphragm. And then by posterior approach, we do the typical Rockamillo Tomita technique at this point with this malleable retractor that go around the vertebral body. And then we separated the dural sac from the vertebral body, ligating the nerve roots, disc section, and this is an En-bloc resection. So everybody's happy. As we did the En-bloc resection, there is a good margin. The tumor has never been touched. But to achieve that, we had a very profuse bleeding. The patient was very difficult to keep a good balance, cardiovascular balance. It was 10-hour surgery with 3 liters of blood loss. And so after 2 days, they called me during the night in the hospital, and the patient was experiencing some motor weakness. Is 1 on 5 on the left, 3 on 5 on the right. So I opened the surgical room in the night, and we have evacuated, removed the hematoma with a good recovering of motor function. But after 7 days, there was a urinary infection with a very high fever, and so we started antibiotic treatment, but didn't prevent from a systemic sepsis. After 14 days from surgery, you can see here a collection of purulent liquid around the vertebral resection site. So really a disaster, as the patient was a sepsis with the problems in moving the legs. And so we did a drainage of the purulent cavity, 200 cc, and we had a small improving of the situation. But after a few days, there was another worsening of the general status with the paraplegic. So we bring the patient again in the operating room. We did a debridement. We removed the stackable cage. We replaced with a titanium cage filled with gentamicin beads. We found that there was also a dural lesion, and so we had to repair it. And then we go on with antibiotic culture-guided treatment with a lot of antibiotic after isolating Escherichia coli and Staphylococcus aureus. And so it looked like a little bit better, but 1 week later, again, paraplegic and worsening of the general status and purulent liquid coming out even from the anterior incision. So you can imagine the disaster. You can imagine that in all these days, it was very difficult for me to sleep. I had only this in my mind. So it was very, very difficult to consider which doing different. And it was still leaking of the liquid even after the third surgical revision. So we did another debridement from both wounds, anterior and posterior. We did another repair as the dura was really breaking as soon as we touching. And we put also some tobramycin beads. You can see here the CSF that is coming out together with the liquid. So we put some tobramycin beads locally. And this was the post-operative picture after this time. So hopefully after 4 revision and after weeks of antibiotic treatment, things were going a little bit better. There was a neurological slow improvement and no clinical sign of infection. You see here that the cage is still stable together with troposidin beads. And I can tell you that after 2 years, the situation was not so bad. The patient had some sagittal imbalance, but it was he was back to full activity. He was working as a professor. The pain was very well controlled. It's not an excellent result, but it was not died and was still working. What is the story later? He had a myocardial infarction in 2013, so 5 years after the surgery, which limited the activity. And after 3 years, in October 16, it means 8 years after the vertebrectomy, he had a recurrence of the local infection. It is really unbelievable, but it's really what unexpected situation. It was impossible to do anything due to the cardiovascular problem, and he died for a cardiovascular disease in January 17, so 9 years after the En-bloc resection. So this is what we can expect in this kind of surgery, that even if you try to do all the best you can do, but you can have infection, cardiovascular problem, and obviously the compression on the dural sac. So really difficult, and difficult to find in the literature as how you can describe this case. Every case is different, and every disaster is different. But if you want to work in this subject, you must be prepared to have cases like this.
I think you should be really hard in your, strong in your heart and mind to face all these conditions.
Yes.
So how do you manage your work-life balance? Because it seems that most of the time you are in the hospital.
I have already given the answer. The answer is that you have not anymore your private life, as it's almost impossible, at least for me it's impossible to separate my mind from these problems. So I arrive at home, and it's difficult that I can have another idea, have another thing. And you can imagine that now that I am close to thinking that I have to stop working before or later. We have a time that you should stop, but if I stop doing that, I don't know what to do, as I have no hobby. All my life was concentrated only in this activity, and so I cannot go fishing, I cannot go golf, I cannot do anything else than prepare a slide for you, for example.
Amazing, Professor, amazing. You have dedicated your whole life for this surgeries, and which has brought us so much of activity in us. Like, we can do so much on seeing you and learning from you. So thank you very much, Professor Boriani, for taking your time. And I hope there'll be a lot of questions from the audience. And I would like you to answer those questions if you can. Thank you very much, Professor Boriani.
Thank you very much. It was really a great pleasure. Thank you very much for your question and for interest in my life. Thank you very much.
Thank you.
Thank you, Dr. Boriani. This is Dr. Verma here. I would like to involve my co-moderator, Dr. Sajishman, if he's around. As people go on to start off questionnaire, can I start off with the first one? I'll start with something extracurricular. You said that for so many years, you've been doing such high intense work. All of us have something to wind up and stress buster. What do you use as your stress buster to go back to work the next day? Music? Anything that you do different?
Yes, music. Music is always very helpful indeed. You're right. But
what about some exercises? Because the kind of time that you spend in the OR for hours together, how do you stay so fit? I mean,
yeah, I have never been so much dedicated to exercise. Only recently, I had to replace my left hip. And so I'm compelled now to exercise, to do bicycle every day. Otherwise, my hip is painful. So as a patient, I am better than as a surgeon.
The audience, the panelists, anybody with a question?
There are lots of questions from the audience. If you could stay around, and there will be on the chat box, and maybe you could answer some questions over there as we move on, as we are short of time. And Raghu, would you please like to do the needful?
Yeah, sure. So can we invite the next talk, which is Dr. Rohit Amritandan, who is interviewing Dr. Michael Fehlings.
A very good evening to all of you, to all the delegates and senior colleagues. It's a pleasure to have you all on board for this edition of the ASSI Conference 2021. I trust you all have had a safe year and a happy new year to all of you. We have a wonderful opportunity here today to sit down and have an open discussion with legends in spine surgery. And I can think of no one who fits the description more aptly than Dr. Fehlings. Dr. Fehlings is an internationally known spine surgeon. He is a highly revered figure in the field of neurosurgery and spine surgery. He is currently professor of neurosurgery at the University of Toronto. He is vice chair of research at the university and is also the co-director of the Spine Fellowship Program. Dr. Fehlings balances a very busy clinical practice where he performs complex spine surgery alongside cutting-edge research program. He heads a multidisciplinary team of researchers looking into novel treatment options for both traumatic as well as non-traumatic spinal cord injury. He has been the recipient of a very, very long list of awards and accolades, too long for us to fit into this 20-minute session. He also has 900 peer-reviewed publications to his credit. In addition to all this, all of us who've had the distinction of being Dr. Fehlings' fellows know that he is an avid skier and a great host. Dr. Fehlings, welcome aboard, and thank you so much for sparing time to be with us. I know that everybody in this audience knows you well. You have been a frequent flyer to India. You've traveled to Chennai, Mumbai. I know that you've been to Agra. Now, we welcome you back to India virtually. Now, over the next 20 odd minutes, we've decided that we will engage with you on 3 topics. The first one is some of your thoughts on recent updates in the management of traumatic spinal cord injury. Do let us know what your team and yourself, what new updates have been. As you're aware, traffic in India is chaotic. We have a lot of road traffic accidents, and a lot of our patients want to know what is path breaking, what's up to date, and we'd like to hear from you on that. We'd then move on to some of your recent thoughts on the RECO DCM project, as well as other updates on the management of degenerative cervical myelopathy, particularly when you have old and frail patients, which most of them are, but your experiences on the nuances of management of such patients. And then we'd end the session with your advice to us on how you've managed to balance your career as a preeminent surgeon scientist. So welcome, and I'd hand over the session to you, and I'd ask you to first share your thoughts about current updates in the management of spinal cord injury. Dr. Fehlings.
Thank you very much for the kind remarks and for the invitation to take part in this ASSI session. And Rohit, it's a particular pleasure to have the opportunity to have this discussion with you. It's wonderful for me to see your own successes and many fellows that I've trained who are in India. And it's wonderful to have developed these friendships with India. So on the topic of spinal cord injury. What's new? What's hot? Where are we going? The role and timing of surgical intervention for spinal cord injury has evolved considerably from where patients were generally managed non-operatively, and then if surgery was done, it was done generally in a delayed fashion. We've now evolved. In late December of last year, so just less than a month ago, our group published a major article in Lancet Neurology where we did an analysis on over 1,500 patients prospectively accrued with all forms of traumatic spinal cord injury. And we showed very clearly and quantitatively that early surgical intervention within 24 hours was associated with significant improvements in motor recovery, sensory recovery, and conversion on the Asia impairment scale. And for the first time, within the first 24 hours, we were actually to show a linear relationship between the timing of intervention and recovery. So I think that this paper really nails the question of whether decompression helps and whether early decompression is of value. Now, the challenge is how to apply this knowledge. There are major logistical challenges. The patients are sick. In countries such as India, there can be transportation issues. Sometimes centers can be overwhelmed with the numbers of patients that arrive, and the logistics too need to be ironed out. But what is clear is that surgical intervention is of assistance. And I think the challenges now are to look at practical approaches to translate this knowledge and to develop the systems in place to facilitate transportation of the patients and access to the operating theaters and the imaging studies to do this. This work also validates the concept that time is spine. So the timing of intervention becomes critical. And we have seen the impact of such interventions in stroke, where the early interventions for stroke, for example, with antithrombolytic therapies, have had a dramatic impact on outcome. And so I think that this is going to be our next challenge over the next 5 to 10 years. In addition, from a surgical perspective, we still need to consider what represents inadequate decompression, what is the role of postoperative imaging, and what is the role of more advanced monitoring approaches. So, for example, there has been work done on duroplasty. So should duroplasty be done in patients with an acute spinal cord injury? Probably not in everyone, but perhaps there's a subset of patients. High-resolution intraoperative ultrasound could be an approach that could facilitate this. What about the use of intrathecal catheters to measure intraspinal pressures, potentially to drain cerebrospinal fluid, and to treat an acute spinal cord injury in an analogous fashion to how a traumatic brain injury is treated, where we have catheters to measure pressure and we can titrate blood pressure management specifically to the patient as opposed to guessing on the numbers. And the hemodynamic management in the acute phase will likely undergo intervention. As a first principle, it has been suggested that hypertensive management be used for 7 days. But do all patients require this? Will all patients tolerate this? Well, a patient with recovering incomplete spinal cord injury probably does not need 7 days of hypertensive management. And generally, we would use such management for about 2 to 3 days. And then what about older patients that may have less tolerance for inotropic agents? So I think the intensive management will evolve. And I mention this because this is very practical. This is something that we can do now and that really needs to be looked at. And this is also a shout out to the trainees in the audience, that these are questions that one can look at. And while the application of this can be challenging in the huge Indian subcontinent, nonetheless, I think one should aspire to try to elevate the level of treatment. So what else is going on in the field of spinal cord injury? Well, there are advances in rehabilitation, for sure. And we now recognize that targeted physical therapy and electrical stimulation can potentially facilitate repair in neural plasticity. So, for example, hand and upper extremity function in a quadriplegic individual, it's now recognized that therapeutic and functional electrical stimulation in the upper extremity can act in combination with intensive rehabilitation, can facilitate partial recovery of hand and upper extremity function. And if you combine this with a good decompression and surgical stabilization, this really could have an impact on patients. And then longer term, I see a new specialty arising in spine surgery, and this is where we see surgeons who perhaps have dual training in spine surgery and in functional neurosurgery. So what do I mean by this? So for example, the use of electrical stimulation applied extradurally in the thoracolumbar area of the spine to stimulate the locomotor central pattern generators to facilitate recovery of walking. So to be able to do this, and this requires good research to validate this. Right now, I think this is an interesting concept, but there's been no randomized trial. We have not seen this validated. But nonetheless, the science behind this is quite good. So to do this, one needs surgeons who understand spine surgery, understand spinal cord injury, but also have the skill sets to do the functional neurosurgical aspects of this. So that becomes an interesting area in evolution. Now, where are we with regenerative medicine and the application to patients with spinal cord injury? And Rohit, I'm sure you have many patients coming into your practice years after an injury. I do as well. And to be frank, right now in 2021, we don't have a lot to offer these patients that's truly validated. And I think we need to be clear about this. But what's on the horizon? We're at an inflection point in regenerative medicine, and the science is now remarkable. And so here's where we are and where we're going to be going in the next 5 years. We have now the ability to generate customized neural stem cells for any person that are specific for that person, using either direct reprogramming or induced pluripotent cell technologies. And so you could take a blood cell or a bone marrow cell, expand this in culture, and make this into a neural stem cell. But in addition, there are technologies now where the cells can be genetically engineered to release factors that will degrade the glial scar in a chronic injury, and also release growth factors to facilitate the integration into the neural environment and the reconstruction of neural circuits. And this work is now in late stage preclinical development. Our group in Toronto is leading this along with other groups around the world. And I anticipate in the next few years, we will be seeing significant advances in the application of these advanced regenerative technologies to people. Coming back to the acute injury, where are we with neuroprotective drugs? And I've been very actively involved with trying to translate an existing therapeutic called riluzole. Riluzole is used by the neurologists for ALS, and it reduces nerve cell degeneration. Well, we're 2/3 of the way through the recruitment in a major randomized trial called the RISCUS trial. So riluzole in spinal cord injury study. We've got 193 patients recruited. We had to stop enrollment for a few months because of COVID. And so we took the opportunity to undertake a pre-planned interim analysis of the data. And I'm excited to reveal that the data look very promising. and we have a positive signal, and we've been strongly encouraged to continue enrollment in that study. So it's possible that clinicians in a few years will have an effective neuroprotective drug, which could help also to facilitate neural repair and plasticity. So maybe I'll just stop there. There are many other advances that are occurring, but that might give a nutshell perspective on where I see the field evolving.
I have thank you for that. I have two quick remarks to make to you. The first is that I remember in 2014, I think it must have been the month of May, April or May, we had, there was a patient who had presented to the hospital, and under your leadership, the team had proceeded with stem cell therapy for a lady who had a spinal cord injury. How did that pan out over the next many years? I mean,
oh, yes. So thank you for reminding me about that. And I continue to follow these patients. So this was one of the first examples of a high-level trial with what I might call the first generation of neural stem cells. The patient in question showed a modest level of neurological recovery. She recovered some sensation. Unfortunately, this did not translate into meaningful functional recovery for her. We've recently published the results of these data, and this was done in collaboration with Armin Kurt in Zurich and a number of other investigators around the world. These were allogeneic neural stem cells from a cell bank, so they weren't matched to the patient, and they were not genetically modified to alter the environment. So what this showed us was that we could safely introduce the cells. There were no adverse consequences in the patients, and there was evidence in most patients of some neurological changes. However, the changes that we observed were modest. The patient I'm describing was typical. So what have we learned from this? So we've learned that we can do this safely, and the regulatory authorities now accept this as a legitimate area of investigation. But we've also learned the limitations of the neural stem cells. So they help, but they're not the magic cure-all. And it's now recognized what additional improvements need to be made to the neural stem cells. And specifically, I think there's an advantage to having a personalized approach where you're using the person's own stem cells that are genetically engineered. And then secondly, I think it's important that the cells are engineered to overcome the inhibitory microenvironment, either the glial scar or various inhibitory factors that are in the spinal cord. And so scientists have now gone back to the bench to try to figure this out. There have been many scientific advances that have occurred, and we're now seeing a number of groups, ourselves in Toronto, groups in Japan and in California, are starting to advance this into early phase preclinical trials. And then I envision over the next couple of years, we're going to be seeing clinical trials emerging in this area.
Thank you so much, Dr. Fehlings, for that quick overview. I know that this is an exhaustive topic. You've spent, a lifetime doing this work, and 6 minutes never does justice to this. I appreciate that, and I also appreciate you for the time that you spent. We have a couple of minutes left, and I'm going to quickly race you through DCM. I mean, is there, in 1 minute, can you tell us, what's updated now on the DCM front, on non-traumatic spinal cord injury?
So it's recognized that degenerative cervical myelopathy is the commonest cause of non-traumatic spinal cord injury and spinal cord impairment in the world. So we now have an overarching term which encompasses things such as cervical spondylotic myelopathy, OPLL, and we're trying to unite the field to raise awareness. And so one of the biggest issues here is to raise awareness among patients, among general practitioners. Surgical treatment is effective, And for people with moderate and severe impairment, it's imperative really that these patients be treated in as early a fashion as possible. The conundrum that we're faced with is how to manage mild cervical myelopathy, the patients that come in with impressive imaging findings, but very little to find on a clinical examination. And right now, the best that we can do is to follow the patients and then to consider things on an individual basis through a shared decision-making approach. But what's going to be coming forward is that we will be able to have imaging biomarkers as well as serological and genetic biomarkers that are going to be able to allow targeted treatment. So, for example, some of the imaging biomarkers relate to microstructural MRI, and we've recently published work showing that a metric called T2 star, white matter to gray matter signal ratio, is quite helpful in discerning patients who are at higher risk for neurological deterioration. And it's recognized that there are certain genetic biomarkers which can predict outcomes. We have a paper coming out in Brain on the use of microRNAs, and these can be measured in patients. And so patients who express certain types of microRNAs are at higher risk for deterioration. And so potentially through a blood test and through an MRI examination, you can now, in the future, counsel patients in terms of this, the recovery. Riluzole has also been studied in DCM, and in December of last year, we also published the results of our CSM Protect randomized trial with riluzole. And we found that while there was not an added benefit to recovery on the MGOA scale, interestingly, the patients who received riluzole had better outcomes with regard to pain, which was a bit unexpected, but it actually makes sense. And so riluzole is, I think, an option that I would invite physicians to look at, particularly in those with neuropathic pain. And this could be something that could have an added benefit to our patients. Finally, a shout out to a project called RECODE, which is an effort being led by AO Spine International in collaboration with a former fellow of mine, Mark Cotter at Cambridge University. And through RECODE, we are embarking on a knowledge translation process to raise awareness of degenerative cervical myelopathy, to identify critical research priorities, and then also to develop a minimal core data set that can be used by researchers and clinicians to collect data and to advance the field.
Thank you very much, Dr. Fehlings. Thank you so much. We're running out of time. I expected this. You expected this. I sort of just want to summarize the session. Thank you for your comments on early surgery. Thank you for your reminder to all of us in India that we need to sort of have smoother transport systems in place where patients have better imaging access. Your comments about riluzole are well received. I know it's not an expensive drug. I know that our neurologists use it for ALS, and so we have access to it. The RECODE DCM emails have been obviously accessible to us. Mark Cotter has been one of my co-fellow post-assessors at Toronto, and the program I know runs well under your guidance, and Mark and Benjamin Davis have been doing a great job there. The article by Fehlings, Badiwala et al. On early DCM and surgery was read at one of our journal clubs, and it was very well received at our paper reading, and thank you very much for that. So we will have the floor open to our delegates. If any of you have questions for Dr. Fehlings, please field them in the chat box, and then we will try and pass them on to Dr. Fehlings. And if there are questions that he will answer, then we will certainly share them with you. Thank you very much once again. Good morning to Dr. Fehlings, and good evening and good night to everybody here in India. Thank you very much.
Thank you very much.
Thank you, Dr. Fehlings. Thank you, Rohit. That was a wonderful interview and a lot of insights into pathologies of the spinal cord and degenerative cervical myelopathy. Dr. Fehlings, we would be grateful if you could be around for the next 10 minutes or so, because there will be questions on the chat box which will start coming slowly, and then there will be a huge rush of questions which people will want to ask you. So if you could stay back, and we would move on to the next interview, and that is of Dr. V.J. Laheri and Dr. Atul Goel, Head of Department of Orthopedic Surgery and Neurosurgery at KEM Hospital in Bombay. And they will be interviewed by their student and now a teacher in his own right, Dr. Samir Dalvi. Can we have the interview, please?
Okay, gentlemen, we are here today with two of the legends and the giants of spine surgery of the scene, not just in India, but internationally. We have with us Professor Dr. V.J. Laheri and Professor Dr. Atul Goel. And we aim to bring out the genius in them as well as how they interact together. So these are our giants for today. Both of them started their journey the same way. They started that at Nayar Hospital and then built it up and went on to build up their careers in this hospital, which is the St. G.S. Medical College in KEM Hospital, which is even my alumnus. Professor Dr. Laheri, my mentor and the mentor to a huge bunch of spine surgeons coming out of there. We owe everything to him. Started in a very small town called Radhanpur in Kutch, which a family meant basically surrounded with diamonds. But this diamond came out of that and went into medicine. He started at the Nayar Hospital or the TN Medical College, went into orthopedics with his mentors, Dr. Tanna, Dr. Chaubal, and Dr. Talwalkar. And of course, his main guru was Dr. K.T. Dholakia. He didn't directly work with him, but he was his Dronacharya. He inspired him to go on to larger things. And when he started doing spine, this case probably is what led him into specialty spine surgery. A simple case of disc surgery, which went into discitis, but he ended having to fuse him and thus started the journey of the PLIF. And he and PLIF is what catapulted spine into the midline. This is really his Matrubhumi, or where he learned everything, in the cadaver room, in the dissection. And as this is something which brought him and Atul together, because Atul Goel was there at the same time and they worked together in the cadaver room. He did things which people had never heard of or never dreamt of. And people thought these screws transfixed the spine. And he then came on the international stage at this point at the Goa conference where Art Steffi came. And Art Steffi and everyone was amazed at the x-rays which he showed. And these are vintage x-rays of feet which were completely unheard of in those days. And his x-rays and his pictures left everyone speechless. But this is finally what got these two together. And this is what it's all about, the C1, C2 fixation, which we all know him for. So Dr. Laheri is supported in his life by Madam Laheri, Vandana, his wife, who supports him everywhere, not just in the operation theatre, but also at home. And she's like a mother to all of us. And a father to him was Dr. S.K. Pandya, the chief of neurosurgery, who encouraged him to develop spine and again grew that synergy between him and Dr. Atul Goel to make KEM a center of excellence. His thirst for knowledge is what really makes him buzz. And whether it was books earlier or now computers, he continues to read and learn every day. All his students are extremely grateful for him, and he has a huge legacy of spine surgeons in the city of Bombay. And this is what sums him up. I may not have gone where I intended to, but I think I have ended up where I need to be. So this is a very satisfied gentleman. Our other legend of today, Atul Goel, and these two call each other Chote Bhaiya and Bade Bhaiya. And their journey was together. Atul Goel, truly a giant of a person, not on the national scene, but on the international scene, truly representing India in the world of neurosurgery and spinal neurosurgery. He too started his journey at TN and then came to KEM, and their synergy grew there. He is a scientist of the top order, and the number of publications he has is mind-boggling. And he is one of the most highly referenced neurosurgical spine surgeons in the world. Those who have attended his talks knows that he owns the stage, he owns the audience, and he absolutely captivates everybody with the way he presents. But not just that, he's also loved by his patients, especially his pediatric patients for the craniovertebral anomalies, many of whose lives he has changed forever, and who thank him at all stages of life. So Dr. Atul Goel as well is supported by his loving family, his wife and his daughter, very much a family man. But to us, he will and always will remain a giant. And his motto is, I have come here not to answer all the questions, but to question all the answers. And that is a giant kind of step which you have. So now getting on to the question answer session. Professors, welcome to the talk. I'm going to stop sharing my screen now so that we can have all three of you here. Welcome again to this session. The first question, Dr. Laheri, you came from a very small town, Diamonds. Why did you take medicine? Why medicine? Very short.
Samir, it was accidental. I entered in the medicine almost 4 years late than the usual people. And I was not having any direction, so I came in medicine.
Okay, so we can say an accidental wanderer into this field, which now fascinates you so much.
Misguided missile.
Misguided missile. But what a missile, I must say. What I must say. Dr. Goel, what about you? Were you always wanting to be a doctor, or is this something which you just fell into by mistake?
No, to tell you the truth, whether I wanted to be a doctor or whether I didn't want to be a doctor, but my mother knew when I was 6 years old that my son will become a doctor. So this was the premonition that my mother had. And I think that took me and that placed me where I am. Mother's wishes, mother's blessings, and mother's love. And I think
so that's
great.
Very important. So the next question again to Dr. Laheri is, you undertook your journey, medicine, orthopedics, and although I know that you loved everything, you loved joints, you loved trauma, I worked with you, you loved the whole field of orthopedics, but somehow spine was your main love. So what drew you to spine surgery, or what made you specialize in spine surgery?
Samir, my graduation and the post-graduation in the medicine was a total waste. After passing MS, about 3 years, I assisted Dr. Chaubal for the spine surgery. Must be about 300 cases of the lumbar spine surgery with HeLa transverse fusion, listhesis. And his meticulous handling, his integrity, his freedom of the thought, his compassion for the patient. And the spine is a very challenging surgery. In the field of orthopedic, spine is a very challenging. I've seen most of the great surgeons of Mumbai, orthopedic as well as the neurosurgeon. And as I was working with Dr. Chaubal, I developed a very good interest, and that was the only field which was require a very simple thing, good anatomical knowledge, skill, meticulous way, which all I learned in 82, 83, 84. And then it was obvious that I developed a deeper interest in the spine. And especially, I think so, most important thing, patient and my complication. I used to operate spine, and as you have mentioned, I landed up into discitis, which was so difficult to diagnose even at that time. And there was a strong desire to solve the problem of the patient, because all this was the learning from Dr. Chaubal, Dr. Dholakia. They were so sincere to their patient, and that is how I landed up into spine surgery.
So the complications is what drew you to it, because that's amazing. Yes. Because most people run away from complications, but you embraced your complications, ran behind your complications, and found a solution for your complications. So many of the techniques, because I know him personally much better than I know Professor Goel, of course, because I worked with Laheri. I know that every problem and every challenge to him is more fodder to have a better solution. And that's how this man has grown. Dr. Goel, what drew you to spine? Because I know you're a great brain surgeon as well. You do your you do your skull base, and you are so famous without blood loss, without anything. You used to finish the surgeries, but still you're known as a spine surgeon. So what led you to the spine?
See, I'll tell you, Samir, my story of my life. You see, I am not superbly intelligent or master or anything. But what has made me is the hospitals where I have worked. Like KEM Hospital is a mecca of patients and mecca of neurosurgery. It has been and it had been. You know, it has a big legacy with great heroes of neurosurgery. And then I took up the department as head of department in 1998. So now for 24 years, I'm head of department. What really made me was the people with whom I worked. One is, you know, Dr. Manu Kothari, as you know. What a legend of a human being and what a legend of a philosopher. Then, of course, Dr. Pandya and Dr. Venksalkar was supremely interested in craniovertebral junction. And then my real life started with my relationship with Dr. Laheri. In 1982 or 83, when I joined neurosurgery, I joined in 82, I met Dr. Laheri in 83. And you know, this gentleman was an orthopedic surgeon. And we used to both work with under microscope and suture the glove and started suturing. You know, even neurosurgery, microscope was not a popular instrument at that time. And the way Dr. Laheri, you know, was interested in dissection, cadaver dissection, then he got hold of some rabbit and we started doing his femoral artery suturing. And then we started doing cadaver after cadaver after cadaver. You know, I completely believe my stint of my life with Dr. Laheri has really made me where I stand now on his shoulders, actually, to tell you the truth. You see, he was, if you don't know, Samir, he has created a generation of spine surgeons. Absolutely. There was no spine surgery before Dr. Laheri entered into this field. In 1982 and 83, you know, spine surgery was not in the curriculum of orthopedic surgeons at all. And the way Dr. Laheri used to come to neurosurgery department, the way he used to observe the surgeries, you know, he was operating there in orthopedic and coming and spending the afternoon and evenings in neurosurgery department watching surgery. And we used to both watch the surgeries, decompressive laminectomies and discoidectomies. And I remember in 1984, you know, at that time, CT scan and MRI were not in existence. In 1984 or 85, during that period, Dr. Laheri told me, you see, when there is a disc herniation, L5 disc, to do myelogram was also difficult. You know, you cannot introduce myodil from a painful area. So he was discussing with me that it is impossible to, you know, it is not necessary to do myelogram in a case who has L5, L4-5 disc herniation. It is a clinical diagnosis. And you can have a clinical diagnosis and operate without any imaging. This is what he said to me in 1984-85. I think although those things may not be really,
sure,
you know,
but I think it's people who are ahead of their time which cause science to progress. I mean, if you go behind in time, you can't have progress.
Yes.
So, Dr. Laheri, Dr. Laheri, what do you say about this gentleman who calls you his elder brother, and you also always call him your younger brother? And he obviously, you are at different stages, you are different ages at that time. I think you may have already been a lecturer, and he was just a resident. But yet there is something, the synergy between the two of you. So how did you look on him at that time? Truly, today both of you are giants in your own name, but at that time.
Samir, I think so. I was a very giant at that time. Now I am quite calmed down. And I know that everything is having a good part, bad part. Every graph is upgoing, downgoing. Atul was so much interested in learning Of course, he has started signing after 86 or so, when he almost completed his MCH. But as he has told, I think so, in a week, we used to spend 3-4 nights, almost 4 or 5 hours in the mortuary, not cadaver room. Samir, my 90% dissection was in the cadaver, not cadaver, it was in the mortuary. You will surprise, when there was a death, mortuary people used to come and tell me, Dr. Laheri, body ho gaya. That means that there is a dead body in the mortuary. Come, do. And I think so, that was the Indian, this thing as a, we were allowed to do many things without any restriction. And Dr. Atul, he was always with me. And I will tell you few other people, Dr. Rajesh Manyar, Dr. Vinod Agarwal, they were my, mortuary work is not easy work. Now I will never enter in the mortuary because now I cannot tolerate that environment, atmosphere, smell. But that time we were so crazy. And Samir, if you believe, in last 2500, dead body dissection or the dissection was only permitted in the 3rd century BC for 30 years. After it was started again in the time of Vesalius in the 16th century, 15th century. 1600 years, medicine was practiced on the animal, on empiricism, but then the modern medicine started. And I think so, all the learning was in the mortuary. And all these people, Atul and Rajesh and Vinod.
So Dr. Goel, how much would you attribute the mortuary or the cadaver lab to your skills? Because you are also a fantastic surgeon. We've seen you operate. You go so fast that people can't even see what's happening.
Samir, yeah. Samir, I couldn't hear. Can you repeat that?
Sorry. How much do you attribute to the mortuary? Because we have seen your skills as a fantastic surgeon and you are fearless. So how do you? And you never stop bleeding. I think you're used to operating in cadavers who don't bleed. So maybe that's one of the reasons.
The one thing, if I have to give a message from this conversation, is that, of course, you can become good surgeons, you can become brilliant surgeons, but you cannot cross a line unless you have a very huge experience in dissection, in cadaver work.
Yeah.
Cadavers are, from there you begin and you go beyond a line. You see, the dissection which we used to do with Dr. Laheri, of course, the number of dissection of anterior cervical, each and every fiber of the cervical spine, muscle or nerve, were completely rehearsed. Once I'll tell you that we started doing transoral surgery. One in cadaver, we were not allowed to do any other dissection so we were allowed to open his mouth. And Dr. Laheri got that Killen retractor from ENT or somewhere he got. And we opened the mouth. As we opened the mouth of a cadaver, inside there were maggots in the mouth.
Oh.
So we were wondering whether to do or continue the dissection or not. But what Dr. Laheri did, he took a mop and cleaned the maggots. And we started doing dissection. And you will not believe we did the dissection for 5 hours in the night from 11 to late in the morning on cadaver, on transoral surgery. At that time, transoral surgery was quite a popular kind of surgery. And I remember we doing odontoidectomy and then going to the jugular bulb and then reach the styloid process from the mouth. So that kind of beautiful dissection. And I still remember the wonderful learning that we had from the cadavers, and there is no
So it is
question.
extreme dedication. So let me just get you directly to a point which, all of you, which gets every one of us riled up. And that is regarding this article. So this article was published by Jürgen Harms in 2001. I visited him in around 2000. And when he showed me this article, I showed him an X-ray which was there with me, a slide, and his jaw fell down. Because I showed him an X-ray which Dr. Laheri had done in 1984. And then finally, you published, you as well put up this. And this was the article which was published in this was the X-ray. And this was way before it. So what is the story? Like, what is the story behind this? Like, I want to know how this thing got developed.
See, the thing is, this technique was developed.
Yeah. So that was the top picture. The top picture was before Dr. Harms saw your X-ray. And when he saw your X-ray, he went down and his hair became white and his face became ashen after that. When he realized that it was not his technique.
See, we started doing in 1987. Actually, 1987, we actually started doing. And from 1989, you see, Dr. Laheri was not interested in publications and all. I don't think he's still interested. Maybe he doesn't read also. But, in 1989, I wrote a paper on this. 1989, I have those transcripts. And I sent to Journal of Neurosurgery. And it was very heavily rejected. Then I sent to Neurosurgery, Surgical Neurology. I sent to several journals. And for 4 years, that article was being heavily, pushed back. And rejected very vehemently and very aggressively, till the time I managed to publish it in 1994 in Acta Neurochirurgica. And now, as you know, this has become a history, and this is one of the most cited articles in the entire field of spine surgery. And then I tried to, me and Dr. Laheri, we were presenting here and there, and I presented this article on several forums, in several books. And several, in several articles have also been published. And then to our surprise, when Dr. Laheri brought this article of Dr. Harms and showed that he's published the same thing, absolutely same thing. And he has not even referred to our names. So then we, from there, actually, to take away the credit from Harms' publication, that it really, despite my efforts, despite my great efforts to promote this, it was nobody used to even look at it. But when Harms started, and then the various companies started making rods and polyaxial screws and popularized, he had a big role in popularizing it. And then, of course, our names entered into the business, and then the whole thing got,
Dr. Laheri, how did this, because we have really run out of time, but we had so much to cover. Dr. Laheri, how did this procedure got developed? Let's talk about this procedure, because we can't really talk about everything else now.
Samir, after visiting Goa meeting, I realized that I am having very small series of 40 cases, but they were extremely unique cases. Like I have never seen an ankylosing spondylitis, osteotomy, fixation, and in the plaster jacket, or rigid deformity, vertebral resection, fixation. And when I went to Goa, Arthur Steffi, Ralph Cloward, Paul Lean, these people were there, and they told that what you are doing, that is not even allowed to us in United States. Arthur Steffi was doing only lumbar spine. I got a tremendous stimulation, inspiration from them, and I have started developing my cervical and the craniovertebral work further. Before that, I have done this hangman fracture, which I was forced to do because he was having a maxillofacial injuries. Anesthetist told that if his C1, C2 is stable, we can anesthetize him for the maxillofacial surgery. I told Dr. Khanna, sir, give me 5 days. I will explore the possibility that whether I can do it or not. And in 1987, I did the hangman fracture fixation. And of course, many times at that time, literature was not easily available. Later on, I found it out that Megel is also doing this procedure. He was a bit earlier than us. But I developed a cervical spine interest, and then the mortuary, and then the experimenting, doing it, and then after coming back from the Goa, I thought that now I am having a very good work on the cervical spine. I must, as I know, proceed further, and that is how I have developed a C1, C2 fixation. I have developed it, but it is a Atul who was having a very, very, very strong mind and approach. Okay, our article should get published. It is a work from the city of Bombay, from Nair and KEM. It must go in the literature as a landmark article, and that is how I land up into cervical spine work.
So we have to be really proud that actually the C1, C2, this whole area, which is like a mystery area to everybody, has been demystified by the synergy of the both of you. Elder brother and younger brother working together, each one in their own roles. Elder brother may be thinking, younger brother supporting, and younger brother publishing. Would that be a right? Way to
Just to summarize, screws. What are screws? Even several neurosurgeons till date do not know screws. What are screws?
Yeah,
you understand. So screws was a mystery in even spine surgeon, even orthopedic surgeons at that time. Of course, screws were a mystery till the time Dr. Laheri got interested, and Dr. Laheri and the world got interested in screws. See, and craniovertebral junction was, during that time, was a mystery for everybody. Even today it is a mystery, but at that time it was mystery. So if you can call a synergy, because Dr. Vengsarkar, with whom I used to work, was also very much interested in craniovertebral junction. Dr. Laheri used to come to, we used to do decompression, and he was very interested in syringomyelia and all those things. So the screws and craniovertebral junction and the whole thing got together into this beautiful artwork. And I think there is no question in my mind that this has given life and wonderful life to so many people in the world, that there is, we can be very happy and proud of this contribution.
Absolutely. Thousands of patients, lakhs of patients are benefiting by your research and your hard work. So we are really way beyond time, and I had so many questions. I could really chat to you for 3 or 4 hours, but the organizers has given only 20 minutes, which have already overshadowed. So we're just going to end this by a quick fire round, like Karan Johar. So both of you have to answer this one after the other. Dr. Laheri, being senior, will be given first. First question is, money or fame? What is more important?
Nothing, Samir.
Neither. Dr. Goel.
No fame, no money, absolute work. What Laheri said is the crux, is the basis of our, growth together.
Okay, Dr. Goel, what is more important to you, publication or patient outcome?
Absolutely patient outcome, no question about that. No question, no doctor.
But you have got thousands of publications.
So that is a byproduct of, if your patients are all right.
Dr. Laheri, your answer, I know, because you have not made any publication.
I cannot write one sentence properly. I cannot speak more than 3 lines properly. So I am not a writer. I am not a publisher. But many people who are working with me, Atul, you, Kshitij. Dr. Mihir Bapat, Dr. Kshitij Chaudhary, they have done job for me. I will tell you one thing. Rashid Juma told me, "Jungle mein mor nacha kisi ne na dekha." डॉक्टर लेरी इतना आप बोलते हो, ये किया वो किया, डिस्काइटिस किया, ऑस्टियोटोमी किया, डिफॉर्मिटी किया, C1 C2 किया, बोलता है किधर, एविडेंस किधर है? And I told him that I can't do it. But these are the people. You are the people. You people are the people who has brought me, at least because of Atul and his publication, our method has become one of the most landmark. Otherwise, C1 C2 is a 1% of the spine, and that also very few people are interested. but it has put us in the very different category.
Okay, next question, sir. Private institute or KM?
Samir, it is very difficult to answer. Still, I travel in the bus and the train. So you can say that KSI, yes, work is a great satisfaction. And I think so, I am a very different kind of a person. My mother or my wife demand anything, I tell that, sorry, I cannot give you this.
Dr. Goel,
but I think I cannot answer this question.
Yeah, I can very easily answer this question that KM is my mother, KM is my life, and KM has brought me where I stand. KM has given me work, KM has given me people like Dr. Laheri and other people to work with. KM has given me a girlfriend and later she became my wife. And she has given me my family. And KM is my everything. And KM, if I am without KM, I will be absolutely, I will make money, maybe good cars and good house, which I still don't have. And I want to have very soon, maybe. But KM, there is no question, Samir, I miss you in KM. You were a KM boy. And of course, you have done good work. You have done fantastic work, which are unusual. Your kind of people in private hospitals are unusual people who have done good work. But I am not as talented as you have been and how you have done, promoted your spine, promoted your work and achieved what you have achieved. But for me, if you ask me, KEM has been the key factor.
And the last quick fire, Dr. Laheri, starting with you, health or work? What is more important?
I mean, health is important because I have gone through the few problems, which has also, forced me to go slow. Otherwise, 4 or 5 days in the mortuary, it will kill you. And this I have done 3-4 years till I was caught and given a memo. If you are seen in the mortuary again, you will be suspended from your job.
Dr. Goel, health or work?
See, health is absolutely important. Only you can work if you are healthy. And my feeling is to work properly, you have to be fit and fine. And you have to exercise your body. And recently, if you don't know, Samir, my work on rest of the spine, craniovertebral, of course, is there. Rest of the spine, now my work is very beautiful work on degenerative spine, on OPLL. I wish you sometime invite me to talk on those subjects.
Sure.
And my work is now focused on, human standing position and how the muscles maintain your whole attire and how the muscles, if you don't exercise, lead you to degenerative spine and OPLL and Hirayama disease and Chiari malformation and syringomyelia. So I have related all these anomalies and pathologies to one problem, and that problem is your muscle weakness and your neglect of your body. I think
so health is the most important.
Yeah, absolutely.
So as I said, we are completely out of time, but we just want to end.
Samir, one minute.
Sure. Yeah.
Samir, my wealth is I will not say my student, but my colleagues. I think so. They are so brilliant. They are so perfect. They are so systematic. And their integrity is also high class. I think so. I am always happy that I had such a great, highly competent people. I was very dull and the foolish, sort of. But I was able to manage all these people quite well.
Okay. And Dr. Goel, from you, a last concluding words. I just want 1 or 2 sentences, not more, advice to the juniors who are listening, for them to set up their careers up. Just 2 lines. Guru Killi. I just want the Guru Killi.
My one big sentence is that you keep high aims. Low aim is a crime, not failure, but low aim is a crime. Right. You see, you will be surprised. There was a small kind of written sentence in Dr. Ravi Ramakant, who is also one of the great legends and one of the inspirers of mine, and Dr. Laheri's good friend. In his room, it was written, low aim is a crime, not failure. I think we can do it and we should do it. There is no way we cannot do with such huge workload, such number of patients, such diverse pathologies, such complex pathologies. If we are not able to do, nobody can do. If you have that feeling, if you have that ambitiousness, you can certainly do it, and particularly do it in India.
Perfect. So, guys, we have learned so much from them today. We have learned what is dedication, hard work, slogging in the cadaver room. We have learned the value of thinking ahead of your times, innovations. We have also learned the value of publishing our work to get international acclaim and to aim high. At the same time, respect your health, respect your colleagues, and respect your juniors. Indeed, guys, we are fortunate to have such giants and legends in the spine scene in India. And as an inspiration to us, we will strive harder, and we owe it to them to do better. So thank you, everyone. And this is the last topic of the day. So I wish all of you good night.
So thank you, Samir. If I can just wind up with a few words which I want to incorporate. To all the four legends, thank you very much for their articulate presentations of how they have evolved in their careers. As Dr. Goel put it, with ambition and with passion. Also, how well they use their colleagues and their mentors to their benefit. And to improve and vast experience in the field of their interest. They kept pursuing what they wanted to. And they have surpassed difficulties, faced complications to be where they are with great finesse. There's a lot to learn from all of them, and we should never forget this session. I hand it over to Dr. Gautam Zaveri to wind up the session.
I think this was a fabulous session, starting with Dr. Boriani, who gave us insight into his development as a spinal oncosurgeon, his development of the WBB classification, and subsequently his En-bloc surgery, how he developed it, and how the tumor worked at the institute developed. I think it was fantastic to hear from him. So much to learn, so much for us to, as youngsters, to imbibe and aspire to. From Dr. Fehlings from Canada all the way, he has come and he has enlightened us about the entire. If you Google spine surgeon or just Michael Fehlings, you will find thousands of articles in which his name is there. He has been doing, I don't know when he sleeps, he has just so many articles, so much of work he has researched, published. And besides all this, of course, he's still doing a very, very busy clinical practice. And then to end it with all, we had our two own legends, people whom we are so proud of. And as you could see in the eyes of Dr. Laheri, he was so proud of the legacy he has created in Indian spine surgery, a legacy which all of us know about and respect. So, sir, we are extremely grateful. India is extremely grateful to you people for the legacy you have created, for the research you have done, and coming from humble beginnings, growing to this kind of stature, striving hard. I think these are the values that the youngsters have learned today. It was a fascinating session. I thank each one of you, Dr. Fehlings, Dr. Boriani, Dr. Laheri, and Dr. Goel. I would also like to thank the interviewers who made great efforts at preparing for these interviews, Dr. Samir Dalvi, Dr. Rohit Amritanand, and Dr. Venkatesh Krishnan. I finally thank the moderators of the session, Dr. Sajesh Menon and Dr. Raghu Prasad Verma. And the MCs for this evening, Dr. Ankur, Dr. Neeraj, Dr. Charanjit, all of whom have been working very, very hard to make sure that the program goes without any hitch. It is 11:30 in the night and we still have so many people watching us on this thing. And that is a credit to the type of program that we've had. I wish all of you good night and see you bright and early at 7:30 in the morning again, because we have got a Sunday loaded with fantastic sessions for you. Thank you very much again and good night to all.
Thank you, sir.
Thanks, Gautam. It was a fantastic session and it was like a great pleasure to do this interview as well. And I thank all of you for staying awake so late to hear these giants.
Thank you, sir.